Morning. Welcome to our annual mental health conference. My name is Mikkel Barnacle, and I'm an associate professor of practice at NDSU School of Nursing and project director for our Rural APP program fellowship with Essentia Health. This activity was jointly planned and developed in a collaboration between North Dakota State University and Essentia Health. This event is hosted by the North Dakota State University School of Nursing with support from Essentia Health Foundation and the Health Services Administration Advanced Nursing Education Nurse Practitioner Residency Fellowship Grant. Please take a minute to fill out the required HRSA demographic form in the chat. The full agenda and conference slides for today are also being posted in the chat. At the end of the conference, a link will be provided so that you can retrieve your accredited contact hours. This conference is being recorded and will be sent to all registered participants within 2 weeks. There will be time for a Q&A at the end of each presentation, so you may put your questions in the Q&A box if this is a webinar format. Thank you.
I would like to introduce our first speaker. Heidi Saarinen is a seasoned sleep medicine nurse practitioner with over 13 years of expertise in sleep medicine with a background in family practice and pediatrics. A graduate of North Dakota State University with a Doctor of Nursing practice degree, Heidi brings experience in addressing the intricate connections between mental health and sleep disorders. Her passion lies in exploring the interplay of neuroscience, neuroplasticity, and resilience, focusing on how shifts in thought patterns can drive meaningful health outcomes. Drawing from her experience working with complex patient cases, Heidi is dedicated to sharing practical strategies and evidence-based insights. Today, she will delve into enhancing sleep quality for individuals navigating substance use and mental health challenges, offering valuable tools to transform care and improve patient outcomes. Welcome, Heidi.
Good morning, everyone. Thank you so much for having me, and I'm just really excited to get to share with you today. Sleep can be a very difficult area, and it should be a very natural thing, but it can be kind of hard. So we are mostly going to be focusing on substance use, but there's a lot of mental health aspects that play into this as well. And so sleep education is a really good investment of our time in return from our patients when we can put some time into that to learn more, because it really does impact every aspect of a person's general overall and mental health and function. So really there's a lot of gold to be mined here. So we're just going to go ahead and get to work. So I do have to put out a shameless plug as well, because I spoke this fall at a conference, and there is a lot of information about physicians and physician associates regarding sleep and kind of their training as well as their habits and characteristics. And so I just wanted to also survey nurse practitioners, because we really don't have anything regarding that data. So if you're a nurse practitioner student or a nurse practitioner today, if you could just take about 10 minutes for this survey at some point throughout the day, that would be greatly appreciated for the area of sleep medicine in general. So the objectives today, and I'll have that QR code at the end as well. We really want to go through and understand a little bit better about neurotransmitters, about sleep stages, and the importance of sleep for better sleep care. We really want to look at how the connection between sleep and mental health use as well as substance abuse, kind of the bidirectional relationship that there is. And then looking at common sleep disorders in this population. And I really want to bring some good tools to whatever area of practice that you work in, because we spend a lot of time. We don't have a lot of time with our patients, and we know that it's important, but we need some kind of practical and reasonable tools in order to fit this in for patients. And then we also want to look at evidence-based strategies to improve sleep in this population, again, that are going to be able to fit into that busy day, work it into those multiple needs, and then prioritize sleep health in a way that's reasonable. I do have to just mention too that I am sick today, and so I apologize. I do have some cough drops if I get into a coughing fit or something like that or need to take a drink. So thank you. Okay, so when we think about, we spend about 30% of our lives in sleep, and there has been decades of research about sleep, but we still don't know a lot about its true function. And this is where that research into sleep is really important. And so we want to know that a lack of sleep, we understand that that can have serious implications on general health, particularly cardiovascular as well as immune, and increased risk for depressive disorders, impaired breathing. But medical providers receive little formal training by trained specialists in the area of sleep medicine. Physicians have been found in the literature to get about 2.5 hours total of sleep education, and psychiatrists about an hour. So nurse practitioners, we just don't know either. And so one more reason that I'm doing that survey today. Okay, so stages of sleep, just kind of glossing over this quickly. There are 3 stages of non-REM sleep. And then we have, of course, our REM sleep, and that's kind of how our sleep is categorized in those 2 different sections. Now, that first stage is actually transitioning into sleep, usually about 5 to 10%. That second stage is kind of in that shallow sleep. So normally when I'm talking about sleep study interpretations or kind of how people sleep, I usually say it's like diving into water. So we kind of go up and down. We sometimes have to come back up to the surface. We get some air. And so it is normal. I try to tell patients it is normal to wake up 4 to 6 times a night, as long as we're falling back to sleep within about 15, 20 minutes. And that's just kind of a normal process, in and out, right? So really, when people are, depending on what stage that you wake out of, that can also cause things like sleep inertia, where you feel like you're not fully awake, like you're really groggy. And so a lot of times, if we can get people into a better stage, when they're going to be waking up, they are going to feel a little bit more refreshed. And then stage 3 is really where that happens, where you feel the most refreshed and rested. You have that growth hormone release, and that's technically your deepest stage. And then really where we're going to focus today is in the REM. So REM sleep, we don't know the full capability of why we have it. There's a lot that takes place. There's as much energy usage and brainwave activity as during wake. But this is where we have a lot of the dreaming, more so that we can actually remember, and that memory consolidation and emotional processing. So if we're not getting that, then it's harder to regulate those emotions. And this is also where a lot of our SSRIs are actually going to shorten this phase, because when we do deal with things like anxiety or depression, it actually, our body is elongating that and kind of processing through that. And so those medications work also to kind of help decrease that, therefore bringing it back to a little bit more normal state. So it's also important with withdrawal as well. The importance of sleep, you guys know that it's important. It helps repair tissues and muscle recovery. So if you like work out, you need that recovery time as well. We also know that it's for energy restoration, that we need both for physical and mental, as well as immune function that we mentioned earlier too. But there's a lot of different neurotransmitter regulation that happens during sleep, to kind of reset the body, and also things that slow down, like saliva production, so that we're not coughing and choking, heartburn sensations. A lot of different chemicals are changing during this phase. So when we think about what sleep deprivation causes, with our mood, obviously, if we do have sleep deprivation, it's going to cause increased irritability, different mood disorders, and really it's our attention and ability to concentrate. We also have slower reaction times. We don't have as good of memory. Our brain removes waste products, building up different plaques during sleep. And so a lot of this can also impact how the neurotransmitters are produced within our gut as well. And so also thinking about the different body systems. These are kind of like the main three, but it really can affect everything. Cardiovascular, if you have sleep deprivation, you're going to be at increased risk for cardiovascular concerns independently of having any kind of specific sleep disorder. So if you are just constantly depriving yourself versus having like a short schedule or what we call like an insufficient sleep hours, despite the amount of time that you could set aside for sleep, that will also increase that cardiovascular risk. And so it can decrease, even life expectancy. Endocrine, this is really where you're going to have a lot of an increase in ghrelin, where it's going to make you more hungry and suppressing a lot of that leptin, so where that satiety would be. And so you're at increased risk for insulin resistance, prediabetes, diabetes, as well. With neurocognitive, we just know that you are kind of what we had said, your judgment, impulsive decisions, increased pain, how people are able to tolerate pain. There have been a lot of great studies for that as well. So it's going to regulate cortisol levels. A lot of these circadian rhythm functions, 90% of our serotonin is produced in that gut. So really, we're going to see a lot more increased impulsivity. And we find that even in adolescents and pediatrics, when they have more circadian rhythm variability, that they are at much higher risk for developing substance abuse or misuse later in life, independently of other factors. So there is some neuroscience for sleep as well. We know that restorative sleep with REM and non-REM, that is going to be huge in our memory consolidation and behavioral regulation, as well as that physical repair, but it's also how we perceive our sleep. So the expectations that we have surrounding our sleep and sleep's impact on our mental health then in turn affects our mood and our cognition, that regulation, as well as different mental health challenges that arise. And so this process is vital for our mental health, and it significantly can influence it. However, there is a bidirectional relationship where poor sleep worsens mental health concerns, but then we also know that if you have a mental health disorder, it can lead to fragmented or disrupted sleep, which also worsens the sleep and kind of get that cycle. Substance abuse, that will also disrupt our sleep patterns, particularly with alcohol, that will particularly disrupt or suppress the REM sleep. And then with stimulants such as cocaine or even prescription medication can disrupt our circadian rhythm. So insomnia can increase the risk of substance abuse, kind of like what we said. And so a lot of times we don't know specifically which started first. Were they at higher risk for the substance abuse and that led to insomnia? Or did the insomnia really kind of trigger that substance misuse and lead to this cycle of addiction and then furthering worsening of that architecture and pattern? So there have been different studies, and again, this is just huge to look at, that there have been many saying that it can lead to or make you at higher risk for that impulsive different disorders, particularly with alcohol, marijuana, and cocaine were the ones that they were really kind of focusing in on. So we really need to have an increased awareness and instill a lot of these practices that we're going to talk about today early. And I just think about all of our pediatric population, how we need to not just rely on medications, but really get into those good patterns. So there was also an interesting study done that if you have more sleep variability and circadian rhythm regulation, that even if you did have a substance use disorder, that if you're more stable in that pattern, you actually have a higher success rate for not relapsing again or being able to stay without that substance, and then also that resiliency. So it really makes a big impact on that education piece. Briefly about neurotransmitters, just to kind of jog our memory with serotonin, that helps to promote relaxation and better regulate those sleep-wake cycles. And so this is where we can see that when these neurotransmitters are off, how that can play a role with our sleep. With dopamine, that is more associated with that reward center. And so it does help to motivate and it does produce more of that wakefulness. So low levels can contribute to sleep disturbances. And when I talk about sleep disturbances, it could be anything from initiation of sleep to fragmented or interrupted sleep throughout the night or those early morning awakenings, which can be quite common for people with anxiety or depression or with alcohol use. Norepinephrine, this is the stronger one for influencing alertness, arousal, and attention. And so if it is too high or ramped up later in the day, then it can also impact that ability to get to sleep. Okay, there are more here too. And so other names that might be familiar to you would be things like orexin, which is more of acting on that wake. And then also histamine is kind of an interesting one, and there have been some new developments in some medications for that, particularly Wakix. And as of right now, it's not FDA approved for various disorders. It's pretty much just for narcolepsy right now, but I'm really hopeful after hearing more about it that this would be something that could potentially treat things like chronic fatigue syndrome, ADHD. And so just kind of put that on the radar that might be, it's called pitolisant or Wakix. And then you can see that this is kind of like a teeter-totter roll. Okay, so really what we're trying to do is that during or at night when we're trying to get to sleep, we are really trying to tip the scales to turn off those wakeful neurotransmitters and activate the sleep. And so a lot of the medications that we use, many of them will actually act on that GABA. And so that GABA really helps to induce more of the sleep hormones. You can see that melatonin is also noted there. Adenosine, so this is like what caffeine will work on in the morning. When we wake up and you don't have that first cup of coffee, then that coffee actually washes out that adenosine to help us wake up more. So really it's looking at that balance of what we have going on and how these medications can help us tip the scales. Circadian rhythm, how does this play in? We know that in the evening, melatonin, for example, will rise, and it normally peaks between the hours of 9 and 10 p.m. for most people. Now, people who have delayed sleep phase, theirs is peaking a little bit later, and that's why we see that delay. Or if they have an advanced sleep phase, then that might be peaking much earlier, which is why they're getting sleepier early. That with this too, melatonin is reduced in alcohol withdrawal and even continued abstinence. So after somebody has used a lot, and so then we see that potentially supplementing with that can be beneficial. This is highly regulated by light. And so that is a very good behavioral thing that we can try and induce. And so that influences that hormone production and body functions. At night, those GABA levels rise, and that further helps us to get into more of that stabilized or those deeper stages of sleep. And this is really where you see like the medications such as the benzodiazepines or those non-benzodiazepines or the Z hypnotics such as the zolpidem or the Ambien are inducing on that neurotransmitter. In the morning, our cortisol levels increase, signaling wakefulness, at least they should be. And being exposed to both morning light and evening light has been shown to kind of help regulate this rhythm for us. And so when you live in places where you don't get always, maybe you're going to work when it's dark, people with like shift work, then you're not getting those cues to your brain through the eyes, and then it can cause dysregulation. So during the day, those serotonin and norepinephrine levels rise, supporting that alertness and energy. So GABA is kind of one of those primary inhibitory neurotransmitters, helps to kind of facilitate that transition into sleep and get into more of those stable areas. So again, today I really wanted to give you some tools that maybe you could implement into your own practice. And we're going to spend a lot more time on insomnia just because that's one of the highest areas where substance use affects. However, fragmented sleep and can also be from other comorbid sleep disorders, and so we should consider those as well. So here's just a couple tools that you might be able to use, and they're pretty easy to implement. So the importance of sleep assessments, sometimes if you don't know where to start, these can also be very beneficial for you. About 50 to 70 million adults in the United States do have a chronic sleep or wakefulness disorder. And so that's a lot of people. They might be bringing up concerns, but maybe you just are not having adequate time to address them. And so even bringing them back specifically for sleep would be very beneficial. They're very prevalent, can very much impact a variety of different areas that you might be trying to regulate as well, especially when it comes to mental health and substance use. And then untreated, it can lead to a variety of other health disorders. And then I just have to say that about 48% of people in the United States, as far as adults, in this behavioral risk factor surveillance system survey nationally, were found to snore. So that's almost half of the adult population. So it really should be something that is high on our radar. 37.9% report unintentionally falling asleep during the day within the last month, which I think is pretty significant. And about 5% of people admit to nodding off or falling asleep while driving in the last month, which is no joke. I didn't realize it was so prevalent until I started specializing in sleep, but so it's a very important question to ask. So how do we kind of go about looking at sleep? I think one of the biggest things is that I look at how much sleep are they getting total? What's the quality? What do they feel like the quality is? So asking like when they go to bed, when they're actually falling asleep, when they get up for the day, versus if they're just laying there for hours and they're awake. I also ask about their sleep environment, who they sleep with, if their house is noisy, if they're living with roommates, if they are living near a train track or the airport. Do they have interferences from other, being on call with their job potentially? Does their partner snore? Or do they have pets that might jump on them and wake them up at night? Are they sleeping with them or are they co-sleeping with children? All of those things can be very beneficial. And then really assessing their past medical history. So I find that if they snore, they have high blood pressure, or any cardiovascular risks, I have a pretty low threshold for checking for obstructive sleep apnea and looking at what medications, because a lot of medications can actually induce some fatigue or sleepiness during the day as well. So these, you can do like a sleep diary. I find that if you go to like the National Sleep Foundation or the American Academy of Sleep Medicine, they have them for you, so you can print them off, which is really beneficial so that you don't have to try and explain, how to do something like that. It's done for you. All right, so when we look at caffeine and alcohol, generally we try to say no caffeine within 8 hours of bedtime is the recommendation. For some people, that might be even longer than that. Other people, it might be shorter. It depends on how fast they're metabolizing it. With alcohol, we might differ a little bit in this area where we don't recommend any alcohol within 3 hours of bedtime. Some people might recommend, it's okay to have that glass of wine, but really it has to be like these organic grapes, and that type of wine isn't as, I guess, delicious or taste as well. And then also it really does affect as your liver is processing it through the night, that REM stage. So it's going to cut that REM stage down. You're not going to be able to process and regulate as well. And then the consolidation of those memories. Smoking is huge. Obviously, we want to get people to quit smoking altogether, but I try to, if I've got somebody who's smoking, even every time they wake up in the night, I try to have them cut back by at least 15 minutes. We can do this in chunks. I try to think of it as just like when I'm talking about lifestyle with diet and exercise, you do what you can and you work up towards that goal. And so with quitting smoking, I try to say, the biggest bang for your buck for your sleep is that if we can cut back on the ones closest to your bedtime first. would be highly beneficial. And then medication use, like we talked about, antidepressants sometimes can be stimulating. So things like Prozac, if we don't want to dose that like at night. And then some other medications like Paxil might be a little bit more sedating, might make you feel a little bit more sleepy. And so that one, maybe you want to make sure that you're not doing right away in the morning, or, just trying to figure out the time that would be more beneficial. Beta blockers might be another one that would be a good one to be aware of. They're usually used to treat high blood pressure. However, it can cause a decrease in your natural melatonin production. And so that can also make it harder for people to fall asleep, might start inducing some insomnia at night. Decongestants, we know that they are stimulating. They can raise your blood pressure and heart rate, so that can also affect people when they're going to sleep at night. And then we know that diuretics also would be harder because people are getting up to use the restroom. Smoking cessation medications, they can cause nightmares, weird dreams, and then also like bupropion or Wellbutrin can be more stimulating, so that might make it harder for them to fall asleep. So just to be cognizant. And then steroids, of course, are mimicking cortisol in the body, and so that can be more stimulating as well. If they're just doing a short dose or burst, it might just be very transient. But if they're prone to things like insomnia, it could set them off. So again, just things to consider. And can you offset it with the timing of the day? Can they maybe take a melatonin supplement in addition to try and help offset some of the effects if you need to use some of these medications? All right, so the Epworth Sleepiness Scale is one tool that you could put into your practice. I use this with every sleep patient that I see. I feel like this is the most useful one in my practice. I kind of use it as a baseline for almost like a gauge. Okay, so kind of like in the psych world, if we're evaluating for anxiety and depression with the PHQ-9 and the GAD-7, this one is a self-report questionnaire that is basically that for me for sleep. So it helps to quantify how sleepy the person feels during the day. And it is going to say like how likely are they to fall asleep in certain situations that might be common during the day. The scoring and interpretation, it's from 0 to 24. There are 8 questions, and you can, anything greater than 10 would be concerning for excessive daytime sleepiness. So even though it is not specific to any particular sleep disorder, this can lead to a diagnosis of obstructive sleep apnea or narcolepsy or other daytime sleepiness disorder, as well as, again, be a nice gauge. The nice thing about these tools too is that technically, if you wanted to, you could charge for like a screening tool in your clinic. So it's a CPT code, and I believe it is a 96127 screening tool CPT code. I don't currently do that, but it is something that if you wanted to implement, you could. This is the Pittsburgh Sleep Quality Index. It is technically known as the PSQI. This is widely used, more so I would say in research of sleep. I think that if you're kind of looking at where do I start and asking people questions too, it really helps as a nice guide with that to kind of see like how long does it take them to fall asleep? Do they wake during the night? And just kind of to walk you through that. But otherwise, I don't find it particularly useful in my practice because I'm evaluating all of that for other sleep disorders as well. But there's about 19 questions. Again, they're all self-report, and then the link is there as well. The Insomnia Severity Index, this one might be another one that'd be really good for your practice, especially with your insomnia patients. I always screen for anxiety and depression for all of my insomnia patients. But then this could be another self-administered questionnaire that you could use to really see, are they having more of an issue getting to sleep or staying asleep, or those early morning awakenings. So the higher the score, obviously, then the more severe the insomnia symptoms would be. And again, it helps give a better benchmark so that if you're implementing things, you can see where you've come from. They're a Likert style of question, And so it just kind of helps you to see if you're moving the benchmark forward or if what you're doing is working or not. And then lastly, the stop bang. This is going to be screening for obstructive sleep apnea. So if you've got somebody who is at higher risk, and males are typically at higher risk until age 50, then it's an even playing field for males and females. But for the general population, if you've got anybody who snores, this would be a great one to implement into your clinic. And as you can see, that the higher the risk, then there it kind of just says like what to do. The way that we evaluate this too is going to be with a polysomnogram, and I do have that in 2 slides coming up. So the most common sleep disorders associated with substance use are insomnia, sleep apnea, nightmares, or circadian rhythm disorders. And today, like I said, we're going to focus mostly on that insomnia for a lot of our treatment and management as well. So just making sure, a lot of people who struggle with insomnia do have obstructive sleep apnea. And if you've got somebody with substance use and you don't know where to start, ruling out insomnia sleep apnea is huge, because it's going to be non-medication. They're going to be able to use it, and they can often benefit greatly from it, not just in their energy during the day, but they're going to fall asleep faster and they're going to stay asleep better. Because if you have significant apnea going on, it is going to keep waking you up. Your brain's eventually going to be trained to be afraid to fall asleep. So you can do that in the lab, you can do the home testing. There's just some contraindications for home testing in all pediatrics. If the BMI is greater than 40, or if you suspect any other type of sleep disorder, because it's not going to evaluate for all of them. It's just pure and simple, regular, tried and true obstructive sleep apnea. So a lot of the medications that we give for substance use, or for insomnia, I guess I should say, can worsen obstructive sleep apnea. So that's another plug or reason to screen for this. Okay, so diagnostic criteria for insomnia. So if somebody has difficulty initiating, maintaining sleep, or waking earlier than desired, the second would be if their sleep difficulties are in spite of their adequate opportunities. So it can't be that they're working 3 different jobs and they just they don't have the time for sleep. So that wouldn't be considered insomnia. They actually have to say, like, I go to bed at 10, but I lay there for several hours and I can't fall asleep, would be an example. So this is all with the International Classification of Sleep Disorders, the 3rd edition as well. And then it also has to produce daytime symptoms. So things like fatigue, or if they're just not feeling like they have the attention or concentration or the motivation or the energy, or they're worrying excessively about sleep. Okay, so now what do we do? So I know that people can feel like sleep hygiene is just thrown out there all the time. Maybe your patients are tired of hearing about sleep hygiene, but it really is a mainstay. And so presenting it in such a way that is useful for patients and how we can use this more effectively in practice is essential. So I hear a lot of patients say, yeah, I know I need to go to bed at the same time, wake up at the same time every day. And that's kind of what they think is the crux of this. So this is a really good basics for us, but we really have to build on it. So we do want to have that regular sleep schedule. If they get up at the same time every day, it's actually more effective than if they even go to bed at the same time every day. So eventually, if they have to get up at 5 every day and they're not going to bed until 1, that sleep pressure is going to build. It may feel kind of crappy for them at first, but you're actually wanting that so that they can eventually get into that better routine. So again, everything with sleep hygiene is we're building on that education, we're building on those good habits. And so just like it didn't happen overnight, it's not going to get fixed overnight. And I think that that is a very important expectation to relate to patients, because if they have been struggling for years and they want to go to bed at 9 and wake up at 5 and sleep like what they say a baby, it's just may not be realistic. And especially for our age, we're going to have more awakenings as we age. But it shouldn't be such that they can't get the sleep. Okay. So having that routine is important even on days off. If you're not one that's, easily bothered by that, then you don't have to be as stringent, okay? Create that relaxing bedtime routine, and we've got some slides to talk about that. Optimizing that environment, you really want to make sure it's comfortable, that it is cool. Research shows that between usually about 65 to 69 degrees is kind of that optimal, with 67 typically being one of the best room temperatures for people. And then you shouldn't have lots going on. If you have to sleep during the day, you can use blackout curtains. I used to use black garbage bags on the window when I worked shift work so that I couldn't see anything. And so again, we just want to create that relaxing transition, because if you're going, you're working, we're having all this stimulation, and then you've been distracting your brain all day. When you get into bed, suddenly it's going to start working and it's going to say, okay, now I need to take time for me to go through and make sense of the day. And it starts thinking. So if we don't give it that downtime or that white space before we go to bed, then we're not going to create that environment to sleep healthy. So I find that is a huge problem in today's society, is just the scrolling on Instagram or Facebook and that cheap dopamine that we get from that it's distracting and not allowing us to deal with things that our brain needs to process. So a lot of education surrounding that is important. So again, we already talked about the limiting the substances. Okay, so stimulating factors, we want to avoid these prior to bedtime. So things like reading in bed, watching TV in bed, listening to podcasts in bed. For students, studying in bed, doing homework, you really need to do those wakeful activities outside of the space. So there's a suprachiasmatic nucleus that lives right behind the eyes, and it keeps track of our body position, of the light, the time, and the comfort. And so if you're doing these things in bed, you're essentially training yourself to do wakeful things in bed and not to fall asleep. And so we really need to have that out a lot with our stimulus control technique. So don't clean or exercise if it arouses you. For some people, even having sexual intercourse can be arousing before bed, and then they have a more difficult time. So it's really just trying to avoiding bright lights. Now, there's a lot in there, literature about blue lights and looking at screens. If you do have like a dim light on, that is going to help, because it's not just the darkness and then this bright light coming at you into the retina. So kind of putting different filters on your phone can be helpful. And again, doing those things outside of the bed, but generally not recommending any screen time within an hour of bedtime. Again, we don't want that distraction. We want our brain to be able to make sense of the day. But if it's not bothering them, I mean, obviously it's not going to be an issue. Expectations, we want to allow sleep to come. You can get very like performance anxiety about sleep, and people will say, well, I'm doing all these things, I'm being so extremely regimented, and we just really need to make sure that we put forth good expectations, and again, use this as a time over time, and that we don't want to be so obsessed that it makes it worse. There's a lot of technology out there where we can also measure these performance measures, where they are analyzing data about our sleep, if they got into deep sleep or not. They're getting better, but they're not perfect. And so it is not perfect data that we're going off of. And so they shouldn't see it as that either. And maybe they just need to take a break from it. And that often can be helpful too. Now, if they take any type of melatonin or anything, and then they're using bright light, it's basically like taking a Skittle. So you are not doing any favors. You're just decreasing that melatonin that you just put into your body anyway. So that would be a big one. And that is one of the best behavior changes is using light to help regulate sleep. So I would definitely stress the use of light and the exposure of light close to bedtime or early in the morning. So again, when we're looking at how to create that environment, these are kind of like down regulating behaviors that we can do. Things like taking a warm bath, We do encourage reading a book because that does help to kind of engage. You're also getting this side to side movement of your eyes, which we'll talk about here. And that is extremely beneficial. Things like yoga or any kind of like stretching prior to bed, relaxing music. There's actually a song that has been studied and was developed with music therapy and neuroscience called Weightless. And you can find it on YouTube. The studies aren't, super huge, but it's actually pretty okay data. 65% reduction in stress, anxiety, and has been shown to be beneficial for improving insomnia. So again, you can find it for like a 10-hour recording on YouTube of Weightless is what it's called. So it just uses the rhythm, kind of like the heartbeat to help slow it down and really help regulate that thought process to kind of help down regulate people. Dark, quiet, and cool bedroom we talked about, and then reducing stress. A lot of times I'll find that people have their mind just going, and so if they can make a journal or a list. I'm not a journaler, so I'd much prefer to have make a list of what's on my mind. You don't even have to do anything about the list, and that's kind of the beauty of it. Just have it there, create that list. If you get into bed and start thinking, have it right there, get up, put it on, add it to the list, and then you kind of say, oh, I get to be done thinking about that. I've written it down. My brain doesn't have to keep reminding me about it. And I find that that's a huge one. The other one that I would say has been very beneficial, and I did give you guys like a sleep hygiene handout that I use. So go ahead and feel like you can use that, adapt that, is not watching the clock during the night. So this is a really big one for patients. If they wake up at 2 in the morning and they say, oh, if I can just fall asleep right now, I can get 4 more hours of sleep. And then an hour goes by. Well, if I can sleep right now, I'll get 3 more hours. And then it just goes on. So don't watch the clock. Set your alarm. And they have great alarms. There's even something called like a sonic bomb, where if they need to wake up, they can. CBTI. So this is a big one that I wanted to talk about because this is the mainstay of insomnia. We can use it in all of our mental health patients. We can use it in our substance abuse patients, and it's overlooked. And part of it is because just the access to it. Okay, it's a multi-component approach. So with that, the people who are trained in this really identifies and challenges the negative thoughts surrounding sleep, whether they've got increased anxiety, and they really help provide strategies for better utilizing the sleep hygiene that we've already provided and the time that they can have for patients. It reinforces a lot of things like deep breathing, muscle relaxation, but one of the things that I think is really beneficial is the sleep restriction. So they actually can walk patients through how to go through a program. And usually by week 2 to 3, people are seeing significant benefit. So if you can push through to that second week, and it's usually like the second visit, people do really well. So it's just like psychotherapy. There's probably about a 40% dropout rate if we don't set people up well. But just like psychotherapy, we know that we can't just supplement. We need to train people's way of thinking. Same thing here. They need to stick it out. In person, it has been found to be just as effective as telehealth. And so there are a lot more telehealth options, but we are really, this is such a great tool for people. So they do go through relaxation techniques, which we know about breathing. Okay, you can find all kinds of YouTube videos. There's like 30 different ways to deep breathe. My kindergartner knew about like roller coaster breathing, where you just kind of, take that pause at the top and then come back down and then kind of back again. You can do a progressive muscle relaxation with tensing and relaxing muscle groups in bed to kind of, or before bed. And then guided imagery or meditation, which we all know these are very important things. And, use YouTube, use these CBTI instructors to help with that. So really that cognitive restructuring is so big, but the sleep restriction is the other big piece of it that's actually a tool, as well as the stimulus control where they're not doing wakeful things in bed, and then relaxation techniques. So UPenn has a website for a provider directory, And so they've got a list of everyone in the United States. There's over 1,000 people who are trained in this that can provide telehealth. And I apologize, my light goes out at times in my office. And so this is just really a great directory for you to go ahead and look and see what's close to my region. Okay, who provides telehealth services? There is somebody out in the cities, Dr. Rick Blackburn, and I only just talked to him this week, so I didn't get him on the screen here because I wanted to make sure I could mention his name if he would be okay with that. And he does telehealth from the cities. You just have to be in Minnesota. So if the patient can even drive to like a parking lot in Minnesota, they could be seen through telehealth by him. So again, his name is Dr. Rick Blackburn. Digital CBTI, there is Sleepio, Somrist. Both have been approved by the FDA for CBTI apps. And then there's something called a CBTI coach. And these are all digital. They're not quite as good as an in-person because you don't have that accountability and to kind of talk through some of the fears that patients might be having. But it is a really, really good tool. I actually just used it this last week as well. So it does walk you through a lot of the same principles. And so as long as you can kind of be that accountability partner for them, can be effective. The American Academy of Sleep Medicine does have a list of cognitive behavioral therapy platforms, and that is provided for you. Locally here in the Fargo-Moorhead area, I know you guys aren't all from here, but there is Dr. Kama. She is from Conscious Living Counseling and Education. She does provide CBTI, but she doesn't do as much of like the sleep restriction therapy or like the light therapy after talking with her. So I just want to give a shout out to her that she also, and she provides services to pediatric patients. So it could be through telehealth or in person as well. EMDR, we know that this is important for our PTSD patients. But it is that side-to-side movement. So this Francine Shapiro in the 90s, she was doing a research project and realized that people who use that side-to-side movement saw that it took the emotional tone out of the memories. And so that's really what we're doing. And so whether it's the stress from the day, whether it's the substance use, whether it's the mental health load, all of that impacts. So interestingly, that mimics the REM eye movement during sleep. And so it's really quite fascinating how these simple eye exercises can promote relaxation before bed. So if you just tell your patient to kind of scan the horizon back and forth as they're just kind of like getting ready for bed, and before they get into bed, that can really help, again, down-regulate those emotions and help create that space to get to sleep. So huge practice. Another one that I had heard was where they just actually travel with their eyes up the wall. So if they're in bed and they get stimulated, they can even try that, and that can be helpful as well. Again, these can also be implemented by CBTI, and anyone can be trained in CBTI. The biggest problem is that we don't have reimbursement, right? So your nurse could be trained and you could technically charge $35 for a visit, and that might be beneficial over time, like if it was just an out-of-pocket expense for patients. So that might be a way, but it's all behavioral health codes is how they get reimbursed for it. And that's why these counselors are kind of a better fit for that because it's in their wheelhouse with the CPT codes. Other sleep technology resources, I don't have time to talk about these today, but it is fascinating. There is an index list from the American Academy of Sleep Medicine. They also provide resources for the evidence behind each one. So if your patient is using something and you're not familiar with it, you can go look it up, or you can just look up and say, gosh, I want to try this. There's a really cool neurostimulator where it's like a headset that you actually put on the patient's head 30 minutes before bed. You take it off then for sleep, but it's called like a Muse. American Academy of Sleep Medicine has one too. And that is just where it sends like pulsations and vibrations to stimulate the different vibratory sense to help relax people before bed. So these again are non-pharmacological. Some of them might be more expensive right now, but I just think that the technology is getting where it's getting cheaper and it's getting better. There's a lot of wearables like the Oura Ring. Nearables, where it's like next to the bed, where you could even have like a waking up light where it's like a sunrise lamp where it helps to get brighter closer to the time where they need to wake up. You've got it different acoustics where it's like that song therapy where I was talking about the waitlist, or in bed technologies where you actually have like there's a pillow called a dream pad, and where if they lay on it, it sends vibratory sense almost like with bone connection, where they can hear this music calming and vibratory playing, but like it wouldn't affect a sleep partner. So really, really interesting technology. And there's even something like a dream app where it can start to using credible sources, even interpret some of their dreams. So again, really fascinating. Light therapy, I just want to touch on quickly. There's different types. You can get tables, tablets, floors, desks. You want to use it for about 15 to 20 minutes. And this is a really good tool for us in our practice because there's minimal risk. You don't look directly at the light, obviously. And you just sit in front of it. They can eat breakfast with it if they want to get ready next to it. But usually about 15 to 20 minutes first thing in the morning helps to set their circadian rhythm back about 15 minutes per night. So again, we are shifting this slowly, and you can even couple it with melatonin the night before. And this would be safe to use for mental health, or if they have concomitant like seasonal affective disorder, usually about 2,500 to 10,000 lux. If you look at even on Amazon, they'll have what the lux are. I've usually mostly seen 10,000, and you want to sit about 16 to 24 inches away. So it doesn't have the UV light exposure, so it's not going to affect their skin. They might have like some headaches if they or eye strain potentially or hyperactivity, but you can regulate that. So those would be the side effects to kind of watch for, but otherwise it is very safe. You can use it for all different kinds of ages. And then if you use the melatonin at night to kind of help regulate them, and then the light therapy right away in the morning, this would be a really good indication for moving that internal clock to improve their sleep. So I wish I could say a whole lot more about all of these, but this is a really great introduction and can be very cost effective, especially in the long run. And it helps to establish a lot of those good sleep behaviors without the side effects of medication, which leads us into the pharmacology aspect. So I really like to say that medication comes in when our other treatments fail or when the benefits outweigh the risks, because there are always risks when it comes to pharmacotherapy. It should not be the sole treatment of insomnia. And I really do want people to establish good patterns where they're empowered to sleep better and not reliant on a medication, especially in our substance use population or our mental health concerns, because they're already on medications, and then we get into interactions. And then we also have an increased risk for falls. So we're trying to mitigate all of the balance of all of this. So when we think about our options, we've got different things like melatonin, which it technically is a hormone, and it's regulating that sleep-wake cycle. We've got prescription medications, and then we have different things like supplements that we'll talk about here. As far as melatonin, I kind of wanted to give an overview of each and then kind of recap with kind of maybe like a list of what to use for which substance. So melatonin is actually regulated. You need a prescription for it in Europe. So the United States is different. It's over the counter here. And so it helps to regulate that circadian rhythm, but over time, we don't know how that could affect people like kids, especially. And so I usually say not to use this in children. And if you do use very small doses, you can even use like a 0.5 formulation. As well, you want to dose it mostly about 30 to 60 minutes before bedtime. Go low and go slow. It's going to be more effective. So if you use high doses, it's going to cause a rebound insomnia. And then your patient's going to say that it's not working, and it may be just fine, but it's just more so that that's that caveat that can cause that rebound insomnia, or you're going to have a higher risk for potential dreams or headache is more commonly what I've seen. There are many trials using the 2 milligram dose, but you can go up from 1 to 10. In the general population, I don't usually like to use higher than 6 milligrams. The American Academy of Sleep Medicine doesn't recommend it, but it's mostly because it's not FDA regulated. So you have to find one that's USDA approved. And it does come with some side effects that it can cause an increased risk of bleeding, especially if you have somebody who's on warfarin. So it's not completely benign, but it is otherwise a fairly safe. The only indication that I would say is a better one for children would be if they have ADHD, because again, their natural production of melatonin isn't going to increase as it would normally.
And Heidi, hi, I just want to note that we have about 5 more minutes till the Q&A, and so please put any questions in chat.
Perfect. Thank you. Okay, mirtazapine, this one is not a scheduled medication either. This is more of in that antidepressant category. The dose is normally 15 to 45 milligrams at bedtime. However, for sleep, the lower doses do work better. So even 7.5 to 15 milligrams is kind of the target range for that sedating effect. And it's usually going to be better for increasing the amount of time in that slow wave sleep and possibly some mild REM suppression. So just watch for that, and then watch for weight gain. So that is one of the bigger ones that you're going to see. 50% of patients will gain weight, so that can be very difficult. But if you're using it in substance use, this is going to be a little bit safer. And so just making sure that it's not in anybody who you're worried about weight. It's not going to impact their sexual dysfunction directly, but it might impact their body image. So just if they are gaining weight. Compared to placebo, it does have a reduction in their insomnia scores, and so that has been found to be effective. There's a box warning about suicidal ideation risk in younger people and even younger adults. It didn't specify a specific age, but just if you have a younger adult to watch for that. Doxepin, this is Silnor. It's also not scheduled. It comes in both tablet and capsule formulations, so you can split the dose. 3 to 6 milligrams is currently FDA approved, but higher doses are then putting you on that Beers criteria. But I do find that they probably are a little bit more effective. And so, again, it's just that fall risk that we're worried about with the American Academy of Sleep Medicine does say that it's better for sleep maintenance. So if you've got that person who has early morning awakenings, or they get anxious in the morning, can't fall back to sleep, this is kind of a better one to try for that. Or I find it that I'll use it more in my female population with those early morning awakenings. So you don't want to use it with potential pregnancy. So that would be a concern. And then avoid taking it with food because it will prolong the effect. Trazodone is actually not FDA approved for sleep, but it is probably the most studied as far as in substance use. And it is probably the most widely used. So you want to take it on an empty stomach, not with food. Usually, again, the lower doses are going to be more efficient for that sedating effect for sleep. I would even say that you could start it at 25 milligrams if you've got somebody on substance use, just to make sure that there's no interactions, especially if they're already on like an antidepressant to control mood. And you want to watch for serotonin syndrome or like a prolonged QT, particularly. With this, you can get a hangover effect. If they do get that, just cut back the dose before bed and make sure that you're using all of these other good tools to support their sleep, and you don't want to stop that quickly. Rosarum, this is basically like a melatonin on steroids. The 8 milligram dose can be very effective for substance use disorders. It can improve mostly their time to get to sleep, so that sleep latency. And the American Academy doesn't really have a lot of guidance on this, but the half-life is going to be 5 to 6 hours, whereas melatonin is only about 30 minutes. So you can see that this is a much longer acting kind of form of melatonin. And so it may not maintain sleep as well, but it it should be more helpful in getting them to sleep and establishing that routine. So things like our Ambiens, our Zaleplans, I just wanted to state that they are going to put more activity on that GABA receptor. I kind of want to jump to this next slide because it kind of highlights each one. You really shouldn't be prescribing greater than 5 milligrams in your female population just because it is, what would I say? There is a higher adipose tissue in women, and so it's going to bind to that, and so you're not going to clear your system out as effectively. So you've got more medication in your system, and that's really why they say that. But it can go up to 20. I typically don't do that. The extended release or that might provide about 1 more hour of sleep for them. But just when we think about how to dose this, always start at the lowest dose. They usually come in tablet form, so you can't even break them. So if you're wanting to use this, this one is actually found to be studied in marijuana abuse. It's one of the only ones that is approved for that. And so this would be a good one to choose for that as long as they don't have other contraindications. Zaloplan is one that I really like to use often, and it's one that maybe people aren't as aware of. And that has a shorter half-life as long as they're getting about 4 more hours of sleep. They can take it even in the middle of the night to fall back to sleep. And so it's kind of nice to use that. And then you have less side effects. But just remember with all of these, they can have complex sleep behaviors and maybe even impaired driving the next day. Bilsamra, these are the Doras. These ones really haven't been studied in substance use, so we just need a lot more education about them. They are also Schedule 4, and so usually the higher doses are going to be better, but it does take about 6 weeks for these to be effective. So even if they've tried it a couple weeks, I would say that that's kind of a pearl to watch for. Please use this slide. It just kind of talks about how to switch or taper, and it was just published in 2023. And then I can finish up with kind of the influence of marijuana. I have put in here kind of what is recommended by the evidence to use, kind of in the order that they recommend it. So hopefully that can be helpful to you. But I would say that most of the time people take marijuana for sleep, and people who use it recreationally don't have as big of a problem, but people who use it medically actually have more of an issue because it is a sleep disruptor. So it doesn't help people get to sleep as fast as they think, and they are actually more disrupted at night. But I can see that I'm getting out of time here, so.
No, that was great, Heidi. And I've been posting the links and for all the rest of the last of Heidi's slides that are great resources for everybody. Everyone can view those as well. So thank you, really great information. We will move now to the Q&A portion of the presentation. The first question is, I have patients who are being prescribed a stimulant. These patients usually have ADHD. Can you elaborate why this is or not beneficial? I recently had a patient with ADHD and bipolar who was taking Adderall 20 milligrams and not sleeping until 3 a.m. I encourage her to only take in the morning. Thank you for your thoughts.
Yes, so this is really tricky when you've got ADHD or things like narcolepsy to help people sleep, because a side effect of these stimulant medications are going to be insomnia. I would suggest, that you've done a great job saying that the earlier that they take it, I would really try to have them keep track of their decreased concentration and make sure that they have gone through formal evaluation. I just learned of an online telehealth service that can diagnose ADHD without like the extensive 4-hour neuropsych testing for, I think it's like 20 minutes. And it was just really interesting. So I just think that making sure that they do have that diagnosis, that they've been formally diagnosed, and that maybe that's when you start to look at how can we treat the insomnia that's separate or that's because of this. But if they need to use it, then I would look at how to help them sleep. So CBTI is a huge impact for that. So I would say definitely getting them into a resource there, or having them use that coach. And then trying to see too if they can come off of the stimulant on days where they're not needing it, like non-work days, for example. Um, I it's a tough thing, but also, you might have to resort to some pharmacotherapy in that case to help them get better sleep as well, because then in turn, maybe they don't need quite as much of the medication during the day. So I would really try to have them scope out, their periods of during the day as well as their sleep patterns.
Great. Next question. What are your thoughts on using modafinil off-label for insomnia?
So modafinil off label.
Modafinil, thank you.
Yeah, no, that's fine. So this is a medication to stimulate wakefulness, and I do think that this could be a useful tool. I again would make sure that they don't have like some underlying ADHD or even some other sleep disorder. So if you've ruled all those things out, I think it definitely could be. Obviously, you can use it like a 50 milligram dose. I believe that the next step would be 150 milligrams. It's a pretty good medication. The one thing caveat that I would say with modafinil is that it is decreases the effectiveness of oral contraceptives. So you really need to counsel those patients that are potentially going to get pregnant because you don't want an unintended pregnancy. And so just being aware of that fact too. But otherwise, I do think that that can be beneficial. Again, it's kind of like the light therapy. We're trying to stimulate those wakeful hormones to help them sleep better. And so may not be my first tool, but I think that it could be used if you've exhausted everything.
Great. We have time for a few more. In regard to Ambien, what conversation do you have in regard to length of time these should be used? I know a lot of insomnia meds are not recommended long-term, but I have a lot of patients who become reliant on these meds and struggle to want to trial off.
Whenever I give a medication, I'm always telling them this is going to be about a month. So I use 1 to 2 weeks every day, and then every other day. And then we try just as needed after that. And then I come back and see them and follow up. And I would say that all the guidelines and up-to-date American Academy of Sleep Medicine do recommend coming off of them every 3 months. I technically don't always do that either, just because, like you said, it is kind of difficult. We really need to get into the mindset of, have we done other things first? And I think that if we can establish a lot of these good patterns, or sometimes I will use the medication to help that pattern. And that's why I say that this is for a month. They're going to like it. And so, making sure that we've done some good groundwork first, I think is highly beneficial, or using something like a melatonin, which has a lower abuse potential, because even with substance use, if you use the Ambien, there is a potential that they could get addicted to that itself.
Thank you. Do the benefits of long-term melatonin use on sleep outweigh the risk of long-term OTC hormone replacement? How much melatonin is too much? This speaker has seen people take up to 20 milligrams per night.
Okay. I would personally feel that 20 milligrams is too much. And I think that there really aren't good guidelines. The kind of just looking at all the different facets of the pieces of this question, it's useful. It's not going to knock somebody out, right? And so I think that long-term use can be okay from what I've read in the literature, but really establishing, again, all of these things kind of in conjunction together really is helpful. And that I would hope that people don't have to be on it long term. With that said, if they do, I don't know what else is going on in their life. And if you can get by with melatonin, I'd much rather use melatonin than not. So I do think that if you have to use that 20 milligrams and it's effective, then I'd probably leave them on that versus switching them to like an Ambien or something. But because it's a hormone, like we don't really know, and we don't know the concentrations. And so that gets to be really tricky. Even when they buy it from month to month, it might be different formulation and have other additives in there. So as long as they realize that too, I think that that's what the conversation needs to be had.
Okay, we have time for about one more. What are your thoughts about CBD, CBN for sleep?
So again, I listened to a really great podcast recently too with somebody who does specializes in like marijuana care. And so the American Academy of Sleep Medicine does not endorse it for sleep. Um, Again, if I've got somebody who's using it recreationally, they probably aren't going to have as many of the side effects. I'm probably going to be like, I'm not as worried about it. But over time, we see that if they're using it consistently, that's when we're going to see more of that fragmented or disrupted sleep. And then it can also worsen that, dysfunction over time. And it might be even when they come off of it, this is the tricky part. They feel like they're going to sleep worse for 100% for sure. And for 2 to 4 weeks, and maybe even up to 12. And so they're going to feel like that was helping them sleep. And so just really educating the fact that that's not, but it does cause the withdrawal symptoms to sleep worse. So just making sure that they realize that. And I do think that in some instances, as we learn more, I'm open to the fact that it might be very beneficial, but we just don't have enough studies on it. But in certain, disorders, it might be beneficial, especially if you've exhausted everything else. So I'm not against it, but I can't endorse it at this time with the knowledge that we have.
Great. And then just one last quick one here. I had a patient complain of a terrible taste in their mouth after taking Lunesta. Any suggestions to help with this? And then that's our last question.
Great. Usually I've had some people say that it works really well with ice cream. I don't recommend taking ice cream at bedtime just because of the high sugar, but eating it with food definitely can help with that metallic taste because it really is known for its bitter taste.
Great. Okay, thank you so much, Heidi. Again, all of Heidi's slides are in the chat. Thank you for facilitating our session today. We will take a 3-minute break now as we get prepared for our next speaker. Thank you again, Heidi.
Thank you so much for having me and have a great rest of the day.
Welcome back, everyone. I'm going to introduce our next speaker, Jacqueline Jarvis. Jarvis is a psychiatric and addiction certified nurse practitioner with a doctorate in executive leadership, serving as the CEO and medical director of the Ridge Treatment and Reentry Center. She brings extensive experience working with justice involved in underserved populations, providing compassionate, evidence-based care for individuals facing mental health and substance use challenges. Known for her innovative leadership, Jacqueline is committed to fostering recovery and resilience through patient-centered care and specialized programs that address the unique needs of marginalized communities. Her expertise spans both clinical practice and organizational management, driving positive change for individuals and the broader community. Welcome, Jackie.
Thank you. Hi, everybody, and thank you so much for coming today. I'm always excited to do this conference because I think they put together such a nice array of topics, and I'm always excited to speak about my topic. But this year we are talking about PTSD, which I think is really timely because over the last couple of years, I think both due to awareness and we've seen definitely more and more focus on this diagnosis. And so I'm excited to talk about it. And so today we are going to talk about both just understanding definition and symptoms of PTSD. And also I'd like to talk a little bit about differentiating between trauma and PTSD and how to kind of piece that out. Causes and a lot about the biology, and then of course treatment. And so first of all, what is PTSD? And most of you probably have heard quite a bit about it, but PTSD essentially can be triggered by any traumatic event. I think commonly we hear about it from combat veterans historically or sexual violence. But I think a lot of times we also forget to think about like grief and loss, people who have lost a loved one, especially suddenly through accidents or suicide, medical experiences too, life-threatening illnesses or injuries that can be traumatic for people, and also just natural disasters, things like that. All of those types of things can trigger PTSD symptoms in people. And so key symptoms, which we'll talk about more, are intrusive memories, avoidance. It really is your brain's way of avoiding traumatic reminders, negative changes in thinking and mood, and hyperarousal. And so how prevalent is PTSD? They say it's 7 to 8% of the U.S. population, but really what is really pretty striking and probably more relevant to us is I read up to 20% of people who work in emergency settings and first responders, which probably pertains to a lot of us. And I think a lot of what happens to us is we kind of have this kind of buck it up and go back to work, and it's kind of part of the job. And so I think it's important to talk about the high rates of PTSD among healthcare workers and among people who are exposed to repeated trauma through the setting. So again, I'm glad to talk about this today. So yes, high rates among veterans and first responders. And also, women are about twice as likely to develop PTSD as men. And the reasons for that are largely unclear. I mean, one of the obvious reasons is women experience violence more, but also just there's some speculation that there are some biologic differences among females that make them a little bit more prone to PTSD. And we'll talk about those biologic differences as well. Men, more men obviously are involved in combat exposure and physical assault. The first thing that I wanted to kind of piece out is a lot of people have trauma, and I would say almost everybody's experienced trauma at some point, and it gets to be kind of hard as a clinician because both are important symptoms, whether you've experienced trauma or you actually have PTSD. I think both deserve to be treated and responded to in a serious way. But trauma is the experience of a reaction to any distressing event, and it usually is pretty temporary. But PTSD is actually a chronic mental health disorder that can develop if the trauma is not fully processed. And PTSD contains ongoing debilitating symptoms. And so not everybody that experiences trauma develops PTSD. The likelihood of developing PTSD depends on a lot of different factors, including how severe the trauma is, personal coping mechanisms, and access to support. And when I say depending on the severity of the trauma, that's so subjective. And so some people can develop can experience a pretty serious trauma and perceive it in a pretty resilient way. And some people's perception of a serious trauma, obviously, that can vary pretty widely. So PTSD is it involves prolonged symptoms, including intrusive memories, hyperarousal. It actually involves brain changes that without proper therapy and proper treatment will continue lifelong, and it requires a professional intervention for recovery. The DSM criteria for diagnosis will involve repeated exposure to trauma, intrusive symptoms, avoidance. And so avoidance behaviors are really common. And sometimes that you're not even aware of the things that you're avoiding. And that's, I think, the really challenging thing about PTSD. It often involves triggers in the environment. And so, for example, say that somebody was assaulted, and their memory of that assault is somewhere in their psyche. Years later, they may somewhere in their brain remember colors from the outfit the person was wearing, or smells that were in the environment at the time of their assault, maybe the tone of somebody's voice. There are a lot of little different details about a traumatic event that a person might retain, and they're not always, in a very conscious way, aware of those triggers. But somewhere in their psyche, their brain is aware of them. And so a lot of times different things might trigger some sort of arousal response in a person that they don't know about. And all of a sudden they're getting very anxious or getting very avoidant or hyperreactive. And that's why PTSD is so complicated. And I guess the best example I can give to you, I work I work with federal inmates that are just released from prison. And I had a gal a few years ago that when she had like a kind of a white collar crime, and she didn't expect to go to prison, but she ended up going to prison for like 6 years. And I think it was for some sort of money fraud. I think she had stolen money from her employer. But at any rate, right when she was about to be indicted, or right when she was about to be incarcerated, you have to take off all your jewelry. And she was, said goodbye to her family, that kind of thing. And she had taken off her earrings, her rings, and gone to prison. And she ended up doing 6 years. And then she was released, and she, years later was on probation, doing well, had a job, kind of back to her normal life again. And then she was meeting with me, and she was talking about how she had gone to put an earring in, and she had completely like disassociated and had this panic attack, and she didn't know why. And then after we kind of processed it, she's like, it kind of brought her back to that moment when she had removed her jewelry, and that was a really traumatic event for her, right? And so sometimes it can be the smallest thing like that just kind of puts your brain back into this moment that was really traumatic for you. And so that's really a long explanation of triggers, because it's almost impossible to identify all the triggers until they happen to you. And so PTSD can be really scary like that, because you could be at work or in the middle of something, and all of a sudden something triggers that arousal state for you, and it can incapacitate you. And so that's why it's so incredibly important for PTSD to be identified and to be treated. And so that, disassociation is really, really common with PTSD. And a lot of people don't fully understand what disassociation means. And there's different levels of disassociation. But disassociation is a mental process in which people become disconnected from their thoughts, feelings, memories, or sense of identity. So it's basically, it's in a sense a positive thing, and it's a protective thing for your brain. And so it's a way that your mind copes with overwhelming stress, trauma, or difficult emotions by creating a sense of detachment from reality in that moment. And so disassociation can range from mild and temporary episodes, kind of like the one I just described. And so it's common and not always pathologic. And sometimes it can be more severe and chronic, such as what we see in like dissociative identity disorders. And so this probably happens more commonly than we realize. And so in mild dissociation, people will kind of like zone out, like maybe they're driving, or they're in a boring task, or they might be daydreaming or feeling kind of emotionally numb. But in more severe dissociation, they might actually have memory loss or gaps, or what we would call like an amnestic fugue, or persistent detachment from their surroundings, or actually have like a fragment of identity, such as in dissociative identity disorder. And so that there's a continuum of dissociation. And essentially all of it is some protective mechanism to kind of protect your brain from overloading and having what in a layperson's term we would consider a nervous breakdown. And so that is very common in PTSD, and it can definitely complicate your diagnosis and treatment, and just essentially serves as a coping mechanism during traumatic events. And so treatment considerations, I'm going to talk a lot about therapy, because with PTSD, it's really both components. Therapy, I would say, is the heavy lifter with PTSD, and medications, in my opinion, do the secondary lifting. But so we'll talk about therapy probably as a primary focus. But trauma-focused therapy addresses both the PTSD and the disassociation, and then integration of grounding techniques, which is kind of like mindfulness and getting you kind of grounded in the present, to manage those dissociative episodes. So we kind of talked about common causes already, but risk factors, history of trauma, family history of mental health disorders, and then lack of social support, And that seems kind of obvious, but the more social connection that you have, the more protective factors that you have. And then obviously ongoing stressors and other stressors and things that kind of can complicate your diagnosis can definitely play a factor with how likely you are to develop PTSD as well. PTSD is very, very much a biologic disorder, and I like to provide my patients a lot of education about this because I think it's important for them to understand what's happening with their brain when they've had a lot of changes due to trauma. I think the first thing to understand is the overactive amygdala, because the amygdala is your brain's alarm system. And that's the part of your brain that's responsible for processing fear, threats, and emotions. And so when people have PTSD, your amygdala becomes hyperactive. And so that leads to an exaggerated fear response. And so that contributes to symptoms like hypervigilance, emotional reactivity, intrusive memories. And so when that happens, you'll see people like exit seeking. They're just kind of always on watch. And so if you just conceptualize that, it's very hard to relax if you're always just kind of scanning your environment. And so the other thing that happens is an underactive prefrontal cortex. And so your prefrontal cortex is involved in your decision making, your emotional regulation, and then suppressing that fear response from your amygdala. And so with that reduced activity in your prefrontal cortex, that impairs your ability to regulate your fear and distinguish between safe and threatening situations. And so if you think about that, moving forward, if there's any ongoing threats or new threats, they're always going to have a really exaggerated and out of order response to new threats that happen in the environment. And so that's going to contribute to poor impulse control, difficulty calming down after being triggered. And I think we see that oftentimes with law enforcement officers, with emergency room workers, with things like that. Maybe even in ourselves when we find ourselves getting worked up about things. If we've worked in a emergency room setting or in any kind of setting like that. I know with me, and I don't know how many of you have worked in a hectic setting like that, but I worked inpatient psych for 20 years. And I know when I first started working in inpatient psych, when I first went on the floor, I would always feel that adrenaline response. Like, oh my gosh, like this is so scary, right? And I was, 20 something years old. And then after like a year or so, it's like you don't feel it anymore. And it's kind of an interesting thing that happens to your body. And that's why I always talk about the physical changes that happen with trauma. Because your body acclimates to that. And then, for years and years, I'm calm as a cucumber. Like nothing really affects you because you really get used to it. And so it's really so interesting to me because then after years and years, I go and I worked outpatient for a really long time. And then every once in a while, I would cover the ICU, the inpatient unit. And then it was almost like the opposite. Like I would have an exaggerated response when a patient would start acting up. And it was so physical that after a while, I was kind of like, I don't know if I can do this anymore, because it's just so I know everything's okay on a logical level. But it's just so painfully physical. Like I can feel that adrenaline whenever a patient starts acting up. And so I think when you start to feel that increased cortisol and increased norepinephrine, it's really interesting how the body, you can't reason yourself out of it sometimes. And I don't know if it's more concerning how much you can acclimate to that or how much it just changes over time. And so if any of you have experienced that, I think, you can kind of understand how that happens. And I think it's pretty universal, like I said, to first responders. I've talked to a lot of people who have worked in those kind of settings. But moving on to the hippocampus, so the hippocampus has reduced volume and function. And so the hippocampus processes memories and it helps distinguish past memories from present experiences. And so in PTSD, the hippocampus often shrinks in size, potentially due to chronic stress and high cortisol levels. And so when you have impaired hippocampal function, it makes it really difficult to conceptualize trauma memories, and that leads to flashbacks and like a sense of reliving the event. And so what I see a lot of times too is people just having difficulty with executive functioning, cognitive functioning. A lot of people just feeling like they have ADHD, they're just not functioning well. And so it's really hard sometimes to piece out a diagnosis because so many different things kind of can complicate that, because their memory is impaired, they just can't think very clearly. And it may be a lot of different things, because there's so many different things going on with the brain. So I think my slides get a little repetitive, so I apologize for that. I'm not the best person at making slides. But anyway, PTSD involves disruptions in a lot of neurochemical systems that regulate stress. There's the hypothalamic pituitary adrenal axis. And that's the HPA axis regulates the stress response by releasing cortisol, which is the stress hormone. And so in PTSD, cortisol levels may be actually lower than normal, which reduces your ability to shut off that stress response. And that dysregulation can lead to that prolonged fight or flight state and difficulty returning to that baseline after stress. And so the other neurotransmitters that we talk about are glutamate, norepinephrine, serotonin, and dopamine. And so with glutamate, you can actually see increased activity of this excitatory neurotransmitter. And we're going to talk about this more when we get into meds. But with that increased activity of glutamate, that can contribute to that hyperarousal and also heightened stress sensitivity. With norepinephrine, you can see elevated norepinephrine levels, and that's the biggest one that we associate with that increased fight or flight response, hypervigilance, startle response, and emotional reactivity. And so if you like come up behind somebody that's been exposed to trauma repeatedly, you always will see that exaggerated startle response. Serotonin, which most of us are familiar with, we'll see dysregulation of serotonin, and that may contribute to mood disturbances, irritability, impulsivity. And then dopamine, altered dopamine function can affect reward processing and contribute to symptoms like emotional numbing and anhedonia. Anhedonia is just kind of like lack of joy and lack of pleasure in things. And in my experience, is one of the hardest symptoms to treat with psychiatric patients. Also, neuroplasticity, PTSD may impair the brain's ability to adapt and form new connections, and so that can also affect recovery. Did that already? Okay, so pharmacotherapies. The only two medications that are FDA approved for PTSD, I'll preface this with saying most of what we do in psychiatry is off-label. It just is. And so I wouldn't get super hung up on FDA approvals, but we still have to honor them and document appropriately if we're going to prescribe off-label. The two SSRIs that are FDA approved for PTSD specifically are sertraline and paroxetine. That being said, and so those are both SSRIs. I think we're probably pretty familiar with them. I would assume not a lot of us prescribe paroxetine because it's pretty side effecty. It causes a lot of sedation, weight gain, diaphoresis. it's not a bad med. It works well for anxiety and mood. It's just it's hard to tolerate for a lot of people. Sertraline, a little bit easier to tolerate, a lot of sexual side effects, occasional weight gain. It's hard to come off of. Both of those are hard medications to discontinue. But as far as PTSD goes, it's first line treatment. And so those are still considered the gold standard. But most of the time I will gravitate toward other SSRIs, such as escitalopram or fluoxetine, which are can be better tolerated. And so, but those all SSRIs will target core symptoms like anxiety and depression. And, in general, SSRIs can just target depression, irritability, difficulty processing and calming emotional responses, disrupted sleep patterns, including nightmares. And low serotonin levels are associated mostly with increased impulsivity and aggression in some individuals with PTSD. Other pharmacologic, also before I move on, venlafaxine, even though it doesn't have an indication for PTSD, it is pretty widely used for management of PTSD as well, even though it's an SNRI. Other medications that you may be familiar with, prazosin is really effective for reducing nightmares and sleep disturbances. Prazosin is a medication that can just kind of calm down that whole fight or flight response, especially before sleep. And so indirectly, it can help with sleep and nightmares and just help people kind of go to sleep in a more relaxed state. I do occasionally use it during the day as needed if it doesn't cause too much sedation or hypotension, and if people are able to tolerate it during the day. And so I usually start it at bedtime, and then after a week or so, if people are able to tolerate it with 1 milligram at bedtime, then I'll use it during the day. And what's nice about prazosin is you can dose it up pretty aggressively once people build up a bit of a tolerance to it. You just have to make sure that they've been compliant. But I often use it as an adjunct therapy with an SSRI. But targets those specific symptoms rather than the overall condition. Other treatment options, antipsychotics, risperidone. I use, risperidone can be difficult because of weight gain and metabolic side effects, but it is, pretty effective for anxiety related to PTSD. I did just go to a presentation last week on Rexulti, and the rep there is telling me that Rexulti is going to get an FDA indication for PTSD. And so that is coming from a very biased opinion, but they say that that's coming still this year. So I would kind of stand by for that. But the atypicals can be really effective, and they can kind of tap into a different part of the brain that can treat anxiety pretty effectively and pretty fast. But for more severe cases, when other treatments are ineffective, I think it's a good option, and also can affect some of those intrusive thoughts and mood instability. Again, I would just watch for metabolic side effects. And then obviously can also, treat comorbid conditions if they have an underlying bipolar disorder, or oftentimes people with PTSD will also experience paranoia, some psychotic symptoms comorbidly, and so then you can treat that at the same time, but you just need closer monitoring due to those metabolic side effects and sometimes extrapyramidal symptoms. So I would just monitor those more closely. Off-label pharmacotherapies, I do use clonidine quite a bit for the hyperarousal and sleep disturbances. Clonidine, again, you have to monitor a little closely because you can get rebound hypertension from it. I do a lot of dual diagnosis treatment, and so clonidine can be tricky because you got to start low and dose up, again, similar to prazosin. And so with clonidine, I'll usually start with like 0.1, a half to 1 tab 3 times a day. And then once they're kind of taking it regularly, you can dose clonidine up pretty aggressively as well. They just need to be really educated about taking it regularly, because if they get up into those higher doses, like 0.2 3 times a day, and then stop abruptly, they can get rebound hypertension, and it can become problematic. Clonidine is pretty well tolerated, other than it's drying, so they can struggle with dry mouth, dry eyes, constipation, and it can be a little sedating. But generally, if they go up slower, they can build up a bit of a tolerance for it over time. And then mirtazapine, I know Heidi talked quite a bit about mirtazapine in her last presentation. As long as they are tolerating the appetite increase with mirtazapine, it is a nice option because they don't get a lot of GI side effects. They don't get a lot of sexual side effects, but the weight gain sometimes needs to be monitored pretty closely. But I like mirtazapine especially because oftentimes you can treat multiple symptoms with one medication, and sleep is so problematic for people with PTSD. And so if you can give them one medication and treat their insomnia, anxiety, and depression with one medication, it's a good option. Propranolol as well. Propranolol is nice because it's not as sedating. So for people that struggle with sedation with their other options, then that also is a good option for them. I didn't put a lot about benzodiazepines in here because I don't use them a lot. I will use benzodiazepines occasionally for like when I use them as needed, I'll give people like 10 to 15 a month for really severe days. I try to avoid chronic use of benzodiazepines, like 1 to 2 milligrams a day chronically, because especially with PTSD, it tends to mask symptoms and kind of prolong recovery. And I'll preface that with saying there's kind of a phase to it. So when people are actively working on PTSD, you have to kind of know your patient. And so sometimes there's a time to kind of numb a little bit so that they can kind of get some work done. And so I'll kind of have we'll use benzos short term right now because you're starting therapy, and maybe for a couple of weeks you need a little you need to kind of like control your response a little bit, if that makes sense. And so maybe we'll start out a little more aggressively with something like Klonopin, with the goal of eventually getting down to maybe 10 days a month on days that like your therapy was just really overwhelming, or just using that clonazepam on the really severe days, if that makes sense. But my point in that, to not ramble too much, is that when you're using benzodiazepines chronically, we use any substance to numb, and I'll talk about substance use a little bit later on. And so when you're constantly numbing, you're not essentially treating the trauma. And so you want to make sure that you're not contraindicated to their therapy. And so work with your patient on that dosing. And I'll do agreements a lot of times with my clients, like I said, to where we'll do, this many tablets for a 30-day period. And that's, they're usually pretty agreeable to that. Off-label treatments, again, do careful monitoring, document that you're prescribing off-label, and then maybe use in conjunction with FDA-approved therapies, which there are not many. So EMDR is considered the most evidence-based treatment for PTSD, which is eye movement desensitization and reprocessing therapy. I feel like it's become more mainstream, so many of you may have heard of EMDR now. EMDR is essentially trauma processing. And it's people that do MDR are specifically trained to do EMDR therapy. It is essentially has 8 steps to it. It reduces emotional distress by reprocessing traumatic memories and going through eye movements and tapping. So I kind of compare it to hypnosis in that it kind of trains your brain to stay relaxed while you process traumatic memories. It's a very tricky therapy, and people that do EMDR have had quite a bit of training to know how to pace you to go through this kind of therapy. And so essentially, when what we talked about with the brain changes of everything kind of overreacting, the goal with EMDR is to retrain your brain not to react when you're going through all of these different traumatic events. And so it can take years for the brain to rewire itself through EMDR therapy. And if you're with a really good EMDR therapist, they'll know how to move you along the steps. I'm really careful with clients that have, because I don't do EMDR, but I work with EMDR therapists because sometimes you'll have to take a break. And I think one of probably the biggest missteps that we do is probably move clients along a little bit too fast in their recovery. And that can be really more dangerous than it is helpful. And so it's okay with PTSD for clients just to come in and do talk therapy for a little while, and then maybe do a little bit of EMDR, and then maybe sometimes take a break and go back to doing talk therapy. But you have to really kind of know your client and know how well they're progressing with this. And if it's too anxiety, because all trauma therapy is going to be anxiety provoking, but you have to kind of know where that level is of like it's too much and we kind of need to back off a little bit, especially if there's a comorbid other psychiatric disorder or a comorbid substance use disorder, which is very often the case, because you don't want to create other problems for them in trying to treat their PTSD. And so that treatment process, like I said, it has 8 phases. You have patients that revisit those traumatic memories. And then, again, it may not be suitable for all patients. I think I've kind of reeled back a little bit because I think sometimes the other thing that we make the mistake of is we kind of form these algorithms in our head of, okay, you have PTSD, you need EMDR. And we kind of form these little treatment plans, oftentimes as clinicians. And I think now I've gotten to the point that I really rely on the patient to tell me if and when they're ready for trauma therapy. I think my goal as a clinician is to educate them about their treatment options and let them know that eventually I think they need trauma therapy. But this can happen anytime, maybe years from now, and maybe never. I think that sometimes we push people. My point is, I think sometimes we push people into things way too fast, especially like I run a large treatment center. And most of the time that people come to treatment, we immediately put them into trauma therapy. And they're already getting clean and going through substance abuse treatment. And so they can be in a pretty fragile state when they first come into treatment. And so to get sober and do trauma therapy at the same time, even though clinically it probably makes sense, it's just oftentimes too much. And so I talk to my clients a lot about if they're ready for that. And sometimes they're like, yeah, let's do it. But oftentimes they're not. And I think that's okay. I think if they're not ready to deal with the trauma, that's fine. That being said, most of the time that people first get sober, and we'll talk a little bit about substance use disorders, that's when all their trauma kind of starts to resurface. And so it's a really common time for people to do EMDR. There's also trauma-focused CBT, and CBT is just a way of looking at the way we view the world. And so CBT is a really big umbrella of therapy. We all kind of have cognitive distortions, which kind of means just the lens that we view the world in. And sometimes we're not aware of that. Most of us aren't that aware of how we view the world and how that might differ from other people. And so a CBT therapist will kind of help you understand how the way that you view the world might impair your ability to live your life in the best way possible, or how it might be harmful to you, and how maybe making some small changes in the way you view the world would help you to function better, either socially or occupationally, or otherwise. And so that focuses on addressing trauma-related emotional and behavioral issues. So trauma-focused CBT will focus on relaxation techniques, cognitive restructuring, reframing negative thought patterns, and oftentimes negative thought patterns about ourselves that we believe to be true, and encourage a safe reprocessing of traumatic memories. It's definitely proven to reduce PTSD symptoms, depression and anxiety, and also promote emotional regulation and resilience. It can be used in children and adults. And like I said, it's a big umbrella. And so it's oftentimes a good starting point for people who are ambivalent about therapy. Just to get in with a CBT therapist is sometimes a lot less intimidating than doing something like EMDR if they're not sure about it. Alternative therapies, acupuncture, yoga, meditation, equine therapy. I don't think anybody in the Fargo area does equine therapy, but there are some places in the Midwest. Meditation can be really, really hard for people with PTSD, but I always encourage patients to practice and to try, even if they can only do it for a minute, because most of the time, it's the practice that gets them better at it, and it's supposed to be hard. People's minds are supposed to be busy, and so just because they say they can't do it, or just because it's hard, that's the more reason to encourage it. And there are a lot of really good apps now that people can download that really do guided therapy with them to do meditation, and so and they're free, and so I encourage people to download those and use those. Experimental therapy, there's a lot of research in psychiatry about psychedelic assisted therapy. And so the one that I'll talk about now, because it's probably more mainstream, is MDMA. There's a lot of research. I don't know how many of you have looked into this, but it shows a lot of promise in clinical trials. It's not FDA approved at this time, but MDMA enhances empathy and emotional openness. So that allows individuals to engage with their traumatic memories in a safe and supportive environment. It reduces fear and anxiety, which that often accompanies traumatic memories, and makes it easier for individuals to process their trauma without becoming overwhelmed. It's not FDA approved, but like I said, there's a lot of research going on. But it also has an ability to reduce activity in the amygdala, which we talked about. And so that's the brain region responsible for fear and threat response. And so it can make those traumatic memories less distressing, and it can allow individuals to confront and process these memories without becoming flooded or overwhelmed. And so I would be surprised if that's not FDA approved in the next couple of years. I almost deleted this slide because I didn't want to confuse anybody, but esketamine is only approved for treatment-resistant depression. And ketamine, okay, so esketamine is a nasal spray, and that's, like I said, that's Spravato, and that's only FDA approved for treatment-resistant depression. Ketamine is not FDA approved for any psychiatric condition. And that's only used for anesthesia and chronic pain. So, but a lot of people pursue this. And so anyway, so I administer Spravato for major depressive disorder, and I run an esketamine clinic. I put it in here because while people are using esketamine for depression, which is remarkable for, a lot of trauma comes up. And so it's being widely researched for PTSD because it's an NMDA receptor agonist or antagonist, sorry. And it promotes that neuroplasticity and that rapid symptom relief that we talked about. It's administered via nasal spray. And it shows really rapid improvement for depression, and it has like an 86% remission rate for major depressive disorder. But what I see, and I've been administering esketamine for about a year, there's about a 30 to 40-minute window where people oftentimes disassociate during their sessions. It has to be administered in an office setting, and they become very, very workable in the office, but they're all, they have mild dissociative symptoms, and it's much easier for them and much less threatening, kind of like we talked about with the MDMA, to reprocess trauma. And so it's, in my opinion, becoming a much more beneficial treatment, even though it's not indicated for PTSD and it won't be approved. So I would also be surprised if that does not get an approval for PTSD in the future. But as of right now, it is not approved for that. And then supporting recovery, building resilience, obviously peer support groups, individual and family therapy. We have like DBT support groups and things like that, NAMI, a lot of different things that people can go to. And I think a lot of times just being around people with lived experience, with shared experience, oftentimes is helpful. I educate a lot about regular exercise, healthy eating. I firmly believe that nutrition is like the bottom of the pyramid, like the base of mental health. And so I encourage. I am also not perfect with that, but I really try to educate on that. And then stress management techniques. Mindfulness is a really good grounding therapy, and just staying grounded in the present moment. And then also just relapse prevention planning, because like I said, people with PTSD, they're going to have an exaggerated fear response to things that are happening and that happen in the future. So I do a lot of encouraging to stay off social media, not watch scary movies, not exposed to negative people, and things that will potentially trigger a fear response with them. And so really modifying, not creating a false environment, but also just not intentionally exposing themselves to things that they know are going to cause them stress. Being in toxic relationships, things like that, I have so many people who have been sexually assaulted, and yet they're with an abusive partner. And I don't think it's, and we know a lot about the circumstances of the why people are drawn to that. And it's not my position to give advice with relationships, but I do a lot of supportive care and educating and guiding, to help them make an informed decision, to empower them to get out of those harmful relationships, because it's only doing more damage to their brain and to their systems. And then continuing monitoring and follow-ups. And then comorbid substance use. I would say at least 80% of my clients have a comorbid substance use disorder, but up to 50%. And this is the statistics, but I would argue it's probably more, but of individuals with PTSD also met criteria for a substance use disorder. We know that people use substances to numb. And so if we just look at the disorder itself, it's just only obvious that people with trauma would be drawn to use substances, because once we have trauma and we want to disassociate, we want to forget, we want to not feel what we feel, we would be drawn to use something to make us not feel. And so that would be an easy thing to do, is just to use something that makes us not feel. And so that's why we see, especially with childhood trauma and adverse childhood experiences, most of my clients that have an addictive disorder started using at a very young age to just mask that, and oftentimes have used most of their lives. And so it can be really difficult to recover, because they may have not dealt with those feelings, those emotions, those at all. And so depending on what age they chose to get sober, something called flooding can happen. And so all of those emotions can come up at once. And so that's why we talk about being really, really cautious with therapy and with trauma therapy. And so when we were talking about using benzodiazepines, they may need to numb a little bit until they can kind of deal with that flooding of emotions that can kind of come all at once when they first get sober. And so the impact of comorbidity obviously worsen mental health outcomes, increase the risk of relapse and treatment adherence. And I see this a lot in like residential treatment. A lot of times people come to residential treatment, they get sober, and they have all the support around them. And so it seems a little bit easier because, okay, so I have all these negative emotions, but I also have all these therapists and staff and peers around me to help me kind of deal with it. And then I go from residential treatment to home. And then there's like nothing. And now I'm still stuck with all of these emotions. And so it's really important to have ancillary services. I'm a big fan of peer support, outpatient therapy. And that's why, I'm a big advocate for more increased support in the community, because when people leave residential treatment, that's the biggest time for them to drop off because they just got sober, they're processing all of these things, and there's such a big risk of relapse and treatment adherence and overdose and death when they first leave that treatment environment. So integrated treatment approach is really important. Use of medication-assisted treatment when indicated, and all we've seen in the last couple of years is expansion of MAT, and then also just the increased prescribing rates, and then trauma-focused therapy combined with addiction therapy is important. So key takeaways, PTSD is a treatable condition with evidence-based therapies. Early intervention and comprehensive care are critical. And like I said, it is such a complicated condition to treat. And then emerging treatments and experimental therapies offer hope for treatment-resistant symptoms. I think we've already covered that, but I don't want to end on a negative note, but so positive, approximately 50% of individuals that experience significant symptom reduction within 6 months of treatment. And so it is treatable, and some may require long-term therapy. I said most, I would change that, some to most, for sustained improvement. And so it's just important that, like I said, we have a multifaceted approach and a strong therapeutic alliance. Difficult for these clients to establish trust. And so we need to follow them more long-term and participate in evidence-based treatments. So they are positive prognostic indicators. Anyway, that's all I have. Thank you for attending, and I have plenty of time for questions.
Thank you so much, Jackie. Great presentation, and we do have a handful of questions in the chat, and feel free for those of you who haven't asked a question yet to pop those in as well into the Q&A. So the first question is, what do you recommend for sleep? Is prazosin, if prazosin doesn't work for the patient?
Yeah, I use trazodone quite a bit. Sometimes Seroquel. It really depends on the patient. I'm a big fan of Balsamra lately, if you can get it covered. That orexin antagonist, it does work really well. It's just expensive. But lately I've been gravitating more toward Balsamra. It seems to help a lot, because it's so long, both the sleep maintenance and the sleep initiation. But what I'm getting at is sleep is a problem for PTSD patients. I think no matter what you use, until they kind of do the work of therapy, I think you're always going to struggle, because if you really think about it, their brain is always active, and they're always like hyper vigilant, right? So they're not going to feel comfortable sleeping. Like I deal with incarcerated populations, and so to sleep for them was like dangerous. And so it's very hard for them to fall asleep and feel safe. And so I think it depends on where the PTSD stems from, but oftentimes sleep is really, really difficult. Yeah. But
Great.
I guess those would be my main go-tos: trazodone, Seroquel, Balsamra.
Great. And next question, can S-ketamine be used for patients with history of substance abuse?
That's a really good question because most of my patients do. I would say definitely not actively using. Most insurances will require at least a month of sobriety. Some will require at least 6 months, and I would say there are some that won't approve it if there's any history of substance use. I feel very comfortable using it with substance use because it's not a pleasurable high. And my patients that are in recovery, it's not a long-term treatment. And they come in, so the first month they do 2 sessions of 2 hours a week. The second month they do 1 session of 2 hours a week. And then after that, it's really as needed. They're not meant to stay on it long term, but it's not a medication that produces like a lot of euphoria. I haven't had anybody like I've had a couple people that I felt like were kind of like looking for a high and they almost immediately stopped it. They're like, it's more of a like at least initially a negative experience. People get nauseous from it, they get really tearful, emotional. I think if as far as abuse potential, it's pretty low. And so I think yes, they can absolutely. And I think actually early recovery is a good time to do it because you can get quite a bit of work done in a short amount of time. And I consider it to be pretty curative for depression.
Thank
Yep.
you.
Yep.
Next question, what's the anticipated timeline for patients needing to participate in EMDR therapy? How would you describe the process for patients as far as timeline for treatment, what happens during the sessions, and insurance coverage?
Yeah. So I would say years normally, and it depends on the patient and it depends on the therapist. I think, and this is, I want to be careful when I say this. I think back when I first started practicing, there were literally 2 EMDR therapists in town, and they were both really, really like had trained for years. Now it's really pretty easy to become EMDR certified. And so I would say some people have a lot of experience doing EMDR and some don't. And I think there was just a lot of pressure a couple of years ago for a lot of people to get that certification. And so maybe they're just a bit less experienced. And like I said, I don't want to sound unprofessional, but sometimes it depends on the experience of the therapist, right? But it should take years. It really. And so, because really the first 3 months of any therapy is just kind of getting to know your client. And what I've noticed when I send my clients to EMDR, they'll usually quit after 3 months. And I'm like, you're just getting started. Like you haven't even like gotten into anything. And so, but if you're really gonna commit to therapy, you need to commit to therapy and continue it through. And so, I would say if you're really serious about it, at least a year, if not longer. And if you're with a good therapist, they would be continuing with you. And I think if you have a bad therapy session, you should be able to work through that with your therapist and kind of move forward. And most of the time people are like, well, I don't like my therapist and I'm just going to quit. I think that's a good talking point with your therapist to go, what's not working well? Let's fix that and move forward. Whereas most of the time people just quit and find another therapist and then you're kind of back at square one again. So yeah, it's kind of I think we need to work harder at therapy and not just avoid negative like interactions or experiences. So, yeah.
Thank you, Jackie. The VA has used alpha stem for years for PTSD with some good results. Can this be done in clinic or in home? Thoughts on this alternative therapy?
I don't know a lot about it, so I'm really curious about it, and I would love to learn more about it. But to be honest, I don't know, to be honest with you. I've read a little bit about it, and I was aware that the VA was doing it, but yeah, they're the experts for sure. So yeah, I can't speak to that much because I'm definitely not the expert on alpha stem. Yeah.
What free meditation apps do you like to recommend for patients?
Oh, I really love Headspace. I don't know. It's that's almost exclusively what I use. I know there are others, but that's almost exclusively what I recommend to people. They have such good exercises, and my clients all really love it. So, yeah.
Great.
Mhm.
The next question is, how do you address a conversation with a patient who has been on Xanax for several years at night for PTSD and still not sleeping well, but is hesitant to decrease Xanax?
Oh, yeah, I love having Xanax conversations. So I always start the conversation with, if you don't want to make any changes to your medication, I'm not going to take you off of it, because I think just putting that out there kind of just like reduces that like tension between you and the client. Um, but then I start to say, but this is why I think it's a bad idea for you. And getting off Xanax is hard, and so they're going to have a lot of anxiety about it. But I would say, if you're open to that, I would like to put you on something longer acting, because you can't just stop Xanax. And so, step one would be to switch you to like clonazepam or Valium or something that was less short acting for you. And then eventually maybe get you off of that. If you're open to it. If you're not ready for it, okay, we'll just keep doing what we're doing. But this is why I think it's not a great idea. And I think I start almost every conversation with people like that, because I think if they have fear of you pulling their meds away and they're dependent on them, they're just either going to go somewhere else, or they're just going to like lie to you or not want to work with you or whatever the case may be. So I always start with like, I'm your ally and I want to work with you, and try to find a happy medium. But yeah, I would start by trying to get them on something longer acting that's easier to taper off of than Xanax. Mhm.
Thank you. Any other questions for Jackie while we have her for a few more minutes? We do have time if anyone wants to add more questions to the chat. I'm not seeing any populate right now, Jackie. I just want to say thank you for your time today, and thank you for all the work you do in our community for the underserved. You do amazing work, and we thank you for your time and expertise today.
Thank you.
We will have about a 15-minute break now. I do want to verbally say thank you to people who have filled out the HRSA form that I've been nagging everyone about the last minutes. But we do need that to continue to offer conferences like this, because HRSA requires us to report on demographic information of the events that we host. So if you haven't done that yet, there's about 70 of you, it looks like, that maybe haven't filled that out yet. I popped it into chat right now. So if everyone could fill that out during the next 15-minute break, that'd be great. It only takes maybe 30 seconds or 1 minute to fill out. So we'll see everyone back here at 11 a.m. Thank you. Okay, it is the 11 o'clock hour, so I want to welcome everyone back, and I want to welcome our next speaker, Dr. Cindy Sundag, who completed her medical degree at the University of North Dakota in 2011. Then she went on to complete her residency in psychiatry at the University of North Dakota, where she served as a chief resident during her final year in the program. She is board certified by the American Board of Psychiatry and Neurology and has been working at Sanford Health in Fargo since 2015. She is an eating disorder specialist, with the other half of her appointment in the general adult outpatient psychiatric clinic. Welcome, and I'll let you begin.
Thank you. Thank you for having me. I'm very excited to talk about this topic today. Eating disorders are incredibly prevalent, and I think seeing them in primary care is often the first point of contact. And so I think this is hopefully going to provide some good information. So I'm very excited to share what I know. So just looking at the objectives, So first of all, I just want to go through kind of the criteria, or just the different characteristics that we would see, how we diagnose the different eating disorders, the more common ones, of course. And then we'll talk about some of the common medical complications that we tend to see. Maybe some of these will be like presenting symptoms that you all might potentially see actually in the clinical setting. And then just talk through a little bit about how we manage, where we manage, maybe some discussion about, I have a couple case examples, so I think that might be helpful for us. And then also just looking at like when to refer and who to refer to. So with that, we'll move into just talking about the different diagnoses. Anorexia nervosa, probably everybody is familiar with that term. So when we think about anorexia, we think about low weightedness. I think that's a key thing with anorexia. By definition, it's about not meeting your energy needs in a way that you're going to be underweight. For adults, we think about that as less than a 19 BMI typically. But it also can be, if we think about like more of an atypical anorexia presentation, it might be that it's a significant loss from where a weight had typically been sitting. So somebody that has had, say, a 20-pound weight loss in a very short period of time, but is still technically considered normal weighted from a BMI standpoint, they're still going to have potentially the anorexia diagnosis, and that would be the atypical type of anorexia. And then when we look at our kids, we don't always think about BMI necessarily as much as we think about where have they been at in their growth curve. And so if there's like a sudden drop off, or they're no longer progressing along the same curve that we would expect, that's a signal for us that something is going on, and that would be likely the anorexia diagnosis, as long as, in addition to the weight issue, there's also some fear of body shape, some fear of gaining weight, fearful that there's going to be a change in their body that they're very concerned about. So that also has to be present for the anorexia diagnosis. And then I just did put at the bottom too for us to be thinking about. Sometimes I think it gets a little confusing. Is this bulimia if somebody is binging and purging? Not necessarily. So we definitely have the anorexia diagnosis. Again, a low-weighted person that's binging and purging, that's going to be anorexia binge purge type versus the anorexia restricting type. Moving into bulimia nervosa, which is also, I think, a pretty well heard of and probably understood diagnosis. So with bulimia, we have the binges and the purges that have to be occurring. The binges are recurrent, meaning that they have to be happening. I think it's weekly for at least 3 months is how we characterize the frequency for it to qualify for the diagnosis. So sitting down, having a significantly large volume of food in one sitting, and then there are a couple different qualifiers that go along with that, like feeling shameful about it, feeling guilty, tending to hide it, getting overly full in those settings, and having some sense of a lack of control. And then with bulimia, there has to be then that compensatory behavior. So that kind of discriminates between binge eating disorder and bulimia. So with bulimia, we have that compensatory behavior where we're trying to get rid of the nutrition that we've taken in to prevent weight gain. The one that we most commonly see, I would say, and the one that we think of most often would be self-induced vomiting. But there are other ways of purging. So laxatives can be a way to purge. Diuretics are sometimes used. Exercise actually can be a way to purge. And honestly, I think we were discussing this just earlier on our unit that from a research standpoint, we're actually seeing less of the vomiting and more of some of the other behaviors. And some of that is a little bit like, from a society standpoint, right, purging is kind of falling out of favor just because it's a little bit taboo, I would say. And so I think we're actually starting to see a little bit more of some of the other behaviors picking up. And then that qualifier of the frequency, so at least once a week for a period of 3 months. There's also a significant body image component to bulimia as well. And then I just added that from a weight standpoint, our folks with bulimia are typically normal weighted or even sometimes on the overweight or obese side. And then binge eating disorder, another very common, actually probably the most common eating disorder is the recurrent episodes of binge eating, but without a compensatory behavior. So again, that's kind of what separates it from bulimia. Still the same marked distress with the binges, and then the frequency happening at least once per week for 3 months. And then the last one that I added in for today, just for a diagnosis standpoint, or kind of identifying characteristics of the eating disorder, because I think these are the ones that are going to be the ones that are seen most prominent in a primary care setting. This last one is ARFID. ARFID was identified or kind of given the name in 2013. Has been around for much longer than that, I'm sure, but we just didn't consider it a thing until then. And so ARFID is another eating disorder where our folks are going to be low weighted. They're just not getting enough nutrition to meet their energy needs, but it's not associated with body image. So this isn't due to a fear of weight gain or trying to stay thin. This is related to, it can be a variety of different things. Sometimes it is a fear of choking. Sometimes it is a fear of a different medical consequence that they don't want to experience, like significant GI distress with certain types of nutrition. Sometimes it's a sensory thing. So we see that more in our younger kids when they're diagnosed with ARFID, that it's just really having an aversion to food because of a taste or a texture. And then from there, just not being able to eat enough to sustain a healthy weight. So then, the things that kind of are complicated or occur because of that are things like weight loss, nutritional deficiencies. Sometimes these folks end up being completely dependent on enteral feedings or supplements. And in addition to those things, it has to be causing a significant distress in their life. And it's not associated with just not having food available or a cultural practice. And it's not due to another medical condition. So those are kind of the main diagnoses, I think. There certainly are other eating disorders. There's rumination disorder, pica, but I think from a standpoint of what you're going to tend to see most often and what my area of experience or expertise is in would be these particular ones. Oops, I think I went ahead too many. Okay, so just again, kind of hitting home the point of why is this important? We already talked about that. Oftentimes, the first point of contact is actually going to be by primary care. And the number of folks in the United States that meet criteria for a lifetime eating disorder is pretty profound. Definitely more women than men. So 20 million women, 10 million men. But I think we're also learning a little bit more too that we don't know that it's necessarily that the ratio is a 2 to 1 so much as men sometimes don't seek out help, or it's a little bit easier maybe to pass it off as something else. So I think we're kind of learning a little bit more too as we go, that there probably are more men out there that are just not diagnosed. And then importantly, I think things for us to think about too, that, different risk factors, genetics, gender, age, influence of society, peers, history of trauma, those are some of the things that we think about as far as what makes people more susceptible. I added this next slide because I think this comes from the Academy for Eating Disorders website. It's just, I think, good for us to think about, because there are a lot of things about eating disorders that we kind of maybe get an idea, or there's maybe influence from social media or things that really aren't necessarily correct. So I think as we're kind of thinking about diagnosis and we're thinking about who has eating disorders, just good for us to think about some of these things. Some people, they'll come into your office and you might be able to identify just based on looking very cachectic, or some other things that would kind of point you to thinking, yeah, that person looks like they have an eating disorder. And some people, we can't identify that just by looking at them. And that kind of goes through, this isn't a choice. This isn't something that we blame on families. We don't blame it on the patients. Eating disorder diagnosis is a health crisis. I think that's important for us to think about. It disrupts personal and family functioning. Again, they're not choices. They're serious biological diseases. They can affect all ages, all genders, races, ethnicities, ages. So again, it's not just specific to women or young kids or adults of a certain age. The risk factors, I think both psychiatrically and medically, important for us to think about. Anorexia has the highest mortality rate of any psychiatric illness. So just kind of thinking about the severity, risk for suicide and risk for medical complications. Genes and environment play an important role. Genes alone don't predict who will develop eating disorders. And then full recovery is possible. So I liked that table. I think it hits a few very important points. The early detection and intervention are important. I think that's a really crucial thing for us to be thinking about as we're in the clinic and we're kind of identifying folks and remembering that we want to get them help early. Our adolescents have a pretty high recovery rate. So I think last statistics that I saw, it was over 80% for our adolescents that get good treatment and get it right away, can go into full recovery. So that's encouraging. And so now we're going to move into more of the medical complications that we tend to see. I'm not going to list every single one, of course, but I think we'll try to hit some of the highlights and probably some of the ones that clinically we see and are able to identify a little bit more regularly. So both anorexia and bulimia affect the entire body. So as we kind of go to the next slide, we'll look at the different systems. I kind of laid it out in a chart, and really everything is affected. So, and then I just threw in there too. So ARFID also, I kind of clump that together with anorexia when we're thinking about what medical complications we tend to see, because both of them are going to be related to malnutrition and weight loss. So moving into that chart that I talked about, we're not going to go through each of these specifically on this chart. We'll kind of go through them as we move into the next slides. But, you know, we have just kind of the general systems where we've got the weight influence, weakness, fatigue, different syncope, pre-syncope, then into oral, dental, cardiorespiratory, GI. So you can just see there's just one thing after the next listed in each of our different organ systems. Whoops, I went too far. Endocrine, neuropsychiatric, dermatological. So really, there are so many things. It's just kind of a profound, comprehensive effect on the body, I guess, is the point there. So kind of picking some of these apart then and going into the different areas of systems that we see. This first slide, I titled weight loss, but really not necessarily just weight loss itself, but I suppose being underweight or malnourished. The picture, you know, kind of speaks for itself a little bit, that sometimes it's significant and we can see it in our patients when you're doing a physical exam, the bony prominences and just the severe muscle wasting. And other times we don't always see it. So just kind of a reminder that when we're talking about weight loss versus extremely low weightedness, we might not be able to identify it just by looks alone. But being malnourished and being low weighted comes with, you know, the obvious muscle wasting and weakness, kind of a significant loss of muscle mass. That is reversible, right, with nutrition. The neurogenic atrophy, kind of a different twist to the low weightedness or the muscle wasting. That's going to be more due to actual nerve damage itself. And so there's going to be some atrophy that happens because nerves are damaged as well, right? And so that's a little less fixable, if you will. And that happens with our more chronic and severely low-weighted folks. Because of the loss of muscle mass, a lot of times we see pretty significant pain that can come in the form of like back pain, right? If there's not enough muscle to support the spine, pain in the buttocks and joints because there's not enough support or cushion, really. So a lot of just general kind of body aches and pain from lack of tissue. Sometimes it's pressure points and ulcers. So pain is a really common symptom that we see, and especially in our very low-weighted folks. Falls because of some of that weakness, loss of balance. We oftentimes will see fractures in our low-weighted folks when they're falling because of osteoporosis. I literally had somebody sit down in my office one time and she broke her hip in the chair. So can be pretty profound. So then moving into osteoporosis, loss of bone mass due to both increased resorption and decreased formation. For some of our young kids, right, that start with anorexia at a very low age, that's during their bone building years, and they're missing that critical time of bone building. So we see osteoporosis pretty commonly. The recommendation is for just monitoring, so doing densitometry every 2 years. But how we actually treat the osteoporosis once it has happened is controversial, or even in the prevention of it happening, essentially. We know that weight restoration is the primary thing that's going to help these folks, both preventing it and then even after the fact, just to help prevent further progression. So weight restoration is primary. But some things have also been looked at. There's still kind of a bunch of data out there showing kind of both sides to things like bisphosphonates, estrogen patches, the oral contraceptives, we don't really have an answer yet, like what of those is actually recommended. I typically don't start these things, but if somebody comes to me and they're already on them, that's a fair thing to just continue because we don't have any data to say they're causing us any problems. More kind of endocrine type things that we see, low blood sugars, of course, we would expect that in our very low weighted folks, especially, or in our anorexia patients or ORFID, folks that are not able to meet their nutrition needs. Sometimes it can be pretty profound. And sometimes when we have people that are in the, outpatient setting and their body has adjusted and adapted over the years, there are plenty of folks walking around with blood sugars in their 40s and they're not symptomatic. And so the correction, or kind of when we take action, in some of the patients that have been doing this for a very long time is very different, right? And so our typical hospital protocol for low blood sugars, if you just look at like the hospital kind of medical floor, they correct for blood sugars less than 70. On our unit, we don't correct until we're under 40 usually. So just kind of a different way of thinking about it. But if you have somebody come in your office, right, and their blood sugars are low, and it's a young person and you're thinking, it's kind of suspicious, right, that I have somebody that has a fasting blood sugar of whatever, 50 something. Some of those things are kind of our clues, I guess. Absence of menstrual cycle, that's going to be another endocrine issue that we tend to see happens pretty often, and it's not just in our low-weighted folks. Sometimes in bulimia we see it as well. For our patients that are low-weighted though and have amenorrhea, we usually see the cycles return around 95% of their ideal body weight, but sometimes it takes a long time. And so especially with our adolescent patients, it seems like it can take 6 months to a year of being back on a meal plan that supports a healthy weight before they'll actually start to resume their cycle. And it's also not uncommon for us to see thyroid abnormalities. Oftentimes we'll see more of like a subclinical hypothyroid picture where TSH is very elevated. T4 sometimes then is remaining within range. And those abnormalities, just lab abnormalities, tend to resolve after we've gone through the process of normalizing nutrition. Okay, moving over to some of the cardiovascular things that we see. Probably don't have these in the order that I'm going to talk about. I'm sorry about that. Hearts are small, right? And so especially as we kind of think about our underweighted folks, we tend to see kind of that same atrophy that we see in general skeletal muscle. So myocardial atrophy. Along with that, sometimes we'll see changes on EKGs. I usually see kind of the rightward axis shift. That's more of a function of the heart kind of being small and kind of being a little bit at a different angle in the chest cavity. And so we see that one a lot. We see sometimes mitral valve regurg because of the atrophy. So that valve just isn't closing very well. Some of the things that we see in either bulimia or anorexia, chest pain is not an uncommon complaint. Oftentimes we're seeing those blood pressures that are pretty low, or conversely, sometimes in our folks with bulimia, depending on the behaviors and depending on some of the compensatory behaviors that they're using, sometimes we'll see like elevated heart rates, but more low-weighted wise, we tend to see the orthostatic low blood pressures and tachycardia. Again, the rate abnormalities, so very low heart rates typically in our low-weighted folks because body is kind of in conservation mode. So 95% of our patients with anorexia have some bradycardia, sometimes pretty profound. And then again, kind of the tachycardia palpitations sometimes that we see in bulimia, especially if some of the electrolytes are getting thrown off with the different forms of purging. I threw edema in here. It can probably fit in a couple different places, but we can have edema just related to the severe low weightedness and low albumin and low protein levels. But we also sometimes will see edema as a function of just poor cardiac function too. I did separate the next couple slides out when we were talking about GI difficulties or complications. So in anorexia versus in bulimia, because we see some different things. And so I did separate these. In anorexia specifically, very, very common concern or complaint is going to be just things aren't moving, right? And so our malnourished guts are not going to be able to absorb or not going to be able to perform function-wise the way that normal gut tissue is. So we often see gastroparesis, right? So just significant discomfort, slow transit time, fullness that sometimes will prevent these patients from taking in more nutrition throughout the day because they're just so uncomfortable. Gastroparesis treatment for anorexia isn't really any different than what you might do for other medical reasons for gastroparesis. So we'll use things like metoclopramide, erythromycin. For kids, I often use periactin. There's a little bit of data for some of the proton pump inhibitors, just being able to help with a little bit of a prokinetic effect. So if you're thinking about treating something like that in the outpatient setting, it's really not different than how you would treat typical gastroparesis. Sometimes the antibiotics are a little bit harder to tolerate just because of some of the GI distress that usually kind of comes with them. So just kind of thinking through side effect profile. Constipation is, I feel like, going to be probably a pretty consistent complaint or finding in really, I would say, most of the different types of eating disorders that you come across, right? So we tend to use the osmotic laxatives because they're going to be the safest laxatives for us to use. Not uncommon, right? Sometimes for eating disorder folks to be abusing laxatives. And so sometimes it's a matter of having to kind of taper off or get away from more of the stimulants. We use the osmotics in pretty extreme doses relative to what I think most people would be used to using in a clinical setting. It's not uncommon for us to use, 6 times the osmotic dose per day as to what is typically used. So we end up getting into some pretty high doses sometimes depending on the nature of the constipation. And then the fullness, nausea, bloating, just some of the things that kind of go along with that malnourished gut as well as the gastroparesis. So if I have to guess, I'm going to say some of the GI complaints are going to be some of the more common things that are going to be presenting symptoms in a primary setting. And then just a couple more things in anorexia or ARFID, just our low-weighted people that we tend to see. Pretty profound elevation of liver enzymes at times. And it's pretty specific. And so you're looking for the AST, ALT elevations. Bilirubin usually is left alone. ALT usually not elevated. And so if you have somebody that comes in and they're low weighted and their liver enzymes are quite elevated, that is most likely just a function of the malnutrition. The other thing that we see that's kind of curious, because a lot of times, right, we're looking at trying to supplement these folks and we're thinking about, okay, we should probably be giving them B1 and we should be giving them B12 and what are the different nutritional deficiencies. But then we look at their levels. B12 levels are usually profoundly elevated, and that's a function of the liver disease that happens. So B12 is stored in the liver. And so when we have these folks that are having liver damage due to malnutrition, those cells are popping open. And so we tend to see really high B12 levels. So sometimes that's even just kind of one of those head scratchers. And then you start thinking about like, okay, what else am I seeing? And so sometimes it can kind of clue us in a little bit as to what might be going on. Sometimes B12 is actually elevated without the other liver enzymes being elevated. And then another one, malnutrition, pancreatitis of malnutrition, I guess. So another thing that we see sometimes is both amylase and lipase pretty profoundly elevated. And you know that can be a little bit confusing to us too, because sometimes we see amylase elevated in bulimia or in anorexia, that there's a purging component because the salivary amylase can be elevated due to the persistent purging. So I usually will check both amylase and lipase just to see if it's more related to like a pancreatic effect. And sometimes we have pretty significant pain. We actually see like active pancreatitis symptoms in some of our very low weighted folks. And sometimes it's just an incidental finding and there isn't any symptoms associated with the pancreatitis.
Cindy, I am going to just pause for a second because there's a question in chat that is actually related to what you're talking about right now.
Okay.
You test then for nutritional deficiencies, hair analysis versus blood?
We do blood on the unit and in our outpatient setting. So we're looking for things like the different vitamins yeah, I mean, I guess mostly we just do like vitamin D, the B vitamins, and then just as we're doing kind of the regular panels of when we're going through the process of nutrition, like refeeding, we're going to be looking at things like magnesium and phosphorus and stuff. But it's just blood tests is what we tend to use.
Thank you.
That was the question, right? I got that.
Yes.
Yeah.
Thank you.
Okay. Yes. Okay. And so then we'll move on to some of the different GI symptoms that we see more so related to bulimia. And so with our folks that are using vomiting as their mode of compensatory behavior, very common for us to see some pretty significant reflux. To be fair, we also see reflux sometimes in our patients with malnutrition and anorexia and ARFID as well. But I would say it tends to be quite a bit more profound when we have vomiting as one of the main behaviors, to the extent that sometimes there's kind of refluxing that's happening completely involuntarily. So using kind of your standard arsenal of what you would use for reflux in other clinical situations that cause reflux. And then nausea is another one when there is self-induced vomiting. Pretty commonly for us to see nausea. Again, kind of treating it the same way. So using some of your standard anti-nausea meds. Pretty uncommon, but still worthwhile mentioning, I think, because textbooks tell us it can happen. The esophageal ruptures and Mallory-Weiss tears. If the method of purging is by laxatives, then we tend to see more of the lower GI symptoms and distress. So again, constipation as a result of having used such a significant amount of laxatives over time that we really just can't have bowel movements unless they're using sometimes pretty profound amounts of laxatives, dysmotility, and oftentimes things like rectal prolapse come up too. With the severe dysmotility, some of these people kind of end up in the GI world, and they'll get put on some of the newer motility agents, or sometimes it progresses to things like, colon just isn't functioning anymore. It's not uncommon for us, unfortunately, to see some of our very chronic folks end up with ostomies. Okay, so yeah, then I wanted to move into kind of the fluid electrolyte status that we tend to see. And I kind of did this one also as a little bit of a combined, but I'll kind of point out some of the separate things that we see in an anorexia picture versus in bulimia. So dehydration can be in both, right? And so it's not uncommon at all for our patients that suffer from anorexia who are restricting food to also be restricting fluid. It can be pretty significant, and that's probably really another way that we see these people present in the outpatient setting or in the emergency rooms, right? They come in pretty severely dehydrated. They don't want you to give them IV fluids, right? And really, especially for our really chronic and very low-weighted patients, we wouldn't necessarily recommend IVs unless it's really necessary, because we can flip to the opposite pretty quickly, and we can end up fluid overloading them with a bag of saline. So we just want to be really careful with how we're correcting the fluid status. But along with that, with our patients that are low-weighted, either because of anorexia or ARFID, not uncommon for us to see low sodium. That's a pretty common finding for us. And that's usually more kind of a chronic picture over time that we see the really low sodiums. I have an outpatient that kind of sits in the 125s, and that's just where she's at. And it doesn't cause her any issues or any sequelae for her immediately by being that low. It's just that's her new baseline. We'll oftentimes see low magnesium, low phosphorus in these patients, and this is even before we start the process, right, of refeeding. Certainly those things get used up in the process of refeeding, so it's not uncommon for us to be replacing things like magnesium and phosphorus as we're working with some of our low-weighted folks. But even in the absence of starting that process, just kind of coming in, we'll oftentimes see magnesium and phosphorus be low. It's not common for us to see low potassium in a restricting anorexia. So that one is kind of pretty unique to, you have to be getting rid of your potassium somehow GI-wise. So it's not, usually just a function of not getting enough nutrition in. It's if you're purging, right? So that could be anorexia binge purge. So we might have a patient with anorexia that has low potassium, but that would be more likely due to some type of purging. And then I just put in there too, just remembering that with the very low-weighted folks, or even just any kind of significant chronic or prolonged hypovolemia, where we have kind of that low fluid status for a very long period of time. When we start the process of getting nutrition back on board and we stop the behavior, there's going to be really, really significant fluid retention. And it really is much more profound with the binging and purging and the laxative, more so than just our restriction or exercise. So not uncommon at all for us to see 10 to 20 pounds of fluid kind of come on. And some of that is due to the rate at which we're correcting things. So like in an outpatient setting, we wouldn't necessarily have that much happen as quickly because the correction is going to be over a longer period of time. I put this chart in there just so you could kind of see and compare some of the different fluids and electrolytes depending on the behavior and what the acid-base balance looks like too. So you can just kind of look through that. I think the one thing that I will point out about this, and we'll actually see it because I have a slide in here as I'm talking through a couple different cases, that the typical finding, I guess I will say, from a acid-base status is you're going to tend to see our patients that are purging, they're going to have really high CO2. Our patients that are using laxatives will often have very low CO2 levels. And so just, you're doing labs in a clinical setting and you're seeing people that have really high CO2, and you're kind of wondering about eating disorder, be suspicious of purging, and those laxative abusers tend to have those low CO2 levels. I think we're going to kind of work our way through. I'm probably running a little bit short on time and we have a lot to go. So one of the other things that we tend to see as you're doing some kind of basic blood work, and you maybe come across low white counts, or kind of a pancytopenia, low hemoglobin, not uncommon at all for us to see because the bone marrow becomes much more gelatinous in malnutrition, and so we'll often see that those blood cells both are not being made as effectively in patients that are low weighted or malnourished, but then they're also not able to get out of the blood marrow or of the bone marrow effectively. So you wouldn't necessarily be surprised if you see like a white count of 1 or 2 in some of your patients and you're kind of wondering what's going on. That can very much just be a function of malnutrition or low weightedness. Get a slide jumpy here. And then a couple more systems that we're going to touch on. So derm effects, and just kind of head and neck kind of stuff that we tend to see. I'll kind of cruise through these because these are a little less relevant just in terms of treatment stuff, just kind of for your information stuff you see. Lanugo, we see that quite often in our really low-weighted folks. That fine hair that's kind of trying to help the body regulate temperature. Keratonemia, so the yellowing of the skin, that happens sometimes because the keratin is stored in fat, and so when we don't have that, it kind of mobilizes the keratin a little bit. The blue fingers and blue toes, so we see that oftentimes there's not a lot of body fat that's kind of helping regulate some of the just core body temperature, but then also some pretty significant vasoconstriction at times. We'll often see kind of those dusky, cold extremities. I've never seen Russell's sign, but that's one of the things that we always put out there as a, watch out for this, because that's a potential thing that we see in our patients that are using their fingers to purge. To be very honest, most of our patients don't need to use anything. They don't have to mechanically induce purging. They can just vomit. Hair loss is a pretty significant one though, and that's actually one that our patients really don't like. And so for our young patients that are starting to kind of explore a little bit with an eating disorder and they realize they're going to lose all their hair, that can be a way for us to kind of help deter patients sometimes. Pharyngitis, recurrent nosebleeds, and the subconjunctival hemorrhage. I just put those ones on there. Those would be more related to patients with bulimia that might be purging. And then the parotid hypertrophy, I did put this one on there because I think that one sometimes is actually kind of a giveaway. That's something that sometimes it does get significantly obvious, I would say. So you might have a patient that coming in and you're really noticing those parotids just being very swollen, and that happens with purging. Okay, couple more slides just related to medical complications, and then we'll kind of move into, I have a few cases that I want to talk through, and then we'll go into more of kind of some of the management stuff. So neurologically, I think, really important to think about. So the long-standing low weightedness especially, we really see pretty significant atrophy over time. We definitely see shifts in cognitive function. Those things in our younger patients that haven't been doing their eating disorder for a very long period of time, they still happen. They will say, I can't think clearly, but it gets better. So that's a reversible thing versus somebody maybe that's been doing this for a very long time. We're obviously not going to change that atrophy that has happened over years. Mood and anxiety, a malnourished brain is going to be a more anxious and a more depressed brain. So if somebody has baseline anxiety and depression when they're malnourished, it gets significantly worse. And then sleep is another thing that gets pretty dysregulated with malnutrition. And even with, our patients that are engaging in other behaviors, so bulimia, binge eating, we see, and some of that is a function of nighttime is when behaviors might be happening, but it's not uncommon for us at all to see sleep get pretty dysregulated in eating disorders. Seizures, of course, can happen when we have patients that are getting some of their electrolytes really off. We don't use Wellbutrin, right, or bupropion in patients with eating disorders. That's kind of a general rule of thumb. Sometimes we do when we have certain situations, but I would say generally in the primary care world, it's pretty common to not use it. Another thing that happens, neuropathy is pretty common, and so we might see somebody that comes in that's been low weighted, or sometimes it's even a function of that fluid shifting, and so somebody that's got some pretty significant edema, not uncommon to have some of that numbness and tingling, just kind of overall peripheral neuropathy. And then, so that kind of covers systems, I suppose, or some of the main complications that we're going to see with low weightedness or with bulimia. But I also wanted to put out there, we can't forget, right, that our folks with binge eating disorder also are going to have medical complications that are going to look quite a bit different than the ones that we've already talked about. So I just put this slide into so we think about the things that we're going to see or be treating more so medically related to binge eating are going to be things related to like obesity and overweight. So type 2 diabetes, blood pressure, fatty liver, metabolic syndrome. Also can still have vitamin deficiencies. They're not uncommon just because sometimes the binges are kind of the types of foods, I suppose, if you will, kind of leave out kind of a well-balanced diet. So we sometimes see vitamin deficiencies to some of the similar GI problems that we've already talked about. In extreme cases, of course, again, these aren't things that we would tend to see on a regular basis, but things can get pretty significant over time, and those would be our extreme gastric perforations or outlet obstruction. So, okay, I'm kind of hurrying, but I'm doing so, I guess, because I want to run through a couple cases real quick of things. So again, these are just like actual people that we've either seen here in the hospital. I do both hospital-based work as well as clinic work. So I kind of have the luxury of seeing all ranges of degrees of sickness. I mentioned, right, when we were talking about some of the different electrolyte disturbances, that I have a patient who sits in the outpatient world with a sodium of 125. So this patient is a 45-year-old female, has been doing her eating disorder since age 14. Her BMI is 12.3. She does have low sodium at baseline. Also has those kind of chronically elevated LFTs, although in the kind of baseline level of her illness, we would typically find those at like 100 to 200. So this was just a check-in. So I see her in the outpatient world from a psychiatry standpoint and collaborate with her primary care. She had gone in, these were her labs. This was a time where she was having some edema but was also experiencing weight loss. And so that was concerning, right? Because she's got extra fluid on board, but she's also now 3 pounds less than her typical weight that keeps her at that 12.3. And then they just put some of her other vitals just to kind of highlight again some of those low blood pressures, low heart rates that we tend to see. So significantly though, on her labs, I was just wanting to point out that so calcium, protein, and albumin all low. Those 3 things usually kind of tell us that there's some edema going on. So the hemodilution effect. So when we see all of those things low and we have edema, those just kind of add up, I guess. Her AST and ALT though were pretty significantly elevated for her baseline. So 563 and 821, those are not the highest I've seen. We see them in the thousands sometimes. And then that B12 being elevated. So just kind of wanted to put that out as an actual situation. So this is an example of somebody that was seen, and then we decided, yep, with the weight loss and edema, the real weight loss was actually more. And so she was referred into the hospital to just kind of get things back on track for her. This case, a lot less, right? If we just take a quick glance at the labs, a lot less things are looking abnormal, right? So again, just kind of a comparison of sometimes you get labs back and it's like, wow, clearly there's something going on here. And other times we can see not a lot of indicators here that something is going on. But this happened to be a 16-year-old patient that was seen for weight loss and fatigue. In conversation with her was actually discovered by her primary care that she had been doing some restriction and was struggling with body image, had lost 16 pounds in a pretty short period of time, hadn't had her menstrual cycle, right? So she was in that amenorrhea phase, was having some constipation, was noticing that she was losing her hair. So again, all those things that we talked about just from a system standpoint. Slightly elevated creatinine. She looked a little bit dry on labs, a very mild elevation of her liver enzymes, but that's kind of the start of some of those things that we talked about that you might see. This next case is a patient, 53 years old, bulimia. Her mode of compensation was laxative abuse, severe laxative abuse. So normal BMI. So again, kind of thinking about with our bulimia folks, they're going to be normal weighted, right? This was a time where I had gone in to see primary care, was actually not doing too bad relative to previous level of eating disorder behaviors. But you can definitely see some of the things that were going on, right? So with bulimia with laxative abuse, we're going to be seeing that dehydrated picture, right? We're just flushing out all of the fluid. So BUN was elevated, creatinine elevated, flushing out a little bit of sodium, potassium was pretty low, and again, that bicarb being low, kind of indicating that picture of laxative abuse. I put this on just because this next slide, because I wanted to point out, so this is the same patient now, but this is a couple years earlier when we had treated her the first time. So laxatives are awful. And I will just say that they can cause so much damage. So this was the first time that we saw this person when she was really struggling with her eating disorder. She actually had to have emergent dialysis because her creatinine was 7.9, her potassium was 1.9. So she had gotten herself very, very sick with laxatives. And then the last case that I wanted to put on was a patient with anorexia binge purge type. So again, kind of more of the purging picture, vomiting type picture that I wanted to point out. So some level of dehydration, low potassium, chloride kind of following as well. So low chloride, and then that really elevated bicarb. So just kind of seeing that's a little bit of a picture that you might see with somebody that's coming in that's doing some self-induced vomiting. So I'm going to try to get through this last little bit here quick. So in primary care or in an outpatient setting, what kinds of things are we potentially going to be seeing, or what are we looking for? What might some of the red flags be? This again comes from the Academy for Eating Disorders website. I put that on the end of my slides just as a resource because it's a good resource. So they have a lot of interesting and kind of treatment related recommendations. So Academy for Eating Disorder website, it's a good resource. So what might be some things that would be kind of raising suspicions for, I wonder if there's some disordered eating going on. I'm not going to read through each of those, but you have somebody come in that's got pretty significant change in their weight or weight loss or shifts in either directions, really kind of focusing on compulsive exercise, stuff about their body image. The GI stuff, I think, is pretty concerning and probably something that comes up pretty often. So kind of coming in with some non-specific GI complaints. The lab abnormalities, we already talked about that, bradycardia, irregular menses. The next one is about patients that have type 1 diabetes that come in with persistently elevated blood sugars or repeat episodes of diabetic ketoacidosis. That's another one that kind of raises a flag of we call it diabulimia, even though it's not like technically a term or a diagnosis. So just underdosing insulin to kind of run blood sugars high so that there can be some weight loss due to that. So just some things that maybe are things that would make you say, I should maybe do a little bit further digging into this. So then what do? The screening tools that are recommended, I guess, and this is kind of, I say this loosely because there aren't any really specific recommendations from a primary care standpoint that I could find, and you guys might know more being in primary care if there are tools that you guys use or recommendations specifically for you. But the SCOFF is a good one. It's simple. It's got 5 questions. You can kind of screen specifically for anorexia, bulimia, probably ORFID to some extent, maybe a little bit of binge eating. The eating attitude test 26, that one's a little bit longer. That one, it's a little bit more cumbersome, but still not terrible. And then actually one very specific for ORFID is the 9-item ORFID screen. So just things that you maybe can have in your toolbox to, do a little bit deeper digging in if you're having people come across your clinic and kind of wondering, where do I go? What do I do next? Oops. As far as like the specific evaluation, if you have somebody come in and you believe that, maybe gone through the SCOFF and you're pretty sure, yeah, they probably have some level of restrictive eating. What kinds of things should I be ordering? What labs? What else do I do? The AED, so again, the Academy of Eating Disorder website, they have a guide. And it's free. It's just on their website. So that one's kind of a nice one. It kind of lays out some of the different tests that you might do. The APA tells us you should do a physical exam. You should do the vitals, including, their height, weight, BMI, kind of looking for physically some of those different signs that we talked about we might see. And then the laboratory assessment, kind of a pretty basic CBC, CMP, kind of looking at, I think magnesium phosphorus we would probably put in there too. And then an EKG, just looking for cardiac issues. As far as kind of our general treatment recommendations, nutrition, of course, right? So majority of our complications can be significantly improved, if not resolved, if we can get our folks to go through some refeeding. The rate at which we recommend kind of doing that restoration depends on the setting. In the inpatient world, we restore up to 4 pounds a week. If you're working on that in outpatient, you might be looking at trying to get somebody to move up a pound a week or half a pound, right? So rate is going to be significantly different. The other piece, of course, is if we have somebody that is doing some type of a behavior that we need to stop in order to really make treatment effective. It's kind of helping stop those behaviors. I mean, really, refeeding is helping stop restriction, right, which is a behavior for anorexia. But thinking about some of those other behaviors that might be happening, like the binging and purging, the exercising, the laxatives, we're going to really work to try to help slow down or stop those behaviors. It's a lot easier said than done, right? So we look at therapy is a big component of really helping these folks be able to reduce these behaviors. Sometimes we use meds, so naltrexone can help a little bit with urges for binging and purging. The only med that's really been approved from an eating disorder standpoint for binging and purging is actually fluoxetine. It doesn't get used all that much specifically for it because it's not a profound helper, but just seems to kind of be thinking about if there's anything we can do to kind of help medication-wise to decrease urges. We recommend routine follow-up labs kind of being repeated over time just to make sure we're not needing to replace some of those electrolytes or seeing any big changes in the stability. And then the other thing is as far as, how do we help these folks kind of right from the start? Eating disorders are not very commonly the sole psychiatric condition that's going on. And so I'm trying to figure out if there's anxiety or depression, getting them on a medication that might treat those conditions, and then referring. So when to refer, that's a case-by-case thing. But I did say, if we're seeing somebody getting significantly worse, that might be a time where we reach out. If somebody has to go into the hospital from a medical standpoint, chances are they're going to get referred for follow-up after that. If patient's asking, actually coming to you and saying, hey, I think I could use to talk to somebody about this, that would be a time to refer. Or just if you're feeling like you're a little bit on an island and you don't know what to do, certainly consider referring. Who do you refer to? There are eating disorder specific therapists, dietitians. You can refer to general psychiatry. And then there's our specialized programs. I'm going to have you remember or kind of write down the NEDA website. That's a good resource because that one has a list of some of the different providers in different areas, including therapists and dietitians. So that's a good resource for who can I refer to. Locally, Sanford has an eating disorder program. We have all levels of care. Minnesota, there are a couple different programs that are specific to eating disorders. And then virtually, there's a program called Equip. And so they serve really throughout areas because it's a virtual program. That's then questions and my references. Sorry, I know I got kind of rushed at the end, but that's it.
Yeah, no, that's perfect. Some of the things you covered at the end actually answered some of the questions in the chat. So that's perfect. Thank you. That was great. Thank you for the information. We do have a handful of questions in the chat, so we'll move to that portion now. One of the questions I believe was probably referencing to earlier in your presentation. It is RBC magnesium level versus regular magnesium levels.
Regular magnesium levels. Yep.
And do you recommend doing diuretics with the retention or caution due to electrolyte issues? I've always felt cautious to do diuretics, but don't want the retention to scare them back to disease exacerbation.
Yeah, that's a great question. And so, some of that a little bit probably depends on the severity of the fluid retention, but so in the hospital, I kind of reserve using diuretics for cases where I'm starting to see actual like stress on the heart. But in an outpatient setting, I think I would be a little bit more likely to say, kind of from a maintenance standpoint, that using a little bit of something like a spironolactone. I don't use Lasix because Lasix is going to flush the potassium that we're already probably worried about if there's a behavior going on that's causing some fluid retention. But something like spironolactone can actually be helpful in that case too, right? Because then it's kind of preserving the potassium. So if I do it, or if you were going to do it, I would say that it should be kind of a time limited course, and done not high doses, but done somewhere kind of on a low to mid-level dose and then tapered over time. Because remember too, sometimes we can get into a situation where then that kind of starts to play into, well, now I want to use diuretics because I like how it makes me feel because it gets some of that fluid off. And so it can even trigger a little bit of potential to kind of go after getting diuretics prescribed more often. So with caution, I would say sometimes it can be done for short periods of time.
Thank you. From a primary care perspective, what's your best approach with AN-ARFID patients as far as encouraging nutrition, being informative about potential complicants with pediatric patients? How do you counsel parents as far as their role in promoting their nutritional intake at home?
That's a good question, and that's kind of there's a lot to that, right? And so we take very much a all food is good food approach to nutrition. And so kind of looking for like a very balanced approach. Sometimes that's where it's helpful to get a dietitian involved. But I think that has to be the same message that's given, right? Because sometimes for different reasons, right, our dietitians are going to kind of educate towards, healthy eating, and we don't want to give that message to our low-weighted people. We want to help them kind of expand their variety and their outlook and their relationship with all kinds of food. As far as like parents' involvement, for us, we really reinforce that parents are in control. And so we talk a lot about like family-based treatment, and that's where parents are feeding their kids. And it sounds kind of simple, but it's surprisingly, that's a huge thing that comes up where parents are completely unaware of what their kids are doing and what they're eating and when they're eating. So kind of putting it back into the like, you eat together and your parents are dishing up your plates for you and they're telling you what your nutrition needs are. So really kind of helping parents understand the importance of their role in being heavily involved.
Great, thank you. A few more questions. With the increased use of GLP-1 medications for weight loss, are there any guidelines or recommendations to help prevent iatrogenic disordered eating behaviors? Also, any screening tools prior to initiation of these medications so where you're not potentially causing any disordered eating patterns?
Yeah, I haven't seen anything that's kind of coming, I think, right, in terms of like actual recommendations kind of coming from above, because I think we know that that's going to be a problem, but we haven't really gotten any guidance yet as to what to do. I kind of look at it a little bit like similar to what we've seen as we've had to refer patients to, like bariatric surgeries, right? When we go that route, they have to be screened and have to see a psychologist and kind of go through quite a process. And we don't have that recommendation yet. But I think it's a really good thing to have on your radar. I wish we had more info on that. And I think it will probably be something that comes. Some of it is kind of intuition, this is, if somebody seems to struggle a bit with, maybe has a history of having had an eating disorder, we're very much kind of focused on compensating and you know, I've done all of these things and I exercise a lot and just very focused on a lot of kind of compulsive behaviors that they've tried before. That might be a bit of a red flag. I think once you've started the med, if there is like a very precipitous loss and it keeps going and you're getting a lot of resistance for decreasing it, those would be things that would be very concerning. But I think this is kind of a new territory that we're going to have to really be aware of and kind of coming up with recommendations as we go.
Thank you. 2 more questions. As you mentioned, there are not always obvious signs of eating disorders. Do you recommend any routine screening tools for primary care, like the PEHQ and GADs distributed with annual wellness checks?
You know, there aren't. I mean, there isn't anything, I think, again, kind of thinking about like from above, like what's been recommended. We don't have any guidance to say that you should screen all of your patients. The scoff is though, I mean, I think if you're looking for something that's easy, and you are in an area where there are a lot of eating disorders or you have a population or you're in, you know, seeing a lot of kids and you're just kind of wanting to do something a little bit more preventative or being proactive, it is an easy one to throw in, I think. Certainly if there's any red flags, I think those would be the times to screen a little bit more closely. But I don't know that I would say that there's any evidence or an actual recommendation right now that everybody should be screened.
Great, thank you. And one final question, other medication options that you like to use for weight gain, appetite, other than Remeron for outpatient in the elderly?
That's a good question. So one thing for us to kind of remember, and so I'm assuming this is kind of elderly with an eating disorder, or maybe it's just kind of general elderly. But from an eating disorder standpoint, we don't often use medications that stimulate appetite. 1, because they're scary to our patients, right? And 2, because eating disorders aren't appetite-driven illnesses, right? And so somebody doesn't have anorexia because they don't have an appetite. It's their kind of a way of overriding that kind of gets them in trouble in the first place. So we don't routinely use appetite increasing medications for treating eating disorders. But just thinking about some of the other meds that could help kind of more just specifically with, say, an elderly person that's having difficulties with appetite, just to make sure I'm answering that question fully. Remeron is a good one, a little bit of Seroquel depending on the person, and obviously there are metabolic side effects that we have to think about with Seroquel, but Seroquel can sometimes be safely used. Periactin, I mean, we use that one in our young population, but there's really, cyproheptadine, there isn't any reason why we can't use it. That's actually a pretty good appetite stimulator, kind of across the board too. So those, I suppose, are maybe some of the ones that I would consider.
Thank you. And that concludes our Q&A portion. Thank you so much for your time and expertise today. That was a great presentation. We actually are on break now for about 30 minutes. And so we will conclude our morning sessions right now, and we will start our afternoon sessions at 12:45. For those of you interested, I am going to put in chat from our first session of the morning, the sleep hygiene talk. There is a study right now that Heidi is doing of sleep patterns for NPs. So if you'd like to take that survey, I know she'd appreciate it, and I'll pop that into chat right now. All right, see everyone back here at 12:45. Thank you, Cindy. Have a great afternoon.
Thanks, you too.
Thank you. Okay, welcome back. It is 12:45, so we are going to get started for our afternoon sessions. I just want to thank everyone who attended this morning, and for those of you maybe just logging on now for our afternoon sessions, welcome. My name is Danny, and I'm a project manager at the School of Nursing at NDSU. and I will be moderating the afternoon sessions. I will pop into chat a quick form for those of you who have filled this out already. Thank you so much. For those of you just joining the afternoon, I will need you to fill this form out. This is what HRSA requires for us for grant reporting requirements so that we can continue offering free sessions like we are today. I will also pop in the slides for the next presentation to chat in a few minutes. But first, I will introduce our next speaker back by popular demand. Thank you for joining us. Missy Hankey is board certified in internal medicine, psychiatry, and addiction medicine. She provides ongoing care to Heartview patients and medical oversight to the Medications for Opioid Use Disorder program. She also participates in interdisciplinary case reviews, develops and oversees patient medical protocols reviews, nursing assessments for appropriate withdrawal management, and confers with the interdisciplinary team regarding patient care management. Dr. Hankey serves as the medical director of the North Dakota Professional Health Program. Welcome, and I'll let you start your presentation. Thank you.
Sounds good. Thanks for having me. So we're going to talk about depression, delirium, and neurocognitive disorder, which certainly doesn't really overlap with what I do at Heartview. However, I used to, when I was at Sanford and Bismarck, I did provide psychiatric consultations in the nursing homes. And so this is very much what I did there. So I'm just trying to make sure I can switch slides. So these are just the objectives that I believe went out with the conference material. So we're just going to review the diagnostic criteria for all three of these, compare the similarities and differences in the clinical presentation, and then different treatment modalities, just to talk a little bit about that. So this is just our basic little outline. Lots of D words. I know dementia and neurocognitive disorder. There's some change in the language with the DSM-5. And so want to make sure that we kind of distinguish between that. So as I go along, we'll talk a little bit more about that. So just to start with, delirium is a mental state of confusion and disorientation that develops suddenly over hours to days. So that's really the difference between delirium and the other two, is that this is a very sudden onset. The four cardinal symptoms are, again, that acute onset and a fluctuating course. So people who are delirious will have moments where they're pretty clear, and then moments where they're definitely not clear. So when these people are in the hospital, it can be very frustrating because the nursing staff will be talking to you about how they're so disorganized and they're in and out. And then you go to see them, and maybe for those 5 minutes, they are spot on check. And you're thinking, I'm seeing something totally different than my nurses. That's actually pretty classic for delirium. They have an altered level of consciousness, which means sometimes they're pretty sleepy, pretty slurry, and other times they're agitated and awake. And they are very disorganized, unable to really follow directions or handle simple cues. This is the DSM-5 diagnostic criteria. And again, there's that disturbance in attention, develops over a short period of time. Disturbance in cognition. And basically the thing with this is that it cannot be better explained by something that they have underlying. And then there has to be evidence on the history, physical exam, or laboratory findings that this is a direct physiological consequence of another medical condition. So again, delirium doesn't exist by itself. It is typically related to substance abuse or withdrawal, some sort of medical condition, and we'll talk about all of those. So these are some of the classic causes: advanced cancer, alcohol or drugs, and it can be intoxication or a withdrawal. Dehydration, electrolyte imbalances, dementia, hospitalization, specifically if they're in the ICU, because days and nights get kind of turned around. Infections, medications, metabolic disorders, organ failure, poisoning, serious illness, severe pain, and sleep deprivation and surgeries. So this is kind of a very broad, and again, the term metabolic disorder is pretty broad, but these are the things you should think of. So there are a couple of different mnemonics. Actually, there's many mnemonics out there, and there's no one that's right and others are wrong, but these are just, if you can get these in your head and kind of think, okay, I'm going to remember pinch me as when I see someone like this, what are some things I really need to worry about? And again, certainly there's lots of overlap. The one that I learned when I was in residency was delirium. And again, it starts with drugs, right? So we want to think about illicit substances. We want to think about medications. We want to think about medication discontinuation. And then electrolyte imbalances, sodium is a pretty common one in the elderly population. Liver failure, low oxygen, infections, retention of urine or stool, any sort of intracranial pathology and an encephalopathy, a stroke, meningitis, any of those different things, uremia and metabolism. And again, there's lots of overlap between these. Just kind of pick one, and it's not all encompassing, right? There's no mention of cancer on there, but that is something also to consider. And obviously pain is one of the most common. So what are some risk factors? Being in a hospital or a nursing home, having underlying dementia. So again, as we talk about these 3Ds, delirium, dementia, depression, there is a ton of overlap. So if somebody has underlying dementia, they're at increased risk for delirium. If someone has delirium, they're at increased risk for subsequently developing a neurocognitive disorder. Any kind of a serious illness or more than one illness, an infection. And I think the classic is a urinary tract infection, right? Like, oh, grandma's doing great. And all of a sudden you go see grandma and she's talking nonsense and, left the stove on and she clearly is not in her normal state of being. Then we want to think about, maybe there's an underlying infection. Older age, recent surgeries, again, a change in medications. There are some classic medications that really impact elderly. We'll get into those a little bit. And then again, specifically opioids. So polypharmacy is something to think about when we're talking about that drug category. And then we need to look at impaired renal and hepatic function. If somebody was doing great on their medications and all of a sudden they develop a kidney failure for some unclear etiology, that is going to impact how they're metabolizing those medications, and maybe they're getting a toxic buildup. So again, drugs affecting acetylcholine, dopamine, GABA have all been implicated in this. So when I was in my training, I had an internal medicine doc who said, if you have somebody come in with a new symptom, a new onset symptom, it is a medication side effect until proven otherwise, which, I mean, that's a little bit extreme, but it has stuck with me for 25 years. And so it is important to remember that, again, somebody comes in, they were perfectly healthy, all of a sudden they have lower extremity edema. Did we change medications recently? And if we did, then let's look at that first and foremost. Same thing with delirium. If we just added a zolpidem or some other medication, gabapentin, we need to really take a look at that and make sure that's not contributing. How prevalent is delirium? It depends on who we're talking about, but hospital inpatients, 23% across the board. Postoperatively and stroke are kind of in that range. Then you start talking about palliative care and hospice. We're getting close to 90%. People who are mechanically ventilated, at least half. So depending on what the scenario is, if they're just in the hospital for something straightforward, that risk is probably minimal. But the more complicated the hospitalization, the more likely we are to see delirium. How do we prevent it? Well, you have to recognize what the risk factors are first so that you kind of have that high alert, and then screen for that. Make sure you're talking to the nursing staff. Make sure you're talking to the therapist and saying, hey, how were they today? Were they paying attention and doing all those things? We try to have a day and night, right? So that people know, yep, it's morning time, get up, put your dentures in, get yourself cleaned up, brush your teeth, all of those things we would normally do at home, we need to be trying to do in the hospital as well. Talking about bowel and bladder, diet, hopefully they're able to eat, correct those metabolic disorders, make sure they're well oxygenated, looking for infections, managing pain, getting them up and moving. Nobody does well when they're laying in a bed for 24 hours a day. And I think we've certainly done a much better job in the past 2 decades of recognizing that. And again, avoiding certain medications. When I was in my residency, I worked with a faculty who said, delirium is a consequence of too much dopamine, so we need to use dopamine blockers. So we used antipsychotics in all of these people who were delirious. it has subsequently been studied, and that has actually not been shown to affect outcome. So we do live and learn. And again, as we've become better at identifying delirium, I think we've become better about treating it, avoiding those benzodiazepines, limiting opioid pain medication if we can, reducing nocturnal disturbances so that people, again, have that awake time and that sleep time, avoiding physical restraints. Again, this has become a big push in nursing homes and hospitals. Certainly, there are times when people are a risk to themselves, but if they're just kind of agitated and fumbling with their hands, then we don't need to tie them down. And then anything we can do to promote sleep. Early mobilization, this is just kind of an abbreviated list. And if we can get devices out, get the IVs out, get the NG tubes out, those kinds of things, people just do better. How do you diagnose it? Well, there's over 50 different assessment tools that are out there, and there's not one that's better than the other. There's some that take a little more time. I really think delirium is the clinical diagnosis. I've never utilized any of these tools because, in my experience, delirium is pretty straightforward. Someone comes into the hospital, they were previously well functioning. All of a sudden, we're having behavior disturbances. They're talking nonsense. They're agitated. Their personalities are changing. They're in and out of conversations. Those are the things that are important. And when you're talking to I always think when I was in residency, we'd have the med students round, and then the residents would round, and then the staff would round. And when everybody had a different report and a different observation, then we were probably looking at a case of delirium. How do we treat it? You treat the underlying etiology. Delirium is caused by something. It does not exist as its own entity. It's delirium due to medications, due to infection, due to uncontrolled pain. It's not a standalone diagnosis. Again, antipsychotic drugs have failed to show benefit. They did some studies on what if we utilize melatonin in the hospital just to make sure people had an awake and a sleep time. There's some mixed results, definitely not clear cut. And then they've also studied looking at cholinesterase inhibitors. Are dementia meds, are these helpful? And there's no clear evidence there either. So again, the focus when treating delirium is to treat the underlying etiology. And again, do those non-pharmacological things. Get up, get dressed. When it's bedtime, go to bed. If that means kicking the families out, that's why we have visiting hours. And again, if grandma's living at home and all of a sudden she's had a change in personality and just isn't at her baseline, she needs to get in and identify that underlying cause of delirium. It's not something that typically is going to resolve on its own. So people need to get that assessed because there are complications. People fall, people aspirate. It is very distressing. If you were living independently and functioned well, and all of a sudden you're confused and not sure what's day and what's night, that's very distressing. It does impact quality of life, increases risk for depression, anxiety, PTSD. It increases short-term mortality, as well as one-year mortality and disability. So the fallout from delirium is significant. So it's not something that we really want to be dismissive of, like, oh, grandma was great last week, but gosh, this week you can really see dementia setting in. Nope, dementia doesn't set in quickly. So this is definitely not something that we want to just keep grandma at home and support her. This is something where let's get her in sooner rather than later, get her assessed, identify the cause, and get it treated so that we can really get her back to baseline and avoid some of these really unfortunate consequences. Outcomes. Typically, delirium is short-lived. It's typically days to weeks. Unfortunately, if we wait too long to assess it, or if it's, related to severe illness, uremia, things like that, it might stretch out. 20% of people will still have symptoms at 6 months. And again, really poor outcomes as far as requiring institutionalization, and precipitating more of a dementia picture. The older the person is, the more frail and the longer it lasts, the worse their outcome is going to be. And if they have underlying dementia, and we know that people with underlying dementia are at increased risk for delirium, and they don't necessarily, when we treat the delirium, get back to their previous demented baseline. So it's, as we see dementia getting worse and someone falling off, they get a case of delirium and then they might drop. who get that delirium treated, they don't necessarily get back to where they were. So again, this is just a great little graph outlining the differences. And again, delirium is an acute onset. Dementia is months to years. Of course, if there's a stroke or trauma, it might be faster, but then again, we have an etiology. Vital signs with delirium are typically abnormal. With dementia, they're typically normal. Dementia is, again, typically pretty progressive, kind of has its own trajectory. Delirium is up and down throughout the course of the day. The duration is much different. Dementia is not something that goes away. Delirium can resolve. Consciousness is altered with delirium, not necessarily with dementia. They typically are able to, pay attention especially in the mild to moderate stages of dementia. Obviously, that gets worse as we get to the severe stages, but attention with delirium is certainly impaired. They're not going to be able to participate in a 30-minute OT session because they're just going to be coming and going with their attention. Alertness is impaired with delirium. These are the people that in the hospital are sleeping in the middle of the day, even though, the family are sitting in the room. Dementia patients typically will be up and awake, again, in the mild to moderate stages. Behavior, we certainly see behaviors with dementia, and we'll talk about that. But again, if somebody didn't have behaviors last week, they're probably not going to be agitated and climbing the walls this week with dementia. There definitely is a change in behavior with delirium. Speech patterns change, and so families can typically pick up on that. If grandma lives 600 miles away, but you call her every day, and all of a sudden she's mumbling, slurring, not making any sense. That's certainly a change. We don't see that with dementia happen that quickly. What we see with dementia is people struggle to find words or name things, but generally their words make sense. They put them in a sentence that is coherent. They might not be able to come up with certain words. There are certainly psychomotor agitations with delirium. With dementia, we can certainly see that, but again, it's that progressive course. And delirium is usually reversible. Dementia is not. So if in your head you're thinking, okay, how do I know? Because this person had dementia and they were pretty stable in their dementia, and now all of a sudden in the last 3 days we've really seen a change. We probably have a delirium on top of a dementia. And dementia is just this vague general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. So typically people with early onset dementia might be doing okay-ish, and then as time passes, they're unable to really function independently. We're talking about Alzheimer's dementia, Parkinson's disease, dementia with Lewy bodies, vascular dementia, and frontotemporal. These are the most common. There are some other specifiers, and we'll talk a little bit about that. There is no one single test to diagnose dementia. You really need the full picture, the medical history, the physical exam, laboratory tests, and you definitely need family members, caregivers, other people to provide some history if you're going to make this diagnosis. There are characteristic changes in thinking, function, and behavior. And again, talking about those big five, there's significant overlap. So when I was going to the nursing homes, I didn't necessarily concern myself so much with what type are we talking about. It's more focused on treatment, quality of life issues. Alzheimer's is a pretty insidious onset, right? It's not that you wake up one day and go, oh my gosh, I can't find any words. It typically is a slow progression. Cognitive deficits decline in learning and memory is an early and predominant feature. And then there aren't really extended plateaus where it's like, oh, I lost a little bit, but now I've established a new baseline. The losses sort of keep coming in a slow progressive fashion. And two cognitive domains have to be affected, and one should be memory and learning. So when we talk about these cognitive domains, there are 6 of them. And again, I don't expect anyone to just know this off the top of their head, right? But when we talk about language, it's naming things, it's finding words, it's understanding directions. Learning and memory is being able to just have conversations about things. And if I say, here are 3 words to remember, and ask you a minute from now, that you're able to pull that out. Social cognition is just being able to like pick up on social cues, right? When we're sitting in church and someone's saying the rosary, and all of a sudden, we're shouting out to our friend across the church, that's not really picking up on those social cues. Being able to maintain attention, or being able to maintain attention to different things. Executive function is that ability to make decisions, respond to feedback. If I'm on my way to dinner and the nurse says, "Hey, I need you to come over here and take your meds," I'm able to make that decision. We certainly see that more so impacted by different kinds of dementia. And then perceptual and motor function. And this is sort of like drawing the clock, and knowing the things that we've known our whole life, and being able to pick up on that. If somebody gives us a picture of a 2-dimensional cube, we're able to pick up a cube and say, yeah, this is that, just in different dimensions. And again, different types of dementia really impact that differently. Most dementias are, in fact, Alzheimer's dementia. We really saw a spike in Alzheimer's and dementia deaths during COVID-19. There's lots of speculation as to why that was. They were not all related to COVID-19. But when we look at how social lives were impacted and routines were impacted during COVID-19, especially in our nursing home population, that probably contributed. Almost 2/3 of Americans with Alzheimer's are actually women. Some of that is because women do have a longer life expectancy, and older Black Americans are about twice as likely to have dementia as older white Americans. So again, just knowing those differences, and that doesn't mean that, if you're seeing someone who is Black, that they're definitely, not delirious. They could still be delirious, but again, they are just at increased risk of that underlying dementia. The greatest risk factor for Alzheimer's is age. And then family history is also significant, of course. And then head injuries. In recent years, there's been a big push to look at traumatic brain injuries, concussions, all of those things. And that is definitely significant. Again, the NFL has sort of made it a push, but something to always think about in our patients that have had major head injuries. If they get to be in their 40s and 50s and start having some cognitive concerns, something to think about. Vascular dementia is the second most common cause. Again, occurs due to microscopic bleeding and blood vessel disease in the brain. The risk increases if you have heart disease, blood vessel disease, sort of that vascular path, right? Somebody that says, geez, my feet are bothering me more. Anytime someone has vascular concerns, we want to look at their risk factors: diabetes, stroke, hypertension, high cholesterol, all of those things, because that is really what we're going to focus on with vascular dementia, is more of that preventive piece, is how do we manage those risk factors so that they don't end up going that route. This does often coexist with other dementias, specifically Alzheimer's. On brain imaging, there should be some gross indications that they've had affected tissue. Again, no medication specifically approved for this, and treatment is just focused on those underlying risk factors. Let's get your A1C managed. Let's get your blood pressure where it should be. Let's get your LDL down and try to maximize HDL. All of those things to prevent it from happening, because once we start knocking out little pieces of our brain does not heal well. Parkinson's disease dementia. If somebody has Parkinson's and then a year or more after that onset they develop dementia, then that's going to be your Parkinson's disease dementia, right? Like the Parkinson's, that pill rolling tremor, that predates the onset of the dementia. Dementia with Lewy bodies is, again, a little bit different. This is when the dementia starts first, and then they develop the Parkinson's. One of the things clinically that you can notice is if these people are exposed to neuroleptic drugs, they're very, very sensitive to that, and they're much more likely to develop neuroleptic malignant syndrome. So again, don't love the antipsychotics in anyone who has Parkinsonism. If they're already having those symptoms, giving them neuroleptics is going to increase their risk of having side effects. So in this particular population, though, there's a significant risk. the criteria for diagnosing dementia with Lewy bodies, they have to have two of these core symptoms: visual hallucinations, Parkinsonism, cognitive fluctuations or agitation, and then rapid eye movement sleep behavior disorder, which is basically during REM sleep, when we should be very still, they're very agitated and they're acting out their dreams. So somebody who has typically been a good sleeper and all of a sudden spouse or children or caregivers are saying, oh my gosh, in the middle of the night, there's thrashing and yelling and kicking and all of these things, then we need to look at that rapid eye movement sleep behavior disorder. So if they have more than two of those, you can look at a dementia with Lewy bodies. Other things that are prominent with this one is orthostatic hypotension, delusions, excessive daytime sedation. And sometimes we kind of chalk that up to, well, gosh, they're not sleeping well, so they're probably more tired during the day. That might be contributing as well. And then anxiety and depression are more prominent with dementia with Lewy bodies. Again, sort of that crossover. Early changes in attention and executive function rather than learning and memory. So more struggling with decision making, planning, and paying attention. That Pentagon copying test, they perform worse on that. And then again, that's sort of the visual processing, right? If I'm going to draw a clock, I'm going to struggle more with this. And then at autopsy, most people with dementia with Lewy bodies show signs of concomitant Alzheimer's disease. So lots of crossover again. Frontotemporal dementia is the symptoms are more in social cognition and executive abilities. So they tend to do okay with learning and memory, but lots more behaviors. I mean, these are the ones that walking through a restaurant, they might just, grab someone's drink and help themselves. So it can be still a pretty insidious onset, but there can be some just prominent declines that happen with their personality and language. So again, this one is more behavioral, and sometimes families don't necessarily recognize it because again, they're still able to learn and process and have conversations, but they're sort of disinhibited and almost more embarrassing. So families will say, I don't know why she's so embarrassing. She's never acted like this before, but she's not, she still does okay in like daily functions, but she's just so embarrassing. Then we want to look at more of a frontotemporal dementia. Socially inappropriate, impulsive, lack of interest, don't necessarily want to take care of myself anymore. And there can be some sort of compulsive behaviors. So when people say, I think she has OCD because she's just so weird about the locks and she's weird about how she does things, that's pretty prominent frontotemporal. And then ultimately they may lose the ability to use language properly. Frontotemporal tends to hit people a little bit younger. So sometimes people kind of talk it up, oh gosh, as dad gets closer to retirement, he's just a little more eccentric and a little bit more inappropriate. It's almost like he thinks he can say anything now. That should be red flags. Disinhibition, there can be apathy or just total disengagement. Really lack of effort as far as following directions can be really stubborn. Loss of sympathy or empathy. Again, it becomes all about me. And then some of those ritualistic behaviors and stereotypies, and can be very hyperfixated with their oral behaviors, and then some dietary changes. So again, these ones are the ones that are kind of just odd, and the families are saying, I don't know what happened. Like all of us, like the older he gets, the stranger he gets, and he just doesn't care what people think or say. That's what we need to think about here. So how do we treat dementias? Well, the acetylcholinesterase inhibitors are the mainstay of treatment. Memantine is additive in moderate to severe dementia. Again, as we get to the later stages of dementia, there might be additional efficacy to combine these. Looking at vitamin E and other medical foods, there isn't great evidence, and there actually might be some risks. So why do we use acetylcholinesterase inhibitors? Because we lose cholinergic neurons from the nucleus basalis of Maynard. It's an early pathologic finding in Alzheimer's disease. So if we can inhibit that acetylcholinesterase, it prolongs the action of that endogenous acetylcholine. We're talking about ribostigmine, donepezil, and galantamine are the three that we use most prominently. And again, there's consistent benefit across all stages. When we're talking about mild cognitive impairment, though, sort of thinking, okay, we're starting to see some decline, let's use these meds and try to head it off at the pass. The benefit has not really been shown clinically, but there's also not necessarily any risk. So it's one of those where you just have that conversation of, yeah, we're starting to see the early signs. This might just be mild cognitive impairment. It might be early dementia. The meds aren't super helpful at this stage, but they also haven't really been shown to have a negative consequence. GI side effects are really common with this class of meds. Nausea, vomiting, diarrhea, loss of appetite. For people who are lower body weight, they tend to have more of these symptoms. And as you get to higher doses, you do see more of it as well. But typically, aside from the GI stuff, these meds are pretty well tolerated, and one hasn't necessarily been shown to be better than another. So it's not like galantamine is better than donepezil. So it might come down to insurance. It might come down to compliance, right? Whether we're doing BID dosing or QID dosing, whether we need a patch, all of those things should be taken into consideration. The American Geriatric Society says be cautious in using these meds. And if you try it for 12 weeks or so and you don't get any benefit, discontinue it, which I think, a lot of times people get to that nursing home stage, they get started on a med like this, and then we just have this tendency to keep them on it. And so I always found when I was doing consultations, there came a time where, the person was in that really agitated, yucky stage of dementia where they were didn't really recognize their family, but they knew something was wrong. That was a time when I would try to stop these medications because we just need to get past this agitated stage of the dementia into that next stage. We're not likely getting a lot of benefit from the meds anymore. So when utilizing these meds, it doesn't mean it's a lifelong commitment to them. If you start it, all they have is GI side effects and they don't really get any benefit, consider discontinuing them. So again, donepezil was approved in 1996. It's been around a long time. There are benefits compared to placebo in terms of cognition as well as ADLs and global assessments. Not necessarily consistent benefit and quality of life. And so before starting these meds, to try to find out what someone's goals are. Is quality of life their most important thing? Then utilizing these meds may not be helpful. And again, the higher dose of donepezil showed statistically significant benefit, but certainly had more GI side effects. Rivastigmine was FDA approved just a few years later. There's a couple of different cholinesterases that it impacts, and it does come in a transdermal formulation, which is nice if somebody is struggling to take a medication or they're having issues with swallowing or it's just always a battle. The half-life is short, but the duration of clinical benefit is a little bit longer. So if you are using the oral, it is a twice daily medication. And again, shows benefits in cognition, ADLs, and global assessments compared to placebo. Galantamine is the last one. Again, competitive inhibitor of that acetylcholinesterase. It is an immediate and an extended release oral formulation. And it did show an increase in all-cause mortality for mild cognitive impairment. So again, that idea that, okay, this might be MCI or it might be dementia, but let's just use one of these meds, there might be risk with that. And no additional cognitive benefit was shown above 16 milligrams. So that's the 3 medications. What if we decide to stop them? Well, there is a risk, right? So if we stop these meds, we do increase the risk that they will be placed within that first year. And again, there is additional deterioration. So we know dementia is a progressive disease and there is that agitated state. And so sometimes prolonging that doesn't necessarily feel good for families or providers. So sometimes stopping medications there kind of to get them to that next stage of their dementia. And again, if somebody is institutionalized and they have psychosis, when we stop these meds, we might get worsening of those symptoms. So just know that ahead of time so that you can prepare the families, prepare the caregivers for that. Memantine is an NMDA receptor antagonist. definitely has a clear but modest benefit on global impression, cognition, and ADLs in that moderate to severe Alzheimer's. In mild Alzheimer's, there's probably no improvement over placebo. So again, that idea that, okay, we're in the early stages, let's just hit it with everything we have, doesn't necessarily change outcomes. The benefit of adding memantine to acetylcholinesterase inhibitors has been studied with mixed results. There is a cognitive benefit once we get to that moderate to severe. And again, people with mild to moderate Alzheimer's did not show enough cognitive benefit to be statistically significant, which is why it is not indicated in that mild stage. What about vitamin E, right? So I've now been around long enough that I get to talk about like the sort of massive mistakes that we've made. So there was a time where there was people said, yeah, vitamin E is super helpful. So we were doing this like high doses of vitamin E, and actually that was later shown to increase risk of hemorrhagic stroke, prostate cancer, heart failure, and overall mortality. So there was a big meta-analysis done which showed no benefit overall for cognition. So not something that we do anymore. What about fish oil? It's a component of membrane phospholipids in the brain, and it has some antioxidant effects. But again, a big meta-analysis showed no benefit on cognition or any other outcome relevant for mild or moderate. So fish oil tablets, I don't know if you guys have ever taken a fish oil tablet. They are massively huge. They taste disgusting. So if somebody's having trouble swallowing, this is probably not a battle that you want to fight because it's not like you're going to, squeeze it into their yogurt. So again, the benefits haven't really been shown, at least for cognition. So it might not be worth the fight. And again, the anti-amyloid monoclonal antibodies, the studies are ongoing, but so far have not really been successful. So again, now talking about neurocognitive disorders, and again, I said they're sort of used interchangeably. So neurocognitive disorders, this is specific to the DSM-5. This is the language that the DSM-5 people put into place. It does not mean that the term dementia went away. It's just this is like an umbrella for delirium, mild cognitive impairment, and dementia. So neurocognitive disorders come in the mild or the major category. And basically, it's characterized by a decline from a previously attained level of cognitive functioning. So I remember when the DSM-5 first came out, and I was like, "Oh, what happened to dementia?" It's still there. It's just one of the categories under these neurocognitive disorders. Again, mild cognitive impairment is just sort of a synonym for mild neurocognitive disorder. It's memory changes that exceed criteria for normal aging, but they don't meet criteria for dementia. So they know there's something wrong. Subjectively, it's like, man, I am just really struggling with word finding, or I feel like I lose my keys more often. And their families and caregivers are saying, yeah, we notice it too, but she's still good at home. Like she's still able to manage. It's just like little things, I might not pay the bill. I stuck it to my cork board, but I never did get that paid. MCI might be an early stage of dementia, but it might not. And again, the difference with mild neurocognitive disorder and major is that they're still able to function independently. They might need a little more help, might need a little more cues, but they're not to the point where you're going, you're not safe at home. So that's the difference. And again, can be an early stage of dementia or can exist in and of itself. Just to review those cognitive domains: learning and memory, language, complex attention, executive function, social cognition, and visual spatial function. So just again, I don't expect anyone to memorize those, but just to understand that when we're talking about cognitive domains, it's not just language. It's not just learning and memory. It might be just an ability to make decisions or to plan a day, right? If I have someone coming for lunch tomorrow and I have no idea how I'm supposed to do that, that's a real problem. But even if I can still find words, right? So again, to diagnose mild cognitive impairment, you really need to have a standardized assessment. These are just a few of them that I found: the MOCA, SLUMS, and the MMSE. When I was in my training, we only had the MMSE, and we'll just talk about a few of the differences there. The MOCA is a 30-point questionnaire. They all actually are. It takes about 10 minutes. It's actually designed to detect mild cognitive impairment, and it does take into account educational level. So if you have someone that finished 8th grade and you give them the mini mental stats exam, and then you have someone who is a professor of language, there needs to be a little bit of a different consideration for their education level. The cutoff score here is 25 or 26. It's very sensitive for MCI and also fairly specific. The MMSE, again, 30-point questionnaire, cutoff score of 27 or 28, not super sensitive. And again, in people who are poorly educated, it's going to overestimate their dysfunction. And in someone who's highly educated, it might underestimate it. So it's not great in that regard. And it's also copyrighted. So that can be a problem in that technically you should pay for it, though I don't know that I ever did. Maybe I shouldn't say that out loud, but pretty sure I never paid for it. The SLUMS is again a different one, and it's more sensitive to detect defects in executive function. It is better validated than the MMSE for detecting MCI, and it does take into account educational level, and it is free to use, which is great. So how do we work up MCI? Again, there's no definitive screening test. You can give them the MOCA, you can give them the SLUMS, and it might kind of tell you where you're at. And then you just need to do some digging and make sure that there's not a thyroid problem or a B12 deficiency or something else underlying that's just causing some cognitive impairment. Typical screening tests: CBC, thyroid, B12, folate, metabolic panel. And then if you're really thinking about HIV, syphilis, Hep C, Hep B, Lyme disease, then really go down that pathway. The other thing is, if you're thinking, God, this could be normal pressure hydrocephalus, or they just have had some significant head injuries. What if we have just a chronic subdural hematoma? Then you want to do some imaging exams. How do we manage it? Well, treat reversible causes if you can find them. Again, addressing those vascular risk factors, the diabetes, the hypertension, the high cholesterol, substance use disorders. It's interesting. I work with the professional health program, and we work with docs and PAs who have underlying substance use disorders. A lot of the treatment centers we send them to do cognitive testing, and a lot of people, when they are in the throes of their substance use, have cognitive impairment that will resolve with some sobriety. So I was not aware in my training how significant an alcohol use disorder could be for someone's cognitive impairment. I certainly understood when they were impaired and when they were going through withdrawal, but I didn't realize that even 60 days later, they would not return to their baseline. It takes up to 6 months. So to ask those questions: how much are you drinking? Are you a weekend warrior when it comes to cocaine? Those are real things. I don't think we have any idea how much cannabis is going to affect cognition in the long term. So as we move forward in the coming decades and we're seeing more cannabis use and it's legalized, we probably need to really do a deep dive into how is that going to affect people's cognition long term. Does that contribute to MCI? We know it contributes to other psychiatric comorbidities. So again, to ask those questions. Medications for Alzheimer's disease are not effective in reducing MCI's progression to dementia. Resistance training exercise twice weekly. So when people say, but what am I supposed to do? Like, you just told me the medications don't help and fish oil is maybe not a thing. What am I supposed to do? Well, this is where we talk about doing some Sudoku and cognitively stimulating activities, getting regular exercise. It's not just for our heart and our lungs, it's for our brains as well. Make sure that they can see well, that they can hear well, that they're able to get around their home safely. All of those things, anything that's going to impact someone's ability to be social is going to impact their cognition as we get older. This is the diagnostic criteria for mild neurocognitive disorder. And the focus, again, they're still able to live independently. There just is a decline in their previous level of functioning. Okay. What are some risk factors? Well, non-modifiable are age. I mean, as every day passes, we do get a day older. Men are more at risk, family history, and again, the presence of that lipoprotein E allele, which is associated with familial Alzheimer's. That is a non-modifiable risk factor. I tell my kids all the time, sorry, but you didn't get to pick your gene pool. You just got what you got. Modifiable risk factors: hypertension, hyperlipidemia, coronary artery disease, stroke, osteoarthritis, COPD, diabetes, and polypharmacy. We see a lot as we age. We just keep adding meds and adding meds and adding meds. And we really do need to make a concerted effort every year or two to really look at those lists and go, do we still need this on here? Do we still need to have this on here? And as we're getting older, should we be looking at different meds? The Beers list is that big list out there about the meds we should use with caution in the elderly. Something to think about if somebody's been on paroxetine for 15 years and has done well, but as they're getting older, is that still really the medication that we want to keep them on? Opioids, benzos, the Z drugs. Again, the Z drugs were never designed to be chronic medications. They were not. When somebody got put on Zolpidem, it was not supposed to be from now until all eternity. So really looking at different things to help people sleep and relax. Most over-the-counter sleep aids are actually antihistamines. Is that a good idea as we get older? Because we know they contribute to constipation and urinary retention and all of those things that we talked about when we were talking about delirium. Antiepileptics, do we need to look at adjusting dosages because of renal changes, liver changes, all of those things? Muscle relaxants should be used with caution, and drug-drug interactions should always be considered. We need to really do a thorough history when someone comes in and they, oh, well, doc, it's all in Epic. You know all my meds. It's all in there. It's in my chart. Okay, but what are you taking that you bought at CVS? Because that's not going to be in there. Did you start taking some sort of an immune modulator? Did you start taking something over the counter that you heard about on NPR? Like, we need to know all of those medications because we need to know how they're going to interact with other things. Reversible medical etiologies, again, hypothyroidism, B12 deficiency, dehydration. As we get older, we get less good about drinking water because all of a sudden I might have more incontinence. And so I don't want to drink water, or my knee really bothers me. So I don't like having to get up and to go to the bathroom. So I'm going to drink less water. Those are all real things that we need to be talking to people about. Blood sugars, UTIs, again, to go back to the UTI. And I just had this conversation with my mother-in-law last week. She was diagnosed with the UTI. I said, how much water are you drinking? She said, absolutely none, because it hurts when I pee. Perfect. Not the plan that we should be going with. But I also understand that it's very uncomfortable. And I said, well, just run a bath and pee in there, because you have to be drinking water, because you're just going to have more problems. Normal pressure hydrocephalus, the triad is ataxic gait, urinary incontinence, and cognitive impairment. So if someone is coming in for the first time and they're like, geez, all of a sudden I feel like falling and I'm kind of slipping cognitively and I'm having trouble with urinary incontinence, NPH is a diagnosis that needs to be considered. And obstructive sleep apnea, if we're not able to rest and we have that daytime somnolence, those things contribute to cognitive impairment as well. Protective factors: higher education, being bilingual, cognitively stimulating activities, a healthy diet like the Mediterranean diet, physical activity, stop smoking. I'm always really hesitant to say mild to moderate alcohol consumption, because there really is no magic formula for how much alcohol is good for us and how much is bad for us. So I always really caution people with that. Maybe a glass of red wine is good, but I also think most of us, when we fill a glass of wine, we fill it a little bit fuller than it was designed to be. So I don't encourage people to drink alcohol, but if they say, well, I have, 4 ounces of red wine every night with my dinner, okay, it's probably all right. But our In North Dakota, our ideas of moderate alcohol consumption is different than the rest of the world. We lead the nation in binge drinking. Some people think a 6-pack is moderate alcohol consumption. It is not. So that one I'm very cautious about. And then make sure people are being social. Holing up in our homes is not good for anyone. So if you're talking to someone and they have stopped going to church and they no longer do their book club and those things, that is a real problem cognitively, and we need to be talking to them about that. This is the diagnostic criteria for major neurocognitive disorder. And again, this is the point where we really see an inability to function independently. There can be behavior disturbances or not. It cannot be better explained by delirium or another mental disorder. So if they were doing fine before and all of a sudden they're not, then that's delirium. If it was really a slow progression and the family says, geez, the last 3 years, since dad died, we've really seen mom go downhill, but it's not been dramatic. But now this year when we came home for Christmas, we really noticed that she probably shouldn't be living alone. Then that's going to be a major neurocognitive disorder. Again, there are subtypes. So when we're talking about these subtypes, you can have major neurocognitive disorder due to Alzheimer's, frontotemporal, HIV, Huntington's disease, Lewy body, Parkinson's, prion disease, related to a substance use disorder, a TBI, vascular disease, other medical etiologies and multiple etiologies, right? They might have multiple things, and then just the unspecified. So when you're talking about a major neurocognitive disorder, these are the subtypes that you're going to look at. So dementia still exists. It's just a subtype of major neurocognitive disorder. Lastly, I just want to talk about late life depression. And again, I'm focusing on late life because the purpose of this talk was to look at delirium, dementia, and late life and depression. And so I'm not going to talk about depression in a 20-year-old because that's not in the same category of differentials for dementia or delirium. Typical presentation is a lot of somatic symptoms. I mean, they're not going to come in and say, "Oh, I'm just so sad," because for a lot of our elderly, they're not even going to identify that. But they might just say, geez, I just have a lot of aches and pains, and I'm tired a lot. It is a risk factor and a predictor of a poor prognosis. Can be precipitated and perpetuated by chronic medical conditions. So what that basically means is if all of a sudden I have a congestive heart failure, that might precipitate a late life depressive episode. But it also just might make it worse, right? I had underlying depression and now I've got this congestive heart failure. And so now it's worse again. Mild cognitive impairment, as well as smoking, mobility issues, vision, hearing, subjective memory impairments, all increase our risk of depression. I cannot stress enough, if people don't hear or they don't see or they don't leave their house, all of those things are bad for their cognition, their quality of life, their moods. It all impacts. So when people say, oh, I just don't want to deal with a hearing aid. They're so cumbersome. And my grandma had one and it always whistled and I just don't want to deal with it. Okay, but you stopped doing the things you wanted to do because when you were around your friends, you didn't know what anyone was saying. Then we have to talk about that. Characterized by, again, the cognitive deficits. When we're talking about a differential with delirium, dementia, and depression, the cognitive deficits tend to be in that executive functioning where I don't know how to fix this. Like I have all these things to do in my house and it's so overwhelming. So I'm just going to not do it. Right. That's what we see with depression. I don't want to go buy groceries because I can't decide what I want to make this week. So I'm just not going to do it. I'm just probably going to have toast, right? Buttered toast is not a meal. But you certainly hear from a lot of people as they age that, oh, I just have toast for breakfast and sometimes like a bologna sandwich for lunch. And some of that is because they just can't make a decision on what to have. Impaired attention and then some memory impairment as well. The relationship between late life depression and cognitive decline is very complex. They look the same, they coexist, and they're mutually a risk factor for each other. So when someone is telling you, my brain just doesn't work as well as it used to, you have to ask the depressive symptoms. And again, don't ask, do you feel sad? Do you cry? That generation is probably not going to answer those questions in a way that is helpful for your assessment. when we're talking about older adults versus younger adults, anhedonia is more prominent in older adults. They just don't want to do anything. It's not as fun as it used to be. And they might say, well, that's because my back hurts and I don't want to go sit in a pew at church because it makes my back hurt. But there might be more to it than that. They typically lose their appetite. They don't sleep as well. They have physical tiring, lack of energy, again, more cognitive deficits. When we're talking about younger adults, they might say, I can't focus on things. I try to read a book and I can't focus. I don't know, maybe I have ADHD. Well, if you didn't have ADHD before, you didn't develop it at 32. So more of the cognitive deficit, and then a lot of GI complaints. I could just kind of, I don't feel like eating. I have more diarrhea. I think maybe it's reflux. I don't know. My tummy just hurts all the time. And then the psychomotor slowing. Whereas in younger adults, there's more of an anxious component. As we get older, everything just kind of lax, right? Like I just don't want to do it. My energy is low. I don't want to eat. I can't sleep. I can't think. I can't read a book. Nothing's fun anymore. How prevalent is it? Well, the older we get, the more prevalent it is. And if we live in an institution, a nursing home or someplace like that, almost half of those people will have some late life depression because a lot of it is they don't operate their own routine anymore, right? You eat breakfast when we say it's time for breakfast, and then you're going to go to bingo when we say it's time to go to bingo. As we lose that control and that ability to do those things, depression becomes more prominent. So what are some risk and protective factors? Being female is a risk factor. Heart disease, digestive problems, respiratory disorders, incontinence, sleep disorders, being unable to hear. And as I look at these risk factors, it's like all of those things impair our ability to be social, right? If I have digestive problems and I'm going to get diarrhea, I don't want to really go out with my friends because the bathroom might be 50 feet away and that's a really long walk. What if I don't get there? Same with incontinence. If I can't hear, I don't want to meet my friends at a restaurant because I can't keep up with the conversation. What about what's protective? Being resilient, being an extrovert, knowing that you do better when you're around people is good. Positive self-perception of aging. So if you're that person that's like, gosh, aging's not terrible, it beats the alternative. Those people tend to do better in regards to depression, having positive coping strategies, hobbies, having some sort of a religious foundation or a spiritual foundation has been shown to be protective, and then just being more physically active. If you lose your social and your support network and you isolate and your family is kind of hands off, you lose your spouse, all of those things are risk factors. So if you're talking to patients and gosh, their grandkids just graduated from high school and moved away, and they typically went to all of their activities, and then their spouse got sick, those are people that you really want to be screening for depressive symptoms. Self-report scales should be avoided. They're not typically accurate in this generation because they're not going to tell you that they're sad because they think that that's a weakness, and they're not really sad. They're more apathetic. Talking to family is absolutely crucial, or friends. If they don't have family, but there's somebody that they have coffee with every morning, that McDonald's crowd, if you can get a hold of the guy that they have coffee with every morning, he might be able to give you some really useful information. A multi-dimensional assessment. So the history exam, maybe lab tests, maybe imaging, just to make sure that there's not a reversible etiology here. Why is it hard to diagnose it? Because a lot of people say, well, gosh, I buried my parents, half of my siblings, my spouse, my children are getting older, my grandkids have left, I never hear from them. Yeah, I probably am depressed, but isn't everybody that's my age? Actually, no. Depression is not normal. Grief is normal, right? We lose a lot of people. We lose a lot of function. There's a lot of stigma around depression. I don't want to tell my doctor I'm depressed. What are they going to do for me anyway? They don't really want to talk about their moods. And there is a lot of overlap. If they're coming in complaining of pain and GI discomfort and low energy, we might think that that's something else. Again, we need to be screening for depression. How do we treat it? Well, they don't necessarily respond to antidepressants as well. When we're looking at meds, we need to think about their kidney and their liver function. We need to look at how did they respond to treatment in the past? How did their family members respond? SSRIs and SNRIs are considered first line, but again, paroxetine has increased anticholinergic effects. Fluoxetine has a ridiculously long half-life, and so might not be first line as well. Side effects, if we're going to start someone on these meds, we need to talk to them about the GI side effects because they might already be having those, can contribute to some GI bleeding and some hyponatremia. Vortioxetine is it's a serotonin modulator, and there's some really good data that for cognitive effects, this has been shown superior, SSRIs and SNRIs in small studies. So that might be something to consider, but then you're going to have to battle with insurance companies. But hopefully that gets better with time, right? Antipsychotics used with caution, and psychotherapy can be very beneficial. So to talk to people about those kinds of things. Lastly, this is going to be very brief because I know I'm running out of time. I just saw Danny pop on the camera. This used to be called pseudo-dementia. And it's basically a psychiatric condition that masquerades as a neurodegenerative disease, but it's reversible if the psychiatric condition is treated. Not a formal diagnosis. This doesn't live in any DSM. Again, it can overlap with dementia. It also increases your risk for dementia, but your onset is much more rapid. Again, it's not a delirium because you don't have the attention and the behavior disturbances, but it's kind of like it came on pretty suddenly. And they typically have pretty good insight that, man, 3 months ago, I could do Sudoku and now I'm really struggling. And they just do a little bit better when you're testing their cognition if you give them cues, whereas people with dementia typically don't respond as well. So our take-home points, the 3Ds, they all coexist. They all increase the risk for each other. They all affect quality of life as well as morbidity and mortality. We really need to involve families and caregivers in the discussion because you have to have good history. Timelines are crucial. Always review the medication list, including over the counter. Always look at drug-drug interactions. Call your pharmacy. Find out what they're filling from other providers. We do have providers in private practice, and so call the pharmacy. And these are high-risk patients that need frequent follow-up. If you're going to diagnose someone with mild cognitive impairment, that's someone you need to be seeing on a regular basis. So sorry for the really rapid fire ending, but.
No, it was really, really good presentation. Thank you, Missy. We do have a few questions in chat, so we'll move to those right now. The first question is, what medications do you like to use in the elderly for behaviors, dementia, Alzheimer's, daily, and PRN?
Sure. So I am a firm believer in sleep, and I think that if somebody is up all night long, they are going to have more agitation and anxiety during the day. Mirtazapine was one that I really liked in the nursing home population. It tends to stimulate appetite as well as help them with sleep. So that was one that I would use pretty frequently. It can help with agitation. Even in young people, if we don't sleep well, we tend to be more anxious. When we're young and anxious, we don't necessarily get agitated, but when we're older and anxious, we tend to get more agitated, especially when people are always trying to tell us what to do and where to go. So mirtazapine is one that I do like in that population. It is always tricky though. There is a time and a place for the antipsychotics in people with severe dementia as far as if they are a risk to themselves or someone else. That is the time where I start to look at something like olanzapine. Quetiapine does have a lot of orthostatic effects. However, what I like about quetiapine is that you can give teeny tiny doses, like 12.5 milligrams. And sometimes that's enough to kind of take the edge off. Certainly you want to avoid the older neuroleptics, the haloperidol, avoid the antihistamines, the benzos, and, sometimes like a valproic acid might be enough to just take a little bit of the anxiety down. Yeah, there's no magic wand. I'm a firm believer in these start as low as you can and go extremely slow because you don't want to increase someone's risk for falling, and you don't want to cause urinary retention or constipation, any of those things. So it's a it's a very fine line. I wish I had a drug that I'm like, this is the one everyone should have, but I don't. But I did love mirtazapine in the nursing home population. They eat a little bit better, they sleep a little bit better.
Perfect. Thank you. Next question. Do you use research on low dose lithium preventative support?
I've always been very cautious about lithium, and I'm just gonna actually pull up the chat so I can see if I can read that question. I'm not sure I totally understand the question. Can you say it again, Danny?
It says, do you use research on low dose lithium preventative support?
Not familiar with that. Nope. But if somebody like wants to reach out to me, I'm happy to share my email in the chat, and I'm just going to type it in there now. So if you want to shoot me an email, please feel free.
Okay. One of the other questions is, have you ever had much experience with Rexulti, Rexulti?
So I've not been going to the nursing homes for a few years now, and that one was kind of just coming out. It has great data. I don't have any clinical experience with it, but I'm always very cautious about using the data that I get from the pharmaceutical reps, but Rexulti does have some really good studies out there now. Couldn't find any like meta-analysis, but it is one that, like the vortioxetine, where there's some new data coming out that says it might be a game changer. When I was trying to use Rexulti in the nursing homes, nobody would cover it because it was too new. But I think that dynamic has changed. So I don't have any personal experience on it, no.
In a hospital setting for aggressive behaviors that pose safety risks, is olanzapine the only medication you'd recommend for the elderly dementia population?
The nice thing about olanzapine is that you can give it as an injection, which is traumatic. And I'm not saying that should be our go-to, but it is nice if somebody is super agitated and you can't get them to take a medication. I do think that one offers some benefits, but it is a very potent neuroleptic. And so understand that if somebody gets olanzapine, they may be out for an extended period of time. I'm much more a fan of the non-pharmacologic options. However, if it gets to the point where they are, a risk to themselves or others, I do think we have to sometimes go the route of neuroleptics. And if they're able to take oral, I would use a lot of risperidone when I was working at Stanford because wasn't quite as sedating. The problem with giving someone olanzapine in the middle of the day is they're then going to sleep. But then when it's time for bed, they're not tired because they've been sleeping all day. So you don't want to get into that vicious cycle either. So sometimes if you can use something that just takes the edge off, but they're able to stay awake, and that way we can really focus on that sleep-wake cycle. So, but I know in the emergency room, they use a lot of olanzapine. Again, if someone is actually a threat to themselves or others, you have to do what you have to do and you have to be aggressive. And olanzapine is probably the go-to for that.
Great. Okay, one final question. If you pull up the Q&A, Missy, there's kind of an example of the patient in there, and I don't know if I'll pronounce the second med correctly, but advice for treatment for someone with dementia with psychosis, aggressive, irritable, angry, Zyprexa or Qutipin, off-label treatments, avoid benzos.
Right. So in their 50s, history of alcohol abuse and adverse childhood events, currently on quetiapine at a pretty big dose. And and then advised to add olanzapine 5 milligrams. So I would always be very cautious in doubling up. That's a pharmacy duplication, right? Quetiapine and olanzapine are in the same family of meds. I would certainly avoid benzodiazepines. Oh, it went away. Certainly avoid the benzodiazepines. And I do think if the person is that agitated, they're in their 50s, it looked like. So still has some physical strength about them. To if you're doing 300 BID of quetiapine, that is a pretty big dose. I would probably cross taper and try olanzapine or something else. If you're not getting benefit from the quetiapine at that big of a dose, I would absolutely consider something like olanzapine. Keep in mind that if someone is a smoker, you're going to need higher doses of olanzapine. So I don't know if this person is allowed to smoke or not, but that is something to consider. There unfortunately isn't a great option in that agitated population. Sometimes you can get benefit from something like valproic acid. In someone who has a history of an alcohol use disorder, sometimes medications like gabapentin can be really useful. And I can't exactly explain why. I just know that it sort of satisfies that feeling without them being impaired. So gabapentin might be an option. And again, with gabapentin, you can start at a very low dose and see if you can't just take some of that edginess off. It might also help with some underlying pain. With alcohol use disorder, we do get a lot of neuropathies and neuropathic pain that we don't always think about. So to utilize a gabapentin in someone with that history, you might be able to take some of that edginess off without them being really over medicated. So that might be a consideration, and that would not be a pharmacy duplication. And then in the elderly with Risperdal, I would always start, like 1/4 milligram twice a day, or 1/4 milligram in the morning, 1/2 milligram at night. You can titrate it if they have bipolar and they're in a manic episode, then you're going to need to use bigger doses. But if they just have an underlying history of bipolar, but are pretty stable at the moment, and you're thinking about maybe I should get them off lithium, or, I just want to they have some thought disturbance that's going on, and I want to use an antipsychotic medication, I would start at that 0.25 or 0.5 really low doses with that crowd.
Thank you. That concludes the Q&A. As usual, thank you so much for your expertise and time today. That was a great presentation. We will take a short 4-minute break right now, and we'll come back at 2 o'clock with our next afternoon session. Thank you. Have a good weekend, Missy.
You too. Thanks.
Okay, welcome back, everyone. It is the 2 o'clock hour, so we're going to get started with our next speaker. Lisa Schock earned her Bachelor's of Science and Medical degrees from the University of North Dakota, where she also completed her general psychiatry residency. She is a board-certified psychiatrist currently working as an inpatient psychiatrist at Prairie St. John's Hospital in Fargo. She also serves as a clerkship director and associate residency program director for the University of North Dakota School of Medicine. Her clinical interests include treatment-resistant mood disorders, complex psychiatric comorbidities, and neuromodulation. Welcome, and I'll let you start.
Great, thanks for having me. So ketamine is a really intriguing topic and something that is constantly evolving, and even as I'm putting this presentation together, there's new and exciting things coming down the pipeline. So hopefully this gives some background about where ketamine is at in psychiatry right now, because we're gonna have to keep up with all the things that are coming forward for ketamine. I do not have any conflicts of interest or disclosures. So by the end of this presentation, my hope is that you guys have an understanding of ketamine's proposed mechanism in the treatment of psychiatric illnesses, that you can identify evidence-based applications for ketamine therapy in psychiatric illnesses, and have some perspective about the potential problems and pitfalls that can come with ketamine therapy. So starting out with the scope of the problem, why are we using things like anesthetics that are many, many decades old to treat psychiatric illnesses? It has to do with the ugly treatment-resistant nature of a lot of the illnesses that we encounter. And one of the big things that we'll talk about is depression. Treatment resistance in depression is common. Our best is not good enough. Our treatment goal for major depressive disorder should be remission. When a patient reaches remission, their chances of having future episodes go down considerably. The chances of this becoming a persistent depressive disorder, which has its own set of challenges in treating, can also improve. And from a quality of life standpoint and disability perspective, treating depression for remission is going to give us our best functional outcomes and patient quality of life outcomes. Treatment-resistant depression is common and it is debilitating. When we are prescribing somebody a first-line antidepressant, and you can pick your favorite SSRI, atypical antidepressant, SNRI, the data is pretty much equivocal across the board that about 1/3 of these individuals will get remitted, about another 1/3 will have a response, and around 1/3 are not going to have any response to their antidepressant. If you take the folks with the partial responses and no response and you switch them to a second agent, around 1/3 of those are going to reach remission, 1/3 are going to have a response, and 1/3 are still not going to have any response to that medication. So after 2 medication trials, there's still a pretty large chunk of our patient population who are struggling with significant symptoms, even if they're not completely resolved, or they've had some resolution of their symptoms. They're still going to have some residual depression. After 2 medication trials, around 20% of patients with MDD have no response to an antidepressant. And after 2 failed medication trials, the likelihood of reaching remission with another antidepressant, and again, you can switch antidepressants, you can pick your favorite antidepressant augmentation strategy. We're going to hit around 10% of patients who are reaching remission. So once that you've hit that 2 antidepressant mark, that's when we start to see things get really tough for patients. This was pulled from a study on the number of antidepressant trials that individuals with treatment-resistant depression had. So as you can see, after 2 medication trials, there's a handful of people who must get better. But as we are going into our number of antidepressant trials, we see more and more patients that have been on 9, 10 medications and are still experiencing treatment-resistant depression. So if you can imagine the frustration that comes with trying 10 different medications and still not having any benefit for depression, you can imagine how frustrating that would be. The medication trials are important because we need to know if the person has had an adequate dose or duration in order to know if they're going to respond. But continuing to throw an antidepressant at the same problem over and over again is going to become pretty futile. So each of these medication trials is taking 4 to 6 weeks. And there's some evidence to go longer if a person has a partial response. So we are looking at, a month or more of a person experiencing treatment-resistant depression. And the longer that this goes untreated, the more difficult it can become to treat over time. If we have a person who has a partial response and we have untreated or suboptimally treated depression, we are going to see that patients are going to become more frustrated with medications. They are going to lose faith that things are going to get better. It can increase their level of distress, and it can decrease a person's adherence to medication. So it's hard enough to get a person to take a medication if we are using things that are causing a lot of side effects or are complicated regimens to take multiple times a day or multiple pills with different interactions. Patients are going to be less likely to follow through with that, and for what? So that's a very discouraging pattern that a lot of people can get into. We know that the risk of future depressive episodes increases with each subsequent episode. So after 1 episode of major depression, you've got about a 50-50 shot of another episode at some point in your life. around 80% after the second episode, and then greater than 90% after that third episode. So finding medications that are effective for people, that keep them in remission, and that are tolerable for them is key to reducing the future morbidity associated with depressive episodes. Bipolar depression tends to be its own beast. It tends to be a more debilitating and difficult depression to treat. Giving people with bipolar depression antidepressant medications is like giving them a placebo. There is no real benefit to treat bipolar depression with antidepressant medications, and there is a small risk that you can destabilize a person's mood. So if you don't have a mood stabilizing medication on board, and you start a person with bipolar depression on an antidepressant, you can get these, the concern is flipping a person into mania, but the evidence on that is probably a little bit overblown. What I typically see is that these patients will get really agitated, almost a mixed state, where they're both very dysphoric, suicidal, hopeless, and have a lot of energy and agitation, and that is a very high risk time for suicide. Polypharmacy is common in bipolar depression. The average number of medications that a person with bipolar disorder is taking is 4, and most of those are going to be targeting the depression part of the illness. So, mania is exciting. It's what gets people into trouble. It gets them into our acute hospitals. But we're pretty good at bringing mania down. It's the bipolar depression that causes the significant portion of disability and quality of life problems for folks with bipolar disorder. And it's the mood state that they tend to spend most of their time in. Other psychiatric illnesses. PTSD can be chronic. Our evidence-based therapies for PTSD oftentimes require exposure, and a lot of our patients do not have the requisite emotional distress tolerance to be able to engage in those types of therapies, especially because PTSD is comorbid with so many other, mood disorders and other anxiety disorders, things like that. If you've got somebody who is struggling to manage mood and emotional responses anyway, exposure-based therapy might make things worse. Schizophrenia. Around 1/3 of our patients with treatment-resistant schizophrenia continue to have clozapine, or they continue to have positive symptoms of psychosis even with clozapine treatment, which we do have evidence to say that that is a better treatment for psychosis than any other antipsychotic that we have. Negative symptoms of schizophrenia. These are always a challenge to manage and treat because just like with bipolar disorder, an acute psychotic episode is exciting, and we can do a pretty good job of treating a person's positive symptoms in psychosis, but it's the negative symptoms of schizophrenia that chronically tend to cause a lot of disability and quality of life problems. Anxiety disorders, even though they can be highly responsive to treatment, particularly psychotherapy, they do tend to be chronic and wax and wane in severity over time, particularly in response to stressors. So are there ways that we can use other therapies to get these people who are unable to respond to our traditional therapies to respond to them? Are there ways that we can treat an anxiety disorder and potentially kind of shut that off and not have it be something that's going to be at high risk of coming back in the future? These are all things that we are looking for in the field of interventional psychiatry. So we need to get more people better, and we need to get them better faster. Right now, our best chances of that are neuromodulation techniques. So ECT and TMS are effective for treating depression. ECT in particular is very effective for treating depression, with the majority of patients receiving ECT for MDD having a response to the treatment, and many of those going on to reach remission with treatment. TMS is, it's been around for many years now, but we are just now starting to look into some of the accelerated protocols that can get people better in a matter of a week to 10 days. TMS has historically been difficult in that in order for insurances to cover it, the protocol indicates that the person is coming in every single day, Monday through Friday, for a series of treatments that lasts anywhere from 4 to 6 weeks. So if you think of the time and the energy and the commitment that takes, if you think about the geographic constraints that we have with TMS not being very widely offered, this can be a really big barrier for people to get treatment. And right now, the best evidence that we have in TMS for rapidly resolving depression and suicidality in these individuals is based off of a protocol that is shortened. It's a much more intense stimulation that the person is getting. And because of that, it's not FDA cleared. A lot of insurances are not going to cover that. So are there other ways that we can get a person to reach remission of a psychiatric illness, particularly depression? That's what we're always striving for. Neuromodulation works by inducing rapid neuroplastic changes that lead to structural and functional alterations of the brain. So not only are we influencing the small microenvironments and the neurons, the neurotransmitters, the way that those are being released in a very rapid and global way, particularly with ECT, we are also trying to stimulate brain circuitry to help it connect in a more healthy way. So over time, we see that neuromodulation can help change the structure of the brain. We see increased hippocampal volume post-ECT, for example. So although ECT is highly effective for MDD, there is limited access depending on location. There can be significant patient preference barriers to ECT, being that it's a very stigmatized treatment and that the media has portrayed ECT as something that it is not. We have to use general anesthesia for ECT, so that's going to require a patient having transportation to and from the procedure a couple of times per week during acute treatment, and they're going to have to recover from that anesthesia afterwards. So people who are working, caring for children, they might really struggle to make the commitment to be able to be doing this type of treatment for a couple of weeks at a time. It can also be disruptive to a person's daily function with some of the acute memory side effects that happen with ECT. So some individuals that I've treated in the past, professionals, for example, who are really concerned about some of these memory side effects, are looking for better treatments with fewer cognitive side effects. TMS tends to have greater patient acceptability. Again, it's a lot easier. It's not invasive. There are fewer contraindications versus ECT, but it is going to take time, and there are going to be accessibility issues with that in our part of the country. Ketamine acts on our GABAergic interneurons in order to modulate NMDA signaling at the synapse. We are looking for increased glutamatergic input in order to increase the signaling and the stimulation in those parts of the brain that are dysfunctional in depressed states. This is a really intriguing picture. This is taken from a study on rat neurons. So these are rat neurons in a petri dish. The first neuron is just a regular old neuron hanging out, and the second neuron is a neuron that has been exposed to ketamine about 3 hours after exposure. And you can see the significant increase in all of these dendrites and the sprouting and the immediate changes that we're seeing to the structure, and we assume then the function of that neuron. So the ability to rapidly induce neuroplastic changes to get the brain to adapt to things very quickly and interrupt patterns that have been keeping a person in a depressed state can be really powerful. So let's talk about evidence-based ketamine treatment. For psychiatry, the first randomized control studies for ketamine were started in the early 2000s. This is where individuals were getting sub-anesthetic infusions of ketamine given over a single 40-minute infusion. And there was a lot of promising evidence that came from these studies. There was a rapid resolution in about 2 hours of depressive symptoms and suicidality in a great number of these patients who were receiving ketamine treatments. However, the effects were short-lived. Many patients were maintaining a response for about 7 days, and then they were relapsing to their previous levels of depression and suicidality. As these studies were repeated over time and pooled in a randomized control trial and as the randomized control trials were pooled and we looked at the meta-analysis data, we're getting pretty similar results. Many people will respond very nicely, quickly to ketamine for depression and suicidality, but how do we keep that effect going? When I had an outpatient practice and I had referred a patient to ketamine treatment for their depression, in a way, it felt like it made things worse for them because they felt so good for that short period of time. And then to have those symptoms return and to feel like they were back where they were before after having that hope, it was pretty devastating. So a lot of the initial work in ketamine treatment for depression looked at evolving the protocol over time so that we can best find a way to keep these results going for patients. So in 2016, there was a randomized controlled trial on repeated dosing. So this was 2 to 3 days a week of that sub-anesthetic ketamine infusion for 40 minutes at a time over the 4-week period. This tended to extend the effect out to about 15 days. So statistically, that sounds really exciting, but for a person living with depression for many years, 15 days is really not a lot of bang for your buck there. There were smaller studies on bipolar depression that followed a similar trend. People would have a robust response for their bipolar depression. And as they did these 4-week infusions with repeated dosing, the effects extended, but not all that great. So right now, a lot of the research on using ketamine infusions for depression are trying to find the balance between the long-term risk and benefit of maintenance treatments. So we have these protocols that are coming from Mayo Clinic, for example, where they are doing tapers instead of just stopping the ketamine after the 4-week infusion, where they decrease something, where they decrease the frequency of the treatment to 1 day a week for a couple of weeks, and they maintain that for a while, and then they start stretching people out. And a lot of maintenance treatment now is settling between people getting these repeated ketamine infusions to help with the effect of it every 3 to 4 weeks. So we are seeing that there are people who can extend past that. We're seeing people who tend to get depressed very quickly after those infusions start to space out. So it's really, we don't have a good guideline about how to do this and what patients are going to be good candidates for a maintenance treatment. In addition to not knowing a whole lot about the risks long-term of repeated ketamine infusions. Esketamine was approved by the FDA in 2019 for treatment-resistant depression in adults. So esketamine is the S enantiomer of racemic ketamine. So a racemic ketamine mix is what you're getting in an infusion. When in isolating that S enantiomer, the hope was that we would get a higher binding affinity to the NDMA receptors because in lab studies, it showed that this one is the more active of the two enantiomers. Randomized controlled trials showed rapid reduction in depression rating scales versus placebo. And both treatment groups experienced a rapid reduction in the severity of suicidality score. In 2021, a meta-analysis of around 10 studies showed mixed results on the difference between esketamine plus antidepressant versus esketamine versus placebo on depression symptoms. We did see that there was a delay in relapse from esketamine versus placebo. But again, how long did these results last? One of the intriguing things that came out about ketamine in 2018 was a study that combined ketamine with naltrexone. And the purpose of the study was to block any potential opioid effects that ketamine would have due to some of the criticism that the ketamine was helping people with depression because it was stimulating opioid receptors and we were getting people addicted to ketamine, so on and so forth. It appeared to have some interference with ketamine's antidepressant effect. When we put that naltrexone in the mix, people did not respond very well to ketamine versus placebo. So there was this concern for addiction and abuse, but there is, some things to be looked at with this study. The result of mu opioid receptor blockade can attenuate downstream mediators of ketamine agents. So by blocking the mu opioid receptors, it might not be that the ketamine was helping because it was stimulating those as it would as an opioid, but perhaps there was other downstream effects of that chemical that were causing the ketamine to become less effective when that was stopped. The 2023 Stanford study took 40 participants with moderate to severe depression who were undergoing general anesthesia for routine surgery, and they used ketamine infusions in a number of these individuals versus a placebo to blind the dissociative effect. So one of the things that we see, particularly with IV ketamine infusions, is that it's very difficult to placebo blind these trials. People are pretty good at being able to guess which group that they're in post-trial. The dissociative effect of ketamine is really difficult to reproduce with things like Versed is commonly used as a blinding agent in these studies. It's just not the same, and people do tend to notice that. So by giving the ketamine infusion during the general surgery procedure, we were blinding that dissociative effect. And you might wonder, is there something about the general anesthesia that is impacting these scores? Probably not. There was some research ahead of time that has established that depression scores do not tend to change. If anything, they can increase a little bit post anesthesia. So treatment revealed that 2 weeks later, both groups had significant improvement in their symptoms, equal to the effects in other ketamine studies. And that afterwards, most patients were unable to correctly guess their intervention. So when we blinded these individuals with some more tricky techniques to prevent them from experiencing the dissociative effect with them, it became much more difficult for them to know what treatment group they were in, and there was a significant response to depression in both groups. So which do we use, ketamine or S-ketamine? A 2023 study compared the efficacy and tolerability of IV ketamine versus S-ketamine. And it found that the drugs are about equal in their efficacy and side effects. Ketamine is from an overall treatment cost perspective versus S-ketamine. But some of the theoretical differences about bioavailability and binding are not resolved as a result of this study. So things to keep in mind. We do not know the effects of repeated infusions for ketamine. We get these things out to the market, and we want to get these things to our patients because they're suffering now, but we still can't say with a lot of certainty what infusions over years are going to result in for patients down the road. Ketamine can cause high blood pressure, particularly during the infusion. There can be bladder irritation and genitourinary problems. That tends to be pretty rare, but again, seems like it might be increasing with the amount of exposure to ketamine, both in dose and subsequent exposures. Dissociation. When I was doing my ketamine certification course through the place that I went through for that, there was a lot of people who said you have to get people to that state of dissociation in order for them to get a benefit from ketamine. And a lot of these people thought that the trials were dosing people too low. From my clinical standpoint, a lot of people who experienced dissociation with ketamine would not go back and do the treatment again. A lot of the people that I referred had comorbid PTSD and trauma histories, and that dissociative experience was really out of control and anxiety provoking for them. So I have had a number of people who have discontinued treatment due to that dissociation side effect. Nausea, abuse and addiction. So over time, there is evidence that people build tolerance to ketamine. And there have been case reports of people who have absolutely become addicted to ketamine as a result of repeated infusions intended to treat their depression. A potential to induce mania, psychosis. Again, the studies that have been done in patients with bipolar disorder are quite small. That risk of mania does not appear to be very large, but if a person does have a history of psychosis, because of the dissociative effect of the ketamine, it's recommended that those patients be excluded from treatment at this time until we know a little bit more. So how do we identify the right patient for ketamine treatment? We have to keep in mind that our diagnostic accuracy in psychiatry is not great. Depending on who is seeing the patient, what the patient reports, what they look like on a particular day, you might have a big change in what a patient's diagnosis is, depending on these different factors. So making sure that we have a correct diagnosis, MDD, for example, helps us set the expectation for treatment about what things we expect are going to get better. It's important to remember that psychiatric symptoms present across many conditions. Depression as a mood state is very common in normal reactions to things that have happened to a person. It is a part of PTSD. It can be a part of grief. So just because a person is reporting a depressed mood, that does not establish the diagnosis of major depressive disorder. And you really need to be careful about making the diagnosis and being accurate about it before referring patients for treatment. Comorbidities are really common in our patients. In our trials, it's very nice to see that they screened out everybody with the most severe suicidal ideation, the people with the most severe depression, and no comorbid anxiety conditions. But that's just not the reality of clinical practice, where comorbidities are the rule rather than the exception. So setting the expectation for what things we expect are going to get better with treatment and what things might still be problematic for a person if they do get a response to treatment is important. I would see this sometimes in ECT, for example. A person with very, very severe depression would start to get better from a depression standpoint, but then some of the underlying cluster B personality traits started to come out in full force. And in some ways, they looked a little bit worse after treatment. So knowing what you're going into is important with comorbidities and expectations. There can be a lot of inaccuracies in treatment history. So is a patient truly treatment resistant? Trying to track down records, trying to have patients recall what medication trials they have and doses can be really difficult. And I know this from TMS as well, being able to verify that a person has had, in some cases, 3 or 4 trials of an antidepressant medication that are adequate dose and duration can be very difficult. So being able to really identify patients that are truly treatment resistant can be tricky. And again, setting expectations. Once you have all of these things in place, you need to set expectations about what things you're going to expect to be better, what things a person might still struggle with, and what the plan is to treat those things long term. Logistics of treatment. So this can vary based off of the type of ketamine treatment that's being used, but in the infusions, there's going to be issues with transportation. Person shouldn't be driving after they've had this treatment so they're going to need somebody to take them there. Both S-ketamine and ketamine take time, so 40 minutes, and then there's a waiting time period with Spravato or S-ketamine to wait and monitor the patient for side effects for hours afterwards. So that can really take time out of a person's day. The advantage being that you're not having to do it every single day like you might with TMS, for example. Availability. So depending on where you're at in this part of the country, this might be something that is available in your town. It might not be. And chances are, if you're outside of the FM metro, it's less likely to be available. Cost is an interesting question here. Ketamine infusions are not covered by insurance, and nobody is going to spend the money necessary to get an FDA label on ketamine for depression, right? It's a cheap, inexpensive, old medication. In order to get that label, that would, encourage insurance companies to start covering this. So people are paying out of pocket generally for these treatments, and it can get quite expensive. $500 an infusion is the last that I was aware of, but that might have changed in the last couple of years as well. S-ketamine, it can be covered by insurance, but one of the issues that we run into is that some of our payers are not reimbursing adequately, that it leaves a large portion of our patients uncovered because the places offering services are losing money on those treatments. So even though it's more expensive up front, a patient might have better chances of getting coverage for S-ketamine. There are issues with lack of regulation. Many clinics offering ketamine do not involve a psychiatrist, and providers giving ketamine infusions might not have any psychiatric training. So again, when I was going through my 60 hours of ketamine CME, trying to get certification, it shocked me how many people just kind of hung out a shingle and started offering these infusions for things and using it off label and having a cash practice, because many of them were not psychiatrists. Given the difficulty with diagnosis, the difficulty with comorbidities, and the way that things can evolve over time with reactions to treatments, it's probably best that a psychiatrist and mental health professional with expertise in diagnosing and diagnostic clarification is on board with some of these things. There are variability in the evidence base that a clinic could be using for their treatment protocols. So dosing, routes of administration. There are some clinics in the country where they are using extremely high doses in infusions, things that I wouldn't do outside of a general anesthesia setting, and these folks are getting them in these standalone clinics. So that is concerning to me. As people are building resistance to the ketamine treatments over time, I have seen people getting more frequent infusions rather than extending the time between infusions, and using ketamine in creative formulations in order to try and extend the treatment between treatments. And that can include things like ketamine lozenges, intramuscular injections of ketamine, so on and so forth. And again, these are things that do not have a great evidence base for them, and make me concerned for the risk of abuse. The lack of standardization in treatment guidelines and education and training. So ketamine was something that I had to go off and learn on my own. It wasn't something that was part of my psychiatric training. Because each ketamine program that's doing research on their protocols is kind of doing their own thing, we don't have a great unified approach to an evidence base for a ketamine protocol that is going to be a standard of care. And because of that, it's really hard to compare outcomes between different places. So what comes in the future? The expansion of ketamine and psychedelic-assisted treatments and psychotherapies are on the horizon. There are individuals who are doing psychotherapy during ketamine infusions in clinics to try and bring some of that psychotherapy, the exposure to difficult emotions, the challenging of cognitive distortions, while the person is getting that, acute neuroplasticity, to try and enhance those changes and perhaps make them a more long-term permanent solution. It's going to be tough to know where that lands. Like I said, in my experience, a lot of folks that had trauma did not like the dissociative part of ketamine, and proponents of this say that it's something that is maybe necessary in order for a person to have ongoing change from their treatment. Novel treatments for rapidly treating severe and chronic mental illness are going to continue to come down the pipeline, and ketamine is an old thing that's been reinvented and repackaged and repurposed, but we continue to have different theories of mental illness, looking at our dopamine theories of schizophrenia and how we are finding out that that's perhaps not the most important thing in treating positive symptoms of schizophrenia. There will be more to come with that. And we want to continue to encourage early treatment of illness to reduce the chronicity and treatment resistance that we see. So the earlier that we can identify patients who could benefit from these treatments, the faster we can get them into treatment and get them to remission, they're going to tend to have a much better long-term prognosis. We need to remind ourselves that even when new and exciting things are coming down the pipeline, that there are psychosocial factors that impact psychiatric illness. And while we are sometimes doing the best we can with our biologic treatments to help people, we are not going to be able to medicate away some of the challenges that our patients face that are outside of their control, outside of our control, and still require systematic changes in order to address those factors. Psychiatric research in general has problems with treatment study design. We have very high placebo effects in antidepressant trials, so it's very hard to power those trials to get significant results because over time that placebo effect in antidepressant trials has increased so much. There are novelty effects with psychiatric treatments. So we see this in TMS as well, where a person is getting a new and exciting experimental treatment, and that element of hope improves their response to where they might see effects that are not entirely related to the biological agent. And for particularly with ketamine, it is a difficult substance to blind people to because of its very distinct effects. Will clinical practice outpace the evidence? So this is what I'm referring to when I'm talking about clinics where people are using unregulated and kind of untested theories of how to administer and what doses to administer ketamine for all kinds of different diagnoses. Are we going to outpace our evidence to the point where we are putting our patients at risk? That being said, sometimes we need to do the best with what we have in the moment. And when a person is suffering now, we need to balance our concerns about the future to whether or not that person is going to have a future if we can't treat them and get them better. So sometimes we need to do our best with what we have, or the concept of psychiatric dialysis, where we are treating a person, we are using therapies with the hope that perhaps someday something that helps them more becomes available. Sometimes this involves redefining our treatment goals in terms of, if we're not going to have remission, what can we do in terms of quality of life instead? And how do these therapies like ketamine play a role in that? I think that ketamine in particular is a great example of the power of belief and hope. We are helping our patients the best that we can with the tools that we have, and sometimes it's inadequate. But the evolution of things like ketamine and other developments in psychiatry could potentially give some of our patients who have been struggling for a long time some hope moving forward. And when we have that belief with our patients, it's a very powerful interaction that you have, to where sometimes it might not feel like you're doing a lot for them from a biological treatment standpoint, but that person is still benefiting from that interaction because it's allowing them to move forward in their life and have something to hopefully experience in the future when it's their turn to hopefully find a treatment that works for them. Looks like I finished a little early. Any questions?
We do have a question. Oh, we have a comment in chat that TMS is now available at Valley Christian Counseling in Fargo. But any other questions we can put, if you want to put those in chat for me right now, I will go ahead and answer them. Any thoughts or comments on pharmacogenetic testing? Local places do this, but not Essentia.
Yes. You do not have to have in-house laboratory testing for pharmacogenetic testing, and particularly for psychiatric drugs, there are commercial agencies available that will do the testing, that you could just send the sample directly to them and get results back. Pharmacogenetic testing from a population standpoint does not have good evidence to help reduce the treatment resistance, the lack of response that we see to antidepressants. So it has its place, but we need to interpret it, and we need to inform our patients about this with caution, because a lot of times I will have patients come in, they're not willing to try something until they get you that piece of paper sent in that shows you the medications that are right for them. So information that you can get from pharmacogenetic testing. The first thing is how quickly a person metabolizes or is likely to metabolize a certain medication. So that can give you information on, is this a person, for example, who we really have to crank up this dose of sertraline because they really burn through sertraline fast and they've had a partial response for their anxiety and OCD, but does it make sense to go, for example, above an FDA recommended limit or to push those things? It can help support evidence to do that in individual patients. The second thing that pharmacogenetic testing can help with is finding out whether people have certain genotypes and certain serotonin transporter gene promoter region configurations that make them more or less likely to make more serotonin transporters throughout their bodies. So there are individuals who have 2 short copies of the serotonin receptor gene promoter region on their genes. And in those individuals, it's theorized that they are a little bit less likely to respond strictly to SSRI medications, and they may benefit to switching to something that has an alternative mechanism of action, not just relying on an SSRI mechanism to help that person. But, again, you might already know that from a person who hasn't responded to an SSRI by that time. So whether or not it's clinically useful is sometimes a little questionable. The third thing that I find helpful in pharmacogenetic testing is looking at methylfolate and folate conversion. If you have a person with reduced folic acid conversion, then supplementing with L-methylfolate does have good evidence to be helpful. I haven't found it a whole lot in patients that I have tested. Around maybe 5% of the population is thought to have this short genetic type for their method of folic acid conversion. But for those people who are not as efficient as converting folic acid, supplementing it can help make antidepressants work better, because we are getting the little building blocks of your neurotransmitters to your body in a more efficient way. I do not have a specific brand recommendation on L-methylfolate. There's a lot of things out there, but I typically have patients ask questions if they have a concern about a particular brand. So basically, the genetic testing has become a lot less expensive over time. So I can see using it from a standpoint of, if it saves us another medication trial, if it gives us some information that keeps a person out of the hospital, the cost-benefit analysis of that might highly favor the genetic testing. But again, from a population standpoint, does not appear to make that much of a difference. And you just have to be able to interpret those results with caution, because a lot of people get hung up on the little, at least the commercial lab that I'm accustomed to, the little categories with the red, green, and yellow, and anything that's in the red column, they'll be like, nope, I can't do that. It's not going to work for me. And that's not really what information is being provided.
Thank you, Lisa. Any final questions? We do have some time for Lisa. You can put this in chat for me, or the Q&A, I mean. Going once, going twice. I'm not seeing any other questions. Okay, well, thank you so much
I
for your
appreciate your
time and
time.
expertise today. We really appreciate that you're able to join us this afternoon for our session. Have a
Sure.
great weekend. And
Thanks.
to everybody else, we will have a short break now. We'll pop back on for our last afternoon session of the day, which will be at 3:15. So we'll have a little bit of a break now, and we'll see everyone very soon. Thank you. Okay, we're going to go ahead and get started with our very last session of the day. I want to thank everyone for staying with us throughout the day and for attending this last session. At the end of this session, I will be putting in the evaluation into the chat. And at that time, you'll be able to do the evaluation, and then it will populate for how to earn your CEUs for the day. Again, this conference, the entire day has been recorded, and I will send everyone the recording link within about 2 weeks. I am going to go ahead and introduce our last speaker. Thank you so much for joining us. Joanna Johnson is a doctorally prepared advanced practice nurse who has worked as a psychiatric mental health nurse practitioner in the Fargo community for more than 10 years. During this time, she has gained clinical experience in outpatient and residential treatment of the child adolescent population. Today, she is going to share her knowledge and expertise about anxiety in the adolescent population, including evidence-based treatment strategies and prescribing considerations. So welcome, and I'll let you take it away.
Yeah, well, thank you for that introduction. I appreciate that. And thank you, Danny, for organizing all this. And it's been a wonderful experience to be able to speak at these conferences. So today I'm going to talk on adolescent anxiety disorder. Let me get my little marker up there. And we're going to do some learning objectives real quick. We're going to identify the symptoms and signs of anxiety. We'll review guidelines for the assessment and treatment, and we'll review those treatment strategies. We'll assess for comorbidities, and then we'll review some case studies. So according to national data, 1 in 3 adolescents experience anxiety, highest leading into adulthood around ages of 17 and 18 years old. And this occurs more in the female population than the male. Now, of those with anxiety, roughly 8% report a severe impairment in their anxiety, and a majority of this population is not getting the help that they need. Now, anxiety rates skyrocketed across the globe during and after the COVID-19 pandemic. In part, this should be expected. Pandemics are very anxiety provoking. But what we saw a lot of was this anxiety with reintegration post-pandemic. A lot of anxiety attending school, being around others, and that increase in stimuli was just overwhelming for many. So during this time, I saw a lot of kids refusing to go to school or wanting to continue online education due to this anxiety, and specifically the social anxiety. But before I get into the DSM criteria of anxiety and anxiety-related disorders, I wanted to briefly review the neurobiology of anxiety, or what we believe is happening in the brain that elicits the anxiety reactions. So first, I want to review the limbic system, also known as the emotion center of the brain. The limbic system, specifically the amygdala, is triggered when there is a potential threat. It sends signaling to the prefrontal cortex, our thinking center of the brain, and the prefrontal cortex will evaluate the information and send signaling back to the limbic system, either elevating the threat and the fight or flight response, or reducing that activation. Now, when there is an overactivity of the limbic system, it becomes dysregulated. It fails to send clear signals to the prefrontal cortex, and the prefrontal cortex cannot make efficient logical decisions. This overactive amygdala and hypothalamus can cause feelings of panic, and the prefrontal cortex, and to some degree the anterior cingulate, can start the worrying process, that rumination and that perseverating. Now, chronic and or intense anxiety produces cognitive impairments, including deficits in the flexibility and decision making. Essentially, neuronal processing anomalies begin to occur. Anxiety that involves intense fear and panic, such as panic disorder, symptoms of PTSD, which aren't technically anxiety disorders, but like phobias, can be characterized as underactivity of the prefrontal cortex, disinhibiting the amygdala. Disorders such as generalized anxiety and even OCD, again, not an anxiety disorder anymore, are more around that worry and that rumination, and they seem to be characterized by an overactivity of the prefrontal cortex. Now, it's been suggested that individuals with high anxiety attend to the threat more readily and are biased in learning related to that adverse outcomes and tend to overgeneralize. Anxious states also increase the capacity to detect threats in the environment by priming and focusing attentional and sensory systems. This reinforces the view of the world as a threatening place, and these threats, associations once encoded in the brain can be hard to change and tend to generalize anxiety more easily. And when that threat and learning bias interact, it provides that continued rationale to maintain this hypervigilant state. Now, this is particularly problematic in the child adolescent population because they don't have fully developed prefrontal cortexes. They're just not fully developed yet, and the amygdala is often more hyperactive. So just as a reminder, like I said in the previous slide, PTSD and OCD are no longer considered anxiety disorders, or they moved them into their own category. But I am going to review a few common anxiety disorders, but focus more on that generalized and social anxiety for the adolescent population. I added a couple other slides, more for supplemental information, but I will review those, the highlights of them. And then we will review the screening and treatment options that are available. Now, generalized anxiety, I think a lot of us might be more familiar with this. The criteria A and B need to be present along with at least 3 of the criteria C. So again, that restlessness, fatigue, that concentration, irritability, muscle tension, and sleep disturbances. So you can, again, see where this nervous system is activated. Excuse me. Anxiety needs to cause the impairment, and the criteria that I did not place on this slide is that it cannot be caused by a medical condition, a medication or substance, or due to another mental health disorder. Now, when we think about generalized anxiety, and we see this in child adolescent population, sometimes it's not just as easily as that criteria in 3. Sometimes you're going to get these vague symptoms, these headaches, these stomach aches. They can't concentrate well, they're not going to school, or they don't want to. Some older adolescents more than younger ones, but some will tend to use substances, again, usually like cannabis or alcohol. They're trying to relieve that tension. It can lead to this irritability, mood swings, anger, rages. And then that thinking can become pretty obsessive, or even a compulsive behaviors can be an outcome of just a generalized anxiety. So you might see it a little bit different, but at the same time, it's like this activation of that nervous system. All right. And with social anxiety disorder, remember this has to occur with peers as well. So this isn't just like I'm anxious when I'm around adults or my teacher or my advisor or whatever. Again, this is that marked fear, anxiety about a social situation where they feel they're going to be exposed to a certain scrutiny by others. Now, I see this sometimes I don't want to go to the store. People look at me. They're thinking things about me. They can tell I'm anxious. And so, this fear will elicit these kind of anxiety symptoms. And sometimes you can even see, of course, the younger kids may be crying or tantrums, but you can still see this in the teenage population where they just kind of shut down. There's this fear and anxiety that is far out of proportion to the actual threat posed, right? So there isn't, I can't go into Walmart because everyone's looking and they know all this stuff and there's this anxiety, but it's like there's no real posed threat of that. And the social situations will be often avoided, or if they do have to attend them, it could create a lot of fear and a lot of anxiety. And this anxiety needs to be persistent for at least 6 months, again, causing that impairment. And again, just like I had said in the last one, what I didn't put on here is that it can't be caused by a medical condition, a medication, substance, or due to another mental health disorder. Panic disorder, again, this reoccurrent and unexpected panic attack, right? Panic is this abrupt surge of intense fear or discomfort. And again, these symptoms, 4 or more of these symptoms, you can again see this, system being activated, this nervous system. Now, this is largely, amygdala based. It's activating that sympathetic nervous system and the fight or flight response. It needs to have one attack followed by at least a month of this persistent worry that creates a maladaptive behavior. And this is that negative loop of that prefrontal cortex, anterior cingulate, and that perseverating distress, dysregulating the behaviors. And again, cannot be caused by a medical condition, a medication, a substance, or due to another mental health disorder. However, that being said, panic and generalized anxiety can occur together. And if you remember that social anxiety where it was like, if they go, they'll have this intense fear, right? This could lead into that panic, right? You're in a heightened state and you're being pushed so much that you end up in a panic state. Overdrive, we're in overdrive. Now, agoraphobia, this too, fear-based, hyperactive amygdala activity, and you can see how all these are threading together with a mix of this limbic and prefrontal cortex dysregulation. But this isn't a rational fear. Everything at this point is a threat, right? And so you might avoid situations because you can't escape, or if you do have some sort of a panic or high anxiety, you won't have the support there. So it's always kind of more of this fear-based anxiety. And oftentimes people will need to have a companion with them, right? Like, I don't go anywhere alone, right? Because they just need somebody in case something were to happen. This is very out of proportion to the threat being posed. And this too is persistent for 6 months, causing an impairment, cannot be caused by a medical condition, a medication, substance, or due to another mental health disorder. So how do we screen for this? Now you can see that the Academy of Child Adolescent Psychiatry, the American Medical Association, along with the Preventative Task Force and the American Academy of Pediatrics are all recommending similar screening and treatments. The GAD, I think we're all pretty familiar with that one, but they all also mention the SCARED screener as an option. And I'll show you what that looks like on the next slide. Treatment recommendations look pretty similar with that SSRI in therapy as gold standards. What sets them apart probably is the Academy of Child Adolescent Psychiatry place that SNRI kind of more at the bottom, where the other ones in their recommendations kind of group those together, SSRI, SNRI as an equal option. But I still think it's good. Probably I'd follow this child adolescent psychiatry one. That's the one I follow, where you're going to probably come out with that SSRI first, but it's always independent on the patient and what you're treating and what you think is going to be the best course of action. All right. So the SCARED screener, this one is much more lengthy. It's 41 questions. It has a 3-point Likert scale, 0, 1, 2, as the scores. You're going to have the adolescent or child do one of them. You can have the parent do another one, and it is ages 8 to 18. So you can kind of get a large group of people in there, age group. The scores over 25 will indicate an anxiety disorder. But once you get scores over the 30 mark, you might be able to see more specific anxieties, right? So they're looking at generalized social separation panic, but they also do include the somatic symptoms as well as school events. And so again, just pretty basic, do I get scared when I'm gone? Do I worry? Do I get frightened? Am I nervous? It rephrases a lot of things in different ways to try to catch those outliers, those outlying symptoms. Now, there are many types of therapy, as previously mentioned. CBT and cognitive behavior, as CBT as cognitive behavioral therapy and psychotherapy are probably the most common, but DBT can also be common in some therapy sects. But therapy should precede medication if possible, if caught early enough, hence the screening process. But sometimes you need medication to stabilize enough to start working on things in therapy. Again, all of this is depending on the severity and the level of the dysfunction that is occurring. Now, I quick want to say something about mindfulness. Mindfulness shows significant improvements for anxiety disorders. Not only does it settle down that limbic system, it activates the prefrontal cortex. Doing a mindful scan of your senses can activate your parasympathetic nervous system. This is what we need. This is very important and can be effective within seconds or minutes. You can actually do this in session, guiding them through a brief moment of mindfulness and see the results. This demonstrates the effectiveness and can encourage them to continue doing it. Oftentimes I hear things like, I can't do that, it doesn't work for me. Well, you don't try to run a marathon without training, and it should be like saying, I tried to run a marathon, but I couldn't run a mile without stopping. That would be clearly silly. So getting the benefits of mindfulness may take repetition for some. And even if they don't think it's helping, it's likely to some degree helping, and they just need to keep trying it. We know this because calming the breath is something that we use in all areas of medicine, right? Childbirth is about breathing. When we work through pain, we're working through breathing, different types of procedures we need to breathe through. We know that breathing helps and breath work matters. So I just wanted to bring that up because I don't want that to be kind of left out of the equation, because it's a very evidence-based treatment strategy that I don't want us to forget about. Okay, so here's what the FDA has approved in the child adolescent population, the ages, indications, dosing guidelines. And as you see, we have 2 agents that are approved for generalized anxiety, meaning that 2 of these medications showed benefits in the population during clinical trials. Now, as you have a 17, 18-year-old, you have more options. But for that 10, 11, 12, 13, the options can be narrow if you want to follow an evidence-based treatment guideline. Now, Lexapro is usually a pretty good option to start, and depending on age, starting at 5 milligrams is totally appropriate. Even in adults, and probably I'll say this, probably at least 60% of the adults that I see that have a generalized anxiety disorder can be maintained on 10 milligrams. So don't rush it. We're not trying to get to a certain number or a certain dose as much as we're trying to get to the management of this dysregulated signaling that is occurring in the brain. Duloxetine, our SNRI option, did not show significant improvements over 60 milligrams, and for some teenagers, 60 milligrams will be too high. it's just too flattening, it's too sedating, or it's just creates too much dysphoria. So I think that'll be something to keep in mind. When you're going down the list, this fluoxetine, that can be very physically activating. It is a stronger inhibitor of the 2D6 pathway, so that's something to keep in mind when using that. Fluvoxamine, or Luvox as we used to know it, has been tagged as this gold standard for OCD. Although OCD is not an anxiety disorder anymore, it can help with that negative looping, that perseverating that we sometimes see in different types of anxiety. Interestingly enough, sertraline did not pass the clinical trials for generalized anxiety or major depressive disorder in the child adolescent population. Not that it wouldn't help, but just go into it knowing that there could potentially be some limitations. Again, don't think that more will be better all the time. More can actually be less in some cases, like worsening the dysphoria and causing flattening. I did put this tricyclic in there, and I could have probably added another tricyclic, but these are not first or really second line treatment strategies in most cases. And I'm not going to really talk about and recommend them too much today due to the side effect profile and, the potential lethality in these medications as well. Okay. Now, here we see some of our off-label agents. Buspirone is a kind of a hit or miss, I think. Due to that multiple doses in the day, it can be cumbersome. I have seen this used as needed, and I have seen it just used at night because it's just like needing to settle in. Can be sedating, but start low, go slow. And if you're using this agent over a long period of time, there can be a strong withdrawal effect coming off. So coming off would be a slow taper, cross taper onto something more efficacious, that kind of thing. Celexa isn't really one I prescribe too often either, especially in this population. There is again, risk factors. I always think of that, this impulsivity, those prefrontal cortexes aren't fully developed and you got some levels of impulsivity. So I'm always kind of keeping that in mind. Desvenlafaxine, it's like that metabolite of the venlafaxine. It tends to be a little better tolerated than venlafaxine, but not sure it's really any more effective per se. But it is an SNRI option, and I think sometimes it can be less flattening and better tolerated than duloxetine, for instance. Mirtazapine, it is good for that anxious depression. Has the side effect of sleep and increase in hunger for most. So not sleeping, not eating, anxious depression, this could be a good option. You can see this paired with an SSRI sometimes, but I would be very cautious because it can be very activating in combination with SSRI. Paroxetine is another one I don't intend to use secondary to side effects, interactions, and it is another strong inhibitor of the CYP2D6 pathway. Trazodone, most often used for sleep, less for an antidepressant. Antidepressant doses are pretty high. Please be mindful of the number of serotonin agents used at one time. More is not always better, and there are increased risk of serotonin side effects. Food changes the absorption of trazodone. So if you eat and then take trazodone, you don't have as high of a sedating peak, and then it tends to take longer to taper off of. As for if you took it on an empty stomach, it tends to peak a little higher for sedation and wear off a little quicker. Venlafaxine is pretty strong in the young population and can be very activating, but when it works good. Lower doses inhibit more serotonin, where higher doses will inhibit more serotonin and norepinephrine. So if you use like 75 milligrams, you're going to have more of that serotonin action, and doses much closer up to 150 are going to be more serotonin and norepinephrine. All right, well, bupropion, I see this ordered a lot. Don't be afraid to use the 12-hour, if 24-hour, I say that out the gate, but the 24-hour version for some, it can be pretty activating, can cause problems with sleep, appetite, more anxiety. But sometimes you can move it to the SR, the 12-hour version, and then people can do better. It doesn't seem to, be as tight in there on the receptors or something. It's just the half-life is a little bit different too. But it can cover even in single day dosing. The half-life is about 22 hours. But it can be very activating for some and helpful for others. It's a strong 2D6 inhibitor as well, so keep that in mind. Now we're going to get into some of these blood pressure medications that can also be helpful. So alpha-2 agonists are calming that sympathetic nervous system. By activating that alpha-2 receptor, you decrease that norepinephrine release. Clonidine and guanfacine, both indicated for ADHD. So if you're treating both, this could be a good option as a standalone or augmenting, just depending again on the person and the situation, what you're treating. Propranolol, beta blocker, so blocking that epinephrine from binding to those beta receptors on the nerves, reducing that heart rate and blood pressure. Sometimes that is elevated in anxiety attacks and nervousness. It could be very helpful for situational anxiety, such as test taking, speaking in front of a group or a crowd, or some social event that they need to go to. You can just kind of calm that nervous system so that you can kind of go in to the situation and feel more comfortable. Research, interestingly enough, I will say this, research has shown propranolol helpful in autism spectrum and that social reciprocity. It's kind of an interesting thing just by lowering that. It's just lowering that activation. It just helps in the engagement in that social situations. Prazosin, the stress response includes changes in norepinephrine and GABA levels in the amygdala. But I will say with this one, be cautious of the different type of anxieties that you're treating. I think prazosin, it works better when you have this excitatory anxiety. And if you have a more generalized anxiety, it's often not as well tolerated. Part of the reason, when reading about this, it was about maybe it's the anticholinergic effect of the prazosin that then can increase the anxiety and that generalized anxiety, where when you have that more heightened anxiety and it's calming that down, it's just better tolerated. Now, I did add a couple of atypicals in here just because they can be helpful. So if you're having this really big anxiety, especially if it's coming from trauma and there's this dissociation and there's sleep issues, this Seroquel, the quetiapine, can be really good even at low doses, even if you're just putting it in there to kind of help sleep. It can really reduce that anxiety response. Abilify, I put that in there too. Again, it's not indicated for anxiety, but what I like about the Abilify sometimes is it can help with that perseverating when you get stuck and everything is in one way, your thinking is just locked in. It just seems to soften things around the edges and makes things more manageable and helps with that mental flexibility. But again, it's not sedating, it can be activating. So keep that in mind. Like activating, I mean restlessness, akathisia, those kind of things. All right. So what are the common side effects of SSRI, SNRI? We have headaches. It's pretty common. GI side effects with 90 to 95% of our serotonin receptors in our gut. We have to expect that would be a side effect. Usually your body's smart. It figures it out. It can regulate it, but initially that can be a problem. Now, I don't know, weight gain is almost like in the child adolescent population, everything's a weight gainer. That's what I think. Very few times will you see something as a weight loss. I mean, you can see that with SSRIs, but oftentimes than not, it's you see weight gain, and that can always be an issue. So kind of keep that in mind. Disrupted sleep, serotonin, adding that serotonin in, especially if you're taking something close to bedtime that's not sedating. So say somebody's on sertraline and they just want to take it at night and then they're not sleeping well. It can cause difficulties falling asleep, staying asleep, early morning waking, sometimes strange vivid dreams. So there can be some of that sleep disruption. I always recommend taking everything in the morning unless you can't tolerate it, then you can take it to bedtime. If it's persistently causing you to be sleepy, if it's the initial reaction is sleepy from taking in the morning, that might get better. But if it's just a persistent, then you can kind of move it over to nights. Obviously, you're going to take something like mirtazapine at night, regardless. Worsening of mood, and this can be this kind of dysphoria versus this akathisia, or maybe it's a dysphoric akathisia, but you might hear some things of like, I don't know, I just feel like I'm restless and I can't sit down, or they're just kind of like, I don't know, I'm just irritable, I'm edgy, and that can be a difficult thing to manage, right, if it doesn't regulate. Now, I wasn't sure I really wanted to talk about this because an SSRI can activate bipolar illness, and I did not want to cause any confusion. However, there is this phenomena called treatment emergent activation syndrome, and this is where there is an activation that occurs with SSRI use, mostly in the child adolescent population. And this is that elevated or even irritable mood state, similar to bipolar activation, and there can be more impulsive behaviors, feelings of anxiety and panic, and even insomnia. The intervention for that would be to lower the dose and see what happens. Now, this is why taking a good history is important, where you're looking at their patterns through their life, you're looking at family history, and you're considering all that is this a bipolar activation, or is it just like that an initial activation that happens, especially in a drug-naive brain? So, you know, something to kind of keep in mind and be cautious about. With antidepressants, when there's an overdose, there's always a risk of QT interval changes. It's just something that's pretty dangerous. So if anybody that you're caring for has that risk factor, maybe having parents keep it, maybe having a pill box where they only have a limited amount so that you can create that safety. And then the suicide ideation, this is something that's a black box warning for all antidepressants and all antipsychotics used in psychiatry. Now, the research on that shows this increase in suicidal ideation, but when you read things that review that data, it doesn't show any completed suicides, but it is a suicidal ideation. It doesn't mean that someone wouldn't complete suicide. It just didn't happen in the clinical study, right? But those are also very short, so you don't get the whole long picture sometimes. So again, always suicidal ideation, keep that in mind if that's occurring. Always have a safety plan in place when you're caring for someone who has those kind of thoughts of, I just wish I wouldn't wake up. Who do you talk to about this? Who can you call? Who's your emergency contact, right? Giving the 988 resource. You can text or call 9888 or go to an ER. So very important to kind of always address that. I address black box warning in everybody I see that I start an antidepressant on because that's our responsibility, but also I want the awareness there and I want the plan there. I want the plan in place that they know what they're going to do if they start dysregulating or having unusual or abnormal thought patterns. Now, this slide is from Stahl, and it may help describe a little bit about that initial flooding of receptors and where some of the side effects are thought to come from. The receiving neuron is low loaded with receptors, right? Trying to get what it can of that serotonin that's in the junction. And then you turn off the reuptake, and now there's more at the junction, right? And this can cause a flooding of receptors, but our body's pretty smart and will regulate the number of receptors, leading to a more balanced level of serotonin. It's thought that during this type of process that the side effects, including activation, would occur. So again, if remembering like the body's going to figure it out. So telling people, hey, you might have these side effects initially. Let's just be patient. Let's go through it. And again, another reason sometimes to start low and go slow for some people when that's appropriate, because, you know, how much flooding do you need at that moment? It'll be something that you're going to decide as the prescriber. Now, I'm talking about serotonin syndrome and serotonin withdrawal. I've heard plenty of people say, I've never seen serotonin syndrome. It's just a made-up thing. But it can happen when there's multiple medications that increase serotonin levels, like an overdose, or if a person is a poor metabolizer of a certain agent that they're on, or even if they're on other medications, such as antidepressant, antipsychotics, you know, maybe they have migraines, they're on a migraine medicine, they have a procedure, they're on opioids, they're taking over-the-counter supplements such as St. John's wort or something that also could increase that. Reglan, right, for that nausea that maybe they're experiencing. So again, you just want to be mindful of that. And you could see it when I've seen some like early where, you know, maybe the people are having these like spasms or they're having this jerking, they're feeling a little bit more anxious, they're having like hot flashes, you know, their stomach hurts, that kind of stuff. Again, okay, what are we looking at? You know, are we on an antidepressant, an atypical, you know, Adderall and trazodone at bedtime? And that's a serotonin storm waiting to happen, right? It's just so much stuff. And, you know, so it's just important to kind of pay attention to even some of those really mild things that you might see on that. This can be potentially life-threatening. So again, if you start seeing those early signs, you can turn down doses, remove agents, whatever is going to work best for you. Benzodiazepines can help, but I'm not going to suggest that in this population if we don't have to, right? And then there's the cyproheptadine for the severe cases of serotonin syndrome. Serotonin withdrawal, this can be that abrupt discontinuation of the serotonin medication, and this occurs roughly 1 in 5, right? And can occur as quickly as 1 month on a medication. So, you know, it's usually pretty mild, and it occurs within a few days and after stopping the medication, and can last, you know, for a few days or even a week, maybe even 2, just depending again on the dose they've been on, the amount of time they've been on it. And then if you reinitiate, symptoms usually go away within a few days. But medications with a longer half-life, such as fluoxetine, will have fewer incidents of the serotonin withdrawal because the half-life is so long that it tapers itself, right? The shorter half-life, more common, like in venlafaxine, everybody like, you know, I miss venlafaxine by an hour and I'm having symptoms, you know, it's like brain zaps and turn my head and I'm dizzy. And, you know, so some of these can be much more intense and severe. But again, you know, just be mindful of this. And, you know, one thing I want to say about this too is sometimes I'll hear, you know, someone's been on a medication for a while and they're like, well, I was feeling good. I just stopped taking it. And then my anxiety got so bad. Or they'll say, oh, I quit taking it and all I did was cry, right? So I know I need it, right? Well, I don't know. That might not always be necessarily accurate, because it could be secondary to withdrawal, right? That your withdrawal and then you get this anxiousness. And then, you know, if they would wait it out, then that might go away. Same thing with that tearfulness, that sometimes you can see that too. So just something to kind of keep in mind, because you will see this population oftentimes stopping their meds. You know, it's a pretty common thing. So some pearls, right? The younger kids have that faster hepatic and renal metabolism and excretion, which may lead to needing increased dose or split day dosing. Younger children, though, will be more sensitive to these SSRIs than an adolescent, statistically speaking, more side effects. Again, there's usually less adherence to the medication in this population. They don't want to be different. They don't want to be on a med or something like that. Each visit always provide medication education, assess where they are, what the need is moving forward, providing supportive management, input from parents or siblings, whoever's coming with them, and always do your safety evaluation. Remember that medication and therapy show earlier remission. So it's interesting because the studies do show that therapy and the use of antidepressant fare about the same. And yeah, they fare about the same. But when you put them together, they fare better than either one alone. So I think therapy is a really important thing that I don't want to miss out on. Now, the recommendation is 6 to 12 months post the acute phase to think about discontinuing the medication. And, again, why are they on this medication? How long has this persisted? And is it reasonable to go off that soon? There's also evidence saying that maybe we don't need to be on these as long as we think we do. So it's kind of a mixed bag. But what I, usually think if somebody's doing good, every time you see them, they're doing good, that's where you're evaluating. How are you doing on your meds? You're still finding them effective. You've been on this dose for a while. We haven't touched it. Do you want to go down and just see what that looks like? And again, if they've been on it a while, take them down a dose and see what happens, and usually, like if you're on sertraline 100 and they want to go to 75 or something, sit at 75 for a while. What does that look like? And as they regulate at that 75, is that still appropriate, And then after a while on the 75, you can go, what does it look like on 50, right? And then there's no harm in going, oh, okay, that didn't work. We'll go back to 75, and sitting there. But it's, again, we don't want to go too low, but we want it to be effective, right? But at the same time, everyone's different and we need to kind of meet people where they are and also be, vigilant. If you don't need to be on something, we don't want you on something, right? And this is, again, why therapy can be helpful, because if you can get the symptoms in place and they're in therapy, then it's going to be easier to pull it out as they're learning new skills and they're becoming more confident and resilient. Non-pharmacological interventions, I guess I could have just done a whole talk on this, so I just kind of pulled out a few. So I apologize for all the ones I didn't put on here, but magnesium, right? This is involved in the production of serotonin. Magnesium also helps with the brain biochemistry, which can impact the development of things like depression. Magnesium glycinate or taurate, those are the ones I often recommend because they're paired with that amino acid, which makes them more easily absorbed, better tolerated. Magnesium can help reduce stress, improve anxiety, improve sleep quality. There's quite a few benefits of magnesium intervention. L-theanine, I put that on there. It's pretty passive in a way, right? Sometimes it's helpful, sometimes it's not. I usually use doses of around 200. L-theanine helps with the production of GABA and has a calming effect. It acts like an adaptogen, kind of helping in different areas. If you pair it with something like melatonin at bedtime, it can kind of potentiate that and kind of help get into that relaxed state, letting the melatonin work more evenly. But pairing it, say, in the morning with caffeine will enhance the effect of the caffeine. Not like doubling the milligrams, but enhancing that cognitive effect. So, you've seen some of these supplements that maybe have L-theanine and caffeine in it because they're just trying to kind of, oh, it's focus, or whatever. But there is some good evidence about the the improvement in that whole GABA process with this. And then ashwagandha, this is something that, sometimes you don't really think about for kids, but it could be an option nonetheless, especially a teenager, because it has evidence to support the reduction of cortisol levels. I mean, this is evidence-based science here, right? This does do that. It has been known to help regulate certain hormones. That's why you kind of need to be mindful if someone's on an oral diabetic agent. This literally, depending on dosing, can have that kind of an effect. You can divide the doses or not. Usually in an adult, I would start at 600. That's usually the dose I recommend is 600 because I think that's where you're going to start seeing the effect. But maybe in this child adolescent population, you'd maybe start somewhere 300 if you want, right? And kind of move it to 600 just for tolerability and make sure that works good. But if you shoot too low, they're going to take it and they're not really going to see as much of the benefit. Remember, you're not these supplements, you're not taking just kind of like, oh, I'm just going to take that and feel better. It's like if you start these because you're already experiencing something, right? Then you should probably be taking a dose that's more appropriate than a little starter dose. That's kind of my thought on that. All right, so safety first. I always say that because, with anxiety and, adolescents, their brain's not fully developed. There's a lot more impulsivity. And I've seen this before where there's so much anxiety that you do worry about safety because they can't continue to feel like this. And it's really crippling and very distressing. So always safety first, safety first, safety first. But okay, so how do we assess this medical screening, right? Well, labs such as your CBC, your CMP, those kind of basic, your thyroid panel, right? Is this a hyperthyroid situation, which I actually have seen before, being a cause of intense anxiety. Vitamin D levels, ferritin, iron levels. Again, we have low iron. We're going to feel more anxious, right? Because your heart's going to beat faster to kind of get that oxygen moving. Medical screening should include nutritional screening. Okay, what are you eating and what are you not eating? Okay, remember every single cell and neuron in your body requires a vitamin mineral. So micronutrients are very, very important. So getting that wide variety of diet is very important. It's not going to be an instant fix for most people, but adding it in over time is going to help keep them regulated. What are they eating, like caffeine, all these energy drinks, sugar, sweets, even things like dyes and different ingredients can also elicit some anxiety, gluten sensitivity, and intolerance. So checking for those whole system reviews is going to be really, really important when you're making an anxiety diagnosis. Family history, what is it? They have anxiety, mood disorder, depression, other psychiatric illnesses. And if so, what worked and what didn't work? That's the other thing that's going to be very important. And also that family history of suicidality. Stressors, this is so common for anxiety in child adolescent population. There's so many stressors in the world already. But, if you're being bullied, if you have changes in your family structure, friendship issues, school failures, school difficulties, abuse, neglect, exposure to violence, traumatic events, it's kind of like this. If, you're being bullied at school and you go home and it's a very stressful home environment, yes, I can medicate that to some degree, right? But I can't remove those stressors. And so my treatment is going to be limited. And this is where the importance of therapy, I think, comes in too, because we have to find a way to also help build resilience. Not that it's okay to be bullied and, or be abused. Those things need to change, right? But it's just important to kind of build resilience because this world is full of stress. This isn't going to change. We have to find a way to adapt to it. And other psychiatric illnesses. What else is going on, right? So depression, mood disorders are common comorbid conditions with anxiety. So for instance, major depressive disorder, sometimes they say that's just, it's not the exception, it's the rule, right? These kind of go hand in hand. And statistically speaking, about half the people, as low as 25, will also have a depressive disorder. Again, if you have this chronic anxiety, this is going to beat you down. And yes, your mood is going to be affected because you can't function in your day-to-day life appropriately. That's definitely going to have an effect on your mood. Other anxiety disorders, this is probably very, very common. So generalized anxiety with agoraphobia, generalized anxiety with panic, that's really common. Generalized anxiety with social anxiety. So about 75% of the times those will go together. ADHD runs up to 50%. People with anxiety also have ADHD. Up to 50%. I saw some things as low as in the 20s and then stuff going all the way up to the 50s. So people who have trauma or stress disorders in particular, 70 to 80% of those people are going to have some type of an anxiety disorder. Substance use disorders, they're looking at up to 45% of the people will have anxiety as well. Depression beats out anxiety a little bit, or a mood disorder beats out anxiety a little bit, but it's up there. And then obsessive and compulsive disorders, right? This is OCD, but it's also trichotillomania, skin picking. So those obsessive compulsive disorders, there's up to an 80% of those people that will carry an anxiety disorder as well. All right, we're moving along here. All right, so I'm going to talk about Benny. Benny was diagnosed with autism in childhood. Benny was always an anxious child, had a tendency to perseverate, and he's been in therapy since childhood. And this helped significantly over the years. Been all sorts of therapy, AAB therapy, ABA therapy, that kind of stuff. However, since high school, he's wanted more social interactions, and he's socially awkward and tends to say things that often defy social norms. This has caused trouble at school. He almost got suspended for telling a girl that her breasts were too large for the shirt she was wearing. Right? And since this time, he just kind of decompensated. Social anxiety has been present because he's fearful of saying the wrong thing and getting in trouble, anxious about what others are saying about him or telling on him for things he's doing that he's unaware that he's doing. And so perseverating more, and for days, he'll talk about something that's coming up, making anxious statements. And his therapist thought he needed to talk to psychiatry as the therapeutic benefits were becoming limited at this point. So he comes in, and we did start some sertraline for this anxiety and this obsessive thinking pattern. And he tolerated this pretty well. And we did end up going up to 100 at one point. He did well for some time after that. He had social situations, such as speaking in front of the class or attending prom, that brought significant anxiety leading up to it. He was perseverating less, but present with that heightened anxiety. So we added propranolol as needed for that situational anxiety, and this worked really well, actually. And he was able to do social things like attend prom, and he ran for student council in his school and won. However, anxiety did continue to be an issue at times, as was that perseverating. And we did eventually increase that sertraline to 150 milligrams daily with some benefit. During his senior year, he began decompensating again. There were a lot of social pressures. He was also getting ready to graduate, so now his routine, his life was changing. And he felt a lot of pressure about graduating and going to college, or getting a job. Where am I going to work? How am I going to manage this? His mother said the perseverating was worse, and he was getting harder to pull out of. His thinking was more rigid, and he would have emotional outbursts. So after discussing some options, we did add a low dose of Abilify at 2 milligrams to help with this problematic thinking and that behavior dysregulation and that kind of anxious, that kept him in that anxious state, right? And this actually worked rather well. He did go on to college. He went to trade school. He did get a trade degree. And he did decide he wanted to lower that sertraline to just 1 tab. He hated taking that 1.5 tab. It always was problematic having that half tab hanging around. And so we did go down to 100 and he stayed on the Abilify and he actually did quite well just with even just that little bit of Abilify. He got a little bit older. He did try to go off that Abilify, but that was unsuccessful. And he just felt himself sliding into that perseverating. It was just really interesting to watch. So he remained on that 100 of sertraline and the 2 of Abilify and did well. So good outcome on him. Then I'm going to talk about Donnie. Now, Donnie's 10. He's not quite that adolescent, but he's moving into it. And I like this case for a number of reasons, so I decided to talk about it. He has a history of ADHD, anxiety, and a history of poor sleep since infancy. This kid was just wired, you know, as an infant. And when I first met him, his energy like filled the room, you know. This kid was all over the place, a lot of energy. And you know, he leaves and you're like, whoa, that was a lot of energy in my space. Now, he was polite. He didn't, you know, talk over people or interrupt him. He was very polite and well behaved. He was just really revved. His energy was just really high. So, you know, something to say here is that poor sleep can be common in ADHD, as well as mood disorders and anxiety, trauma. And if we're not sleeping, it's kind of hard to regulate everything else. Sleep is our reset. So given this poor sleep, this high energy, which could be in part anxiety and a part ADHD, we decided to kind of start with this clonidine at bedtime to see if we could, you know, get in some of that anxiety, but get him to kind of sleep a little bit better. And he actually did rather well on just this one small dose, and he was sleeping much better. His energy was much more contained. It was the most bizarre phenomenon I've ever seen. He just comes in the office the next time, he's very like calm with his body. Again, maybe he's getting used to me, and maybe that first initial visit there was a lot of anxiety, but the presentation was really different. But still with some anxiety, but mom said that his anxiety seemed to be less at that time as well. Well, there were some family changes that occurred. There was a disruption in the family structure. His older sister was struggling, dad was struggling, mom was stable and was very attentive to his needs. Okay, she, you know, she would hold him, talk to him, try to kind of get him to calm down. She was just really, really patient with him, but he was clinging more. He'd worry about things he shouldn't worry about, like she's in the bath and he's worried she's going to drown, or he didn't want anyone to open the door because he's worried that the dog was going to run out and get hit by a car. And so, you know, he was near panic at a few times. She spent a lot of time trying to calm him, but it just wasn't as helpful. Now, you know, there's several reasons anxiety would be present in this child, right? There's a lot of life events going on around him, you know, and this anxiety is kind of taking up a life of its own. Again, that kind of limbic prefrontal cortex dysregulation, generalizing the threat. And therapy was suggested and initiated, but he was struggling in the day-to-day. So mom reports that sister had similar issues, went on sertraline, and it was helpful. And she wanted to try this. We did discuss the risk of activation, the risk of bipolar disorder, the risk of being on the stimulant, the hyperfocus of anxiety. And the kid was already a lot of energy underneath all this. And so the likelihood of activation seemed high to me. She did want to try this before an atypical, such as a low dose Abilify. And we added very low dose sertraline. to see how he would do. And after about a month, Mom said he was less anxious. She felt she could help him turn it around. Therapy was starting to be helpful, and we kept it at a low dose. After the second month, Mom said things at home are still chaotic. Dad was not in the home anymore, and she felt since that time his worried thoughts were increasing. She was able to pull him back, but it was taking more effort and it wasn't lasting as long, and so he was just more tearful, more sensitive to what people were saying to him. So we decided to increase that sertraline cautiously because, again, what are we starting to see? Is this an activation or not? But after another month or two, Mom said he was much better and able to pull himself out at times. She was needing to help him less turn it around, right? He was letting things go a little bit easier and he wasn't quite as sensitive to these critiques that he was hearing. And he did kind of rather well between the SSRI and the therapy. So a couple things about this case. One, as you notice, he didn't need high doses of medication. I mean, low dose Adderall, low dose clonidine, low dose sertraline. I mean, could we have increased doses of each without causing a polypharmacy? Maybe, maybe not. But as you see, we're also going for that alpha-2 calming of that hypervigilance. He's a small guy, weight-based dosing anyway. We couldn't have gone much higher at that age. But he didn't need much. Sertraline did, we did a slow taper due to that genetic risk factor, as well as this presentation. We did not do a rapid taper, and we didn't want to cause any activation, right? And we took what I call baby steps or half steps, right, along the way. And that's okay sometimes. It's just about knowing the situation, the history, and the risk. Now, I only got to see this kid for a couple of years because he relocated out of the area. But when he was around 12 years old, he did taper off of his SSRI. Donnie said he didn't think he needed it anymore, that he had really learned some good coping skills, and he was very introspective. It was kind of just an amazing thing to see this growth and development. And he felt like he had good enough skills. His mom did get him actually in martial arts, which he loved. And she felt it really taught him that self-control and that self-awareness. Family situation remained with father out of the home, but the father was more stable as well, so that probably helped, as was the sister. And we did eventually change his stimulant to long-acting and increase that clonidine over time, but those were the two medications that he left on, and we were able to stabilize him.
Thank you, Joanna. That was great. Thank you for presenting the case studies at the end.
Yes. Glad I had time this time.
Yes, great. Thank you. We will move to the Q&A portion now because we do have a handful of questions in the chat. Best go-to medications for sleep in adolescents with anxiety if OTC, over-the-counter supplements therapy, is not helping.
Right. I mean, I know I didn't put it on there. I know people use hydroxyzine. There were so many meds I could list, and I just kind of cherry picked them. So I know some people do the hydroxyzine, but remember, it's not doing anything for the brain. So again, monitoring the risk factors and what exactly you're treating. Could you do something like a low dose quetiapine or something? You could do a low dose trazodone. I don't tend to run to trazodone too readily. Work on sleep hygiene. That's also very important because regulating those sleep patterns is something to kind of get at because a lot of times they're on their phone and all that kind of stuff, right? Could also think, is the other medication activating, right? So is that also an issue? Do you need a dose adjustment there? So I guess I don't have a go-to as much as it depends on the situation. Sorry.
For patients diagnosed with ADHD using stimulant medication, what medications do you recommend for continuing emotional dysregulation or anxiety?
Someone with ADHD with anxiety, is that what you said?
For patients diagnosed with ADHD using stimulant medication, what medications do you recommend for continuing emotional dysregulation or anxiety?
Right. Yeah, I mean, that's something to remember. Where is it coming from? And so sometimes if there is this ADHD and you can move into something like a clonidine that might be helpful, right? Because it might help calm that, doing the long acting might help calm that nervous system. That's one thing. I mean, you could move to an SSRI as well if you could try a low dose Lexapro. That's another option. For calming, I mean, you could even, again, magnesium, L-theanine would be maybe a couple of options too, right? And was that helpful? Did that answer it? I don't know.
Yes. Thank you. For clonidine at bedtime, do you prefer the ER formulation or standard?
Yeah, right. I just do it at night. That's what I do. And I do, again, if you're using it to treat an ADHD co-occurring, then the long acting might be helpful because I think there is still a little bit of sedation that can happen with that initially. But if you want to add clonidine to bedtime to kind of settle down that nervous system, again, especially if there's trauma history or something like that, you could do more of that regular release. Again, depending on the person, what the comorbidities and the cause of the anxiety is, right?
And then last, couple more questions. Any advice or guidance on resources for safe taper or weaning down resources?
Yeah, that's tricky. The basic guideline is 50% every 3 days, which is way too fast, if you ask me. But so yeah, again, I think it's okay to so it depends too on how fast someone wants to go off of it. Because if they want to go off fast, you could say, okay, 50% every 3 days, but until you're off of it or whatever. But I'm more of a step process, like, okay, you want to kind of go off of this. Well, you can take the sertraline 100 and take it to 50, right? And then just say, then be back with me and we'll see how you're doing on the 50. And then we can, then go down to the 25 and then stop after so many days and then have them return, after they've been off of it for a few weeks so that they know how they're feeling without it. So I usually do a step, and you can do, 100 to 50 if this is them wanting to come off of it, right? The fastest way I would recommend is 50% every 3 days, but that I don't really suggest that to people, I just say, well, we can do it this way if you want to be off right away, or you can always stop taking it and go through the side effects and deal with that. It depends on how quick they want off, why they want off, and so I don't know, there's not really any great guidelines for that.
Yeah, it looks like someone in the chat did post Dr. Greenblatt also has a book of antidepressant withdrawal. So kind of answering a resource that's out there.
Mm-hmm.
And then another question, which form of magnesium?
Glycinate or taurate. Those are the two that I recommend just because they're paired with that amino acid.
Any other questions for Joanna? I'm looking here. Looks like we're done with that. Any final questions while we still have Joanna's expertise on the line? Well, thank you so much for doing this topic. We always appreciate that you're able to share your expertise on the adolescent population.
Oh, yeah.
And so much needed. And I know everyone appreciates that we have a topic on this. We try to every year. So thank you so much for your time. And we appreciate you being here today.
All right.
That concludes our conference. As you can see in the chat, I just posted the link to the evaluation. That evaluation will allow you to claim your credits for the day. I do want to note that if you are a non-Essentia employee, you will have to essentially create an account and then go back in to retrieve your credits. So I did post instructions within the chat on how to do that as well. That's the second post for instructions for non-Essentia employees. I will also be sending the instructions for claiming credits via email with everything you'd need to know for today. And again, the recording will be sent of the entire conference within about 2 weeks to any registered participants. Thank you for your attendance today. I am gonna keep this open for at least another 10 minutes or so, just again, for those of you claiming those credits that you can get the link and get the instructions. Thank you again for your attendance. We appreciate everyone's support of this conference every year. Thank you to the Essentia Health Foundation for supporting the conference this year, and thank you to all our speakers. Have a good weekend.